This
Indication to
conference will now be recorded.
this if the patient has contraindication to CTPA, a patient should go for VQ scan and probably compression ultrasound of the legs. If the investigation is going to take more than 4 hours, this patient should be started immediately on anticoagulation. Remember, patient with low cardiopulmonary reserve and even with chronic kidney failure and estimated GFR just 30 or above 30 should not be denied CTPA. And in many centers, even if the estimated GFR is below 30, patient will not be denied CTPA because the risk to die from PE is more higher than the harm from CTPA and contrast nephropathy. Patient with intermediate risk PE should have inpatient bedside transthoracic echo to look at McWinnell sign, which is a sign of strain in the right side of the heart. Because once this diagnosed, patient will not be discharged from the hospital as before and receive the anticoagulation at home. Patient will be staying in the hospital to make sure that the PE has been treated effectively and a plan for the duration of anticoagulation as an outpatient in place, and also a follow-up with this patient with the least will be a transthoracic echo to make sure that this patient did not develop thromboembolic pulmonary hypertension, which is again a major and incapacitating complication of pulmonary embolism. The low-risk patient is the patient who came with they came with the symptoms and sign which raise the concern of PE, and patient have a Wells score more than 4. This patient should also go for CTPA immediately, and if there is contraindication to CTPA, we should go for the normal pathway, as I mentioned before. This including the VQ scan and the compression CT of the lower limbs. Again, the cardiac biomarkers are part of the standard of care for the investigation, even with low-risk pulmonary embolism. If the Wells score is less than 2, a patient will be screened for pulmonary embolism rule-out criteria, which are 6 questions. Which are 6 questions here. And if the pulmonary embolism rule out criteria had been performed, this patient can be safely go home with no further investigation or medication, and another cause for his symptoms should be worked out. Uh, so I have covered now. Uh, I have covered now the high risk pulmonary embolism and the intermediate risk and a low risk. I want to spend 1 or 2 minutes here that now in the recent guidelines, we have a pulmonary embolism response team, who is a team encompassed of ED skilled in pulmonary embolism and a cardiologist with experience in pulmonary embolism, and the anesthetist also uh, uh, skilled in how to deal with the complication of pulmonary embolism, because actually uh, if the patient decompensate, uh, this patient usually need to be treated by ECMO in addition to mechanical ventilation rather than pressure ventilation. Uh, Patient who decompensate and uh, did not respond to anticoagulation should immediately start on thrombolytics. In the meantime, patient will be supported by inotropes. If the thrombolytics did not work, what is left if the catheter directed thrombolytics, where the patient will be treated with direct thrombolytics through a catheter, and they can use uh, here a direct catheter, or if the experience is not available, patient might need urgent surgical embolectomy. While the patient on the thrombolytics, inferior vena cava should be deployed uh, because of the chance of thromboembolization. Uh, so now uh, I want to uh, just highlight that the unprovoked PE now is treated with indefinite anticoagulation, but after 6 months, the anticoagulation can step down to low intensity anticoagulation. The provoked PE will be treated with 3 months with NOAC, with probable extension to 6 months if the patient has a high clot burden or dysfunction of the right ventricle or significant positive cardiac biomarker. Of note, NOAC can cause bleed in the tummy, and we prefer patient who has a gastric cancer and needs to be treated with NOAC, not to have the NOAC, but to be treated with low molecular weight heparin or Clexane to avoid gastric bleeding from the NOAC. And as I mentioned, the antiphospholipid will be treated with the vitamin K antagonist. And while we are following up patient on NOAC, Patient should be assessed for the risk of bleeding. The important contraindication to anticoagulation is the active bleeding or brain metastasis, or patient who has a bleeding disorder, or patient who has a recent surgery. And in this situation, the ceiling of management will be inferior vena cava filter. Patient who develop thrombosis due to heparin, which we call heparin-induced thrombocytopenia, usually will not be treated by heparin or clexane again, but they will be treated by heparinoid, and later on can be treated with warfarin. Let me spend 2 minutes on the distal deep vein thrombosis. Usually, it is in the posterior tibial and peroneal vein with the sparing of the popliteal vein. The distal DVT usually does not need any anticoagulation except if the clot is close to a proximal vein, or if the patient has unprovoked DVT, or the patient has coincident COVID infection, or he has a significant high D dimer. Patients who are not in the high risk group should not be offered any medication, but they probably could have serial ultrasound to check on the status of the clot on the distal vein. The upper extremity DVT is an important entity because we start to use the chemotherapy and the central catheter frequently, and patients not uncommonly develop deep vein thrombosis in the arm, mainly the axillary or the cephalic veins. The compression ultrasound will diagnose the clot, but most important because this type of clot usually affect young athletes and has a tendency to cause compression syndrome. Patient should have CTA or CT angio and MRI to confirm the diagnosis and exclude thoracic outlet syndrome. And you don't need to remove the PICC line, but patient can continue to be treated through the PICC line with the anticoagulation. Most important, the vascular service should be involved here to prevent persistent thoracic outlet syndrome and severe post-thrombotic syndrome. The benefit of treating the DVT in upper extremity outweigh the harm from any extensive procedure. The patient with massive clot either in the upper leg, either in the lower leg or the upper arm, Again, a catheter-directed thrombectomy can be applied, or the thrombus can be aspirated, or the thrombus could be treated with what is called rheolytic thrombectomy, where agitated saline applied to remove the clot, or the clot can be removed surgically. The ECG guideline indicated clearly that the inferior vena cava filter should not be routinely used, and the indication of inferior vena cava filter when you have an absolute contraindication to anticoagulation because of the bleed, or patients who are treated with thrombolytics and have decreased cardiopulmonary reserve and are at risk to have embolization. This is a sort of patient who should have inferior vena cava filter. I am now going to conclude with two interesting patients and to apply the lessons we have learned from application of the new guideline. We have seen a patient a few months ago. She's a 23 years old lady presented with recurrent upper extremity symptoms consistent with DVT in the legs. She noted swelling of the whole leg with pigmentation and leg pain, which increased with exercise and relieved by other rest or elevation of the left leg. There is no family history of venous or arterial clot, and the patient is not on any medication which could provoke clot. Patient has a compression ultrasound which showed a small clot in the left iliocaval vein, and actually the ultrasound was very specific that this is a small sized thrombus, but despite it is a small sized thrombus, it caused swelling of the whole legs and it caused pigmentation of the whole legs. And again, it was recurring 3 or 4 times at least in the last 6 months. Patient was investigated by her treated physician with a vasculitic screen and the inherited thrombophilia screen and the transesophageal echo with agitated saline to exclude any pitted foramen ovale, and all the investigation came back negative. So where to go from here with a young patient with a small clot which cause symptoms and sign consistent with a massive clot, and the clot is recurring. So we done MRI, MRA, which showed that the left common iliac vein was compressed by the right common iliac artery. And this is a syndrome which is well described in the literatures by the name of May-Turner syndrome. This patient was treated with angioplasty and stenting with complete cure of her symptoms and her disease. The second patient is a 40-year-old patient brought to the emergency department with symptoms consistent with clot in the lung in the form of pleuritic chest pain and shortness of breath. The past medical history was completely unremarkable, and there is no family history of clots. And this patient was not on any regular medication, which could be blamed for clot. On examination, the heart rate was 110 sinus, blood pressure was low normal, and oxygen saturation was low, with high oxygen requirement of 3 liters per minute. This patient has an urgent CTPA, which showed bilateral lobar segmental pulmonary embolism with high clot burden. The troponin and the pre-natriuretic peptide were elevated. An urgent bedside echocardiogram showed evidence of right ventricular strain, and the right ventricle was dilated. The inferior vena cava was not collapsing, and there was protrusion of the interventricular septum to the left with a tricuspid incompetence with a peak velocity more than 3 milli per second, and the right ventricular acceleration time was less than 80 per minute, and the right ventricular wall motion abnormality was very obvious with hypokinesia, with preservation of the right ventricular apex. The right ventricular end-diastolic volume to the left ventricular end-diastolic volume was more than 1, and this is consistent with significant right ventricular strain. Patient was diagnosed with intermediate risk of pulmonary embolism, and this patient is at risk to decompensate at any time. So patient was admitted to the intensive care unit and was started on unfractionated heparin. Patient improved with treatment. Unfractionated heparin changed to low molecular weight heparin, and patient was transferred to the ward for more observation. Patient improved and was started on apixaban 5 milligram twice daily for 3 months, and to be arranged to be seen again in the thrombosis clinic to look at the complication of the pulmonary embolism and to make sure that the strain in the right side of the heart had recovered, and to make sure that the patient did not develop chronic thromboembolic pulmonary hypertension. Patient went home, patient before discharge, he was about on the way home, he developed slurred speech and right-sided hemiparesis. Urgent non-contrast CT scan done was normal. And the question now, what you are going to do next? Patient has been diagnosed with intermediate risk pulmonary embolism which responded very well to anticoagulation. Patient improved, and on the way to go home, he developed a stroke. If this is a separate issue, or we are dealing with one disease. Uh, so the patient has an urgent diffuse weight imaging MRI, which shows a stroke in the left middle cerebral artery and showed uh, a hemodynamic patent foramen ovale. Transesophageal echo was arranged with agitated saline, and it showed a significant hemodynamic uh, shunt from the right side of the heart to the left side, causing paradoxical impulse and causing the stroke. Uh, this patient was treated with anticoagulation, and the patent foramen ovale was closed, and patient continued on anticoagulation for 6 months.
Hello, Dr. Adil. May I know how many slides are there because we have few more talks today.
Yeah. So I'm happy to stop there and receive any questions.
No, you can continue. Can you please
Can I
be
continue?
quick? That's it.
Okay.
We are
Yeah.
asking.
Yeah. No. Yeah.
Okay, you
Just the
can
patient
continue,
has,
but please quick.
yeah. Okay. So the patient
Okay, you can
has a
continue.
stroke, and the stroke has been treated, uh, and the patent foramen ovale had been closed. So in short, the patient has PE, PE complicated by pulmonary hypertension, and the patient, because have a patent foramen ovale, and the pressure on the right side of the heart was high. So this lead to shunting, and the shunting caused paradoxical impulse. So we've been dealing with one disease and not two diseases. So to conclude, pulmonary embolism and DVT are a major uh, clinical issue, and we have now a clear cut and a crystal clear guideline to make sure that we stratify the degree of pulmonary embolism. We treat pulmonary embolism in the hospital, even moderate risk, because they are at risk to deteriorate, and only we discharge patient with very low risk after we roll out all the possibility of ongoing pulmonary embolism or complication of pulmonary embolism. At the end, I want to acknowledge my co-author here and uh, Pity, who is a PhD, and my registrar, who helped me on providing the slides in a short notice. I'm happy to stop here and receive any questions.
Thank you, Dr. Adil, for your presence and presentation. Does anyone having any queries? You can unmute yourself and ask your queries.
Any questions?
I hope there are no queries.
Okay.
Once
Thank you
again,
very
thank you,
much.
Dr. Adil, for
Thank you very much
presence
for
and presence.
attention.
Uh,
Thank you a lot. Thanks.
Thank you. Thank
Thank
you.
you.
Thank you.
Cheers. Thanks.
Now we'll move on to the next presentation. The next presenter is Dr. Hong Xiang Chen from Chongqing University, China. Hello, Dr. Hong. Are you ready with your presentation?
We didn't put the
Yes, I'm
right.
ready.
The,
Yeah,
no,
now
the
I'm
mic,
making
mic,
you as the
madam. Thank you.
presenter. Kindly click on the screen button to share your screen.
Okay.
Now you are the presenter.
Uh,
Hello, Dr. Hong.
I'm sorry, give me some
We have
minutes
made you as a
to set
presenter.
up the system.
Do you got any pop-up window on your screen?
Yeah, I have to set up the system. I cannot share the screen.
Please open GoToMeetings app and click on the screen button.
Yes, that's my system has some issue to share the screen.
Or can you share your presentation to the program manager so that we can share from our end? You can just give the presentation by seeing the presentation from your laptop then. Hello, Dr. Hung. Can you please share your presentation to the program manager?
Excuse me, Clara, are you here?
Hello, Dr. Hung. Yeah, you're
Can you
audible.
can you help to let the next one to go ahead to do the presentation? I will do the presentation after her.
Okay, okay, we'll move on to the next presentation then.
Okay.
Okay, the next presenter is Dr. Huang Yu from Shandong First Medical University, China. Hello, Dr. Huang, you are ready with the presentation.
Okay, but
Okay, Doctor, now
Mr.
I make you as a
Microgram, should
presenter.
you? Yes.
Yeah,
Okay.
I have made you as a presenter. Kindly click on the screen button to share your screen.
Okay. Yes.
Yeah, your screen
Can
is
you see?
on. Yeah, you can start your presentation now.
Okay. Dear President of the conference, dear Senate Peter, and dear professors and fellows here, good morning. Thanks for the invitation from the Congress. It's my pleasure to share a rare case in my hospital. The title of the case is Extramural NKT leukemia, lymphoma leukemia with central nervous system involvement as the initial presentation. Let's see. It was a patient, male, 43 years old. His chief complaint was had right upper arm pain for more than 1 month and had neurological problems such as binocular vision and limb weakness for 20 days. And he was admitted to a hospital on May 7th this year. And after he had admitted to a hospital, we did routine examinations for him. And the CBC results showed hemoglobin, red blood cells, platelets, and leukocytes were all in normal level. And the liver kidney function indicators, AST, GPT, and GARM-GT, were all in normal levels. Because he had neurological manifestations, so we did CSF examinations for him. And the results showed that the pressure of CSF increased to 270 mmHg02, and it was slightly turbid and yellowish. Nucleated cells increased to 56 times 10 to power 10 times 10 to 6 power per liter, and the mononuclear cells increased to 53 times 10 to 6 power per liter. Penny test was first grade positive, and biochemistry of CSF showed chlorine decreased and glucose decreased to 0.17 millimole per liter. And protein quantification increased a lot at 4.33 gram liter. And the shedding cytology of CSF showed nucleated cells were easily to be identified, and many were large with high NC ratio, highly irregular nuclear content, and condensed chromatin. Flow cytometry of CSF showed the proportion of NK cells was significantly higher, and the CD45 expression was attenuated. When we did CSF virology, it showed that EBV-DNA quantification was 1.65 times 10 to 6 power copies per milliliter. And this is the cytology of CSF. We can see increased number of abnormal lymphocytes with round and irregular appearance, round body and irregular appearance with round, oval, or sometimes petals-like nucleus, with abundant plasma, and sometimes some of them had red particles inside. Flow cytometry of the CSF showed that this abnormal lymphocyte had a little large SS, and CD45 was expressed dimmer, and CD7 was strongly expressed, but CD3 is negative. CD4 and CD8 is negative in the meanwhile, and this was consistent with NK cells, and NK cell presentation increased a lot in CSF. So, where did these abnormal lymphocytes come from? We did PET-CT examinations for the patient, and the results showed high FDG metabolism were in the right nasal passages, and mild to high FDG metabolism lymph nodes in biliary neck, mediastinum, pericardium, abdominal cavity, retroperitoneum, and pelvic cavity. And we could also see spleen, double kidney, pancreas, and the biliary adrenal glands were in high FDG. Left testes were enlarged with high FDG also, and the vagal region of biliary nerve roots in the cervical and lumbar spine was also in high FDG metabolism. Same situation was also seen in whole body bone. Overall, these results were all consistent with the former manifestations, suggested pathological examination. So we prepared to do pathological examination. However, before we could do pathologist examination, the patient began to experience fever. His temperature rose up to 39.5 centigrade, with poor meditation and feeding difficulties. CBC showed hemoglobin and the red blood cells, platelets, leukocytes decreased dramatically. And we have reported that the CBC of the patient at the time he was admitted to a hospital was normal. But this time, only 10 days later, CBC decreased dramatically, and the serum ferritin increased to 528, and the lipid Tg increased to 5.89 millimole per liter. Coagulation items such as D-dimer increased to 4.11 milligram per liter. Fibrinogen decreased to 1.90 gram per liter, and the thrombin time prolonged to 20.5 seconds. So we did bone marrow biopsies for the patient. In bone marrow smears, we can saw abnormal lymphocytes. They account for 46% and 4% in peripheral blood. So tumor cells were considered. Lymphoma cell leukemia was supposed. And we can also see hemophagocytosis in bone marrow. This was the picture of the bone marrow smears. Abnormal lymphocytes account for above 50%, and they were large and in irregular appearance, with high AC ratio and condensed chromatin, with abundant neoplasms and some particles in plasma, cytoplasma, just as the same we saw in CSF. And we can also see hemophagocytosis in bone marrow. Cytochemistry stain of bone marrow cells showed these abnormal lymphocytes, POX negative, ASDCE negative, alpha NAE partially expressed, and alpha NBE was negative. So we did flow cytometry of the bone marrow cells. The results showed that 36.9% of the cells expressed CD3 and negative for CMPO. And it is also negative for CCD79A and was positive with CD7. CD22 was also negative, and the CD46 and the CD16 is positive also. The overall immunophenotyping findings are consistent with NKT cells. And then we did karyotype examination, found that the patient had complex karyotype. And we did not do molecular biology for the patient because the patient died soon, very soon. So in combination of CSF, bone marrow findings, positive EBV, flow cytometry, whole body PET-CT showing nasal abnormalities, the final diagnosis is positive EBV, extranodal NKT cell lymphoma, nasal type, leukemia state with hemophagocytosis and the central nerve system involvement. Let's have a brief summary of the case. The patient had CNS involvement as initial presentation, has EBV DNA positive, and abnormal lymphocytes in CSF. PET-CT showed high FDG metabolism in many tissues, including nasal part, and the patient appeared high fever during the disease progression, and the CBC of the patient decreased dramatically. At the same time, serum ferritin, Tg, D-dimer increased a lot, and fibrinogen decreased. Bone marrow biopsy showed tumor cells account for 56% and 4% in peripheral blood. We can also find hemophagocytosis in bone marrow. And FCM considered these abnormal lymphocytes were from NKT cell, and the possibility of NKT cell lymphoma leukemia was very high. The disease progressed rapidly, and the patient died in 10-11 days after diagnosis. So let's have a summary. Extranodal NKT cell lymphoma, that is ENKTL, nasal type, classically presents with nucleotizing upper aerodigestive tract lesions in patients of Asian ethnicity. When nervous system symptoms present, central nervous system CNS involvement should be considered. MRI and CSF examination are recommended. Primary CNS involvement is extremely rare. Our current case illustrates this rare phenomenon with ENKTL involving CNS. ENKTL metastasis carries a poor prognosis, and the median OS was only 8.9 months was reported. So that's a case I'd like to share with all of you. Thanks for your attention and Christian guidance. Thank you.
Thank you, doctor, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Once again, thank you, Dr. Huan Ling Hu, for your presence and presentation.
I'm very glad to share this rare case because the patient died very soon, and um, at first it has neurological presentations, and we found abnormal lymphocytes in CSF, and that's a clue of the patient of the disease. But the patient died very soon, so it's a pity. So let's pay attention to this kind of disease, and maybe a diagnosis in the early time, and comprehensive um, therapy are very important. Thank you.
Hello, Dr. Hung, your screen sharing was stopped. Can you please check that?
Yes.
Hello, Dr. Huang Hu. Are you there?
Yeah, I have finished my
Yeah.
presentation. Yeah, thank you.
Okay, does anyone having any queries of the presentation, Dr. Hu given? I hope there are no queries. Once again, thank you, Dr. Hu, for your presence and
Yeah.
presentation. Now we'll move to the next presentation from Dr. Hong Xiang Chen from Chongqing University, China. Hello, Dr. Hong. Are you ready with your presentation?
Yes.
Yeah, now I'm making you as a presenter. Kindly click on the screen button to share your screen.
Why? Still not allowed me to share my screen.
I have made you as a presenter. Please go to the GoToMeetings app.
Why? It's the privacy security issue.
Have you opened the GoToMeetings app?
Yeah, I'm using the GoTo app,
You
but
can please open the GoToMeetings app. Click on the screen button below.
yeah, it said please open the system preference to grant the permission. So I
Okay, if
already
you have
did
any other,
the setup.
have you send the PPT to the program manager?
Okay, I will send it to her. I'm so sorry.
Hello, Dr. Shan. Can you please share your PPT to program manager Simon Peter?
Yeah, I will. I will do it now.
Yeah, please send. We'll be sharing the PPT from our end, then you can give your presentation smoothly.
Okay, okay.
Okay, we'll move on to the next presentation. Meanwhile, hope you're okay with that.
Okay, okay.
Okay, meanwhile, we'll move to the next presentation. The next presentation is from Dr. Jainab Said from University of Huddersfield, United Kingdom. Hello, Doctor Jainab. Are you ready with the presentation?
Yes, I am ready.
Yeah, now I'm making you as a presenter. Kindly click on the screen button to share your screen.
Okay.
Capture your screen. Capture your screen.
I have made you as a presenter.
Okay, I'm sharing now.
Yeah, your screen is shared. Kindly open the PPT and make it as a full screen. Yeah, it is perfect now. You can start your presentation now.
Can you see me? Can you see the presentation? Hello? Hello?
Hi, yes, we can see.
Okay. Good morning or good afternoon. My topic will be regarding the identify the target of antibiotic use for the management of carbapenem resistance Acinetobacter baumannii, which called CRAB, in hospitals. It is multi-center data collection, and I will use the nonlinear time series analysis. So here first,
Sorry for
anti
the disturbance. Hello, Dr. Janab. Sorry for the
yeah,
interruption. Can you please make it as a full screen, please? Can you make it your presentation a full screen mode?
like this. Okay.
No, we are seeing the two slides at a time in detail, actually.
Now,
No, it is the same as of now. Okay, we will be zooming in the session, or you can continue. No problem. Yeah, it's perfect now. You can start.
it is now okay. Okay,
Yeah, it is
so
perfect. You can continue.
yeah, so I will, as we know, the antibiotic are essential medical therapy for treatment of infection, and that will reduce the human morbidity and mortality, but also when we are using as excessive or inappropriate use, that will promote the development of antibiotics resistance. So all of us know that penicillin is first started, discovered 1928, and after that the antibiotic resistance began. The penicillin resistance was detected 1940. As we know as well, the antibiotic resistance happen either by genetic or molecular mechanism related to drug use by prescriber and pathogen. So in 2019, the global burden related to drug-resistant infection was approximately 4.95 million deaths, and there was 1.27 million deaths directly attributable to drug resistance. So next topic will be the antibiotic stewardship. And as we all of us aware about the program of antimicrobial stewardship, and that can optimize the antibiotic use and enhance patient outcome and reduce the antimicrobial resistance, the AMR. So the AMR resurfactance as well, it is essential to the country that will determine the prevalence of infection rate and antibiotic consumption. Therefore, the antimicrobial stewardship team role is significant in reducing bacteria resistance through optimizing antimicrobial therapy. The AMS team need to implement guidelines and that help to prescriber choose the correct antimicrobial therapy. Also, some strategy can start with antimicrobial restriction, point of prevalence survey, and post the prospective audits for the use of antibiotics. Infection prevention and control precaution should also be started by wearing the gown and gloves upon entry to the patient isolation room when the patient care is applied, along with the hand hygiene, environmental cleaning, and infection screening. So my study was doing the time series analysis and the threshold methods. So what is the time series? The time series, it is a tool used for related antibiotic consumption and bacteria resistance by predict or by forecast the future behavior based on the history data behavior. So the threshold is the estimation of the maximum amount of antibiotic use in population over a given period without causing resistance to that antibiotics. So here the study was done on my country, Oman, and the aim was to identify the threshold on antibiotic use below specific antibiotic classes have no measurable impact on the incidence of resistance gram-negative bacteria, and I only include one bacteria, which is carbapenem-resistant Acinetobacter baumannii. So the objective is to collect the monthly data on the incidence of pathogen and antibiotics on the hospital. There was around 6 hospitals involved on this study, and the study was to investigate the relationship between the antibiotic use and incidence of the carbapenem resistance Acinetobacter baumannii using the nonlinear time series analysis. So there was a research gap on this on the Oman. As we know, the prevalence of AMR in Oman, it was equally as reported globally, and the Ministry of Health they launched the Oman Antimicrobial Surveillance System 2017, which is the one component of National Action Plan to prevent antimicrobial resistance. According to that survey, OMAS, the crab was resistant to imipenem and meropenem by 73% and 81% for the patient. So that's why I was choosing to study this organism. The giving AMR condition in Oman hospital, and also there was no study investigate the connection between the antibiotic use and antimicrobial resistance. So I made this research. The study design was multi-center data collection in Oman on 6 hospitals. The study was approved by Ministry of Health and also by the University of Huddersfield. And we used the time series analysis multi-variated adapted regression plan. So we collect data from 6 hospitals and we use only the clinical sample, and the screening swab of for infection controls was not included. We remove the duplicated patient isolate within the 30 days. And also we collect the monthly data of antibiotic use per DDD, and then per 100 occupied bed day. And also it was calculated the alcohol hand base rub each month. So all this data was obtained from the hospital information management system. The result of the study was the average monthly incidence CRAB was high. For example, in Royal Hospital it was 0.030, and on Khawla Hospital it was 0.108. So it was little high than Royal Hospital because it was surgical hospital. And the result of the following hospitals, as you can see it. Second result which was identified is, for example, on Royal Hospital, First Hospital, we found the third generation cephalosporin. The median use of that group of antibiotic was around 4, and the threshold was 5.87. That's mean it is within the normal. We can use it up to 5. Then if we are going to use it above 5.87, it will increase the carbapenem resistance Acinetobacter baumannii incidence rate. So on the second hospital, or Khawla Hospital, we can see that piperacillin tazobactam was used on the hospital by 3.45, and the threshold is 2.99. So mean the use is above the threshold. That's mean the on this case, I will show you in the next slide how gonna reduce or translate this data or this result to inform the antimicrobial stewardship team to reduce the incidence rate of antibiotics. So we can see here on second hospital, piperacillin tazobactam, the maximum used is 44, and the last year average use within the 12 month was 55. And mean here 11 patient we have to reduce the use of antibiotic by 11 occupied bed day, mean by 20% of the use of piperacillin. And we can see only on second and last hospital we have to use by reduce the tazocine by 3%, 27%. That's mean by 3 DDD of tazocine. Here we can see the figures on, for example, let me explain the figures number C. We can see there is a thick black line, and the thick black line is this fitted linear regression line. So you can see it is a trend it is trending to increase. And the thin black line is a fitted linear regression. That means before the threshold, and it is making up. And the dashed black line focus on the X less than threshold, and we can see it is reduced being before the threshold. The breakpoint mean it is the threshold. So after the threshold, like for example aminoglycoside, we can, if we are gonna use it above the 0.847, we will increase the antibiotic resistance for the carbapenem resistance. In this figure, we can see here the third generation cephalosporin on, for example, Royal Hospital. It will decrease, or the the incidence of bacteria, carbapenem resistance Acinetobacter baumannii, is reduced, or it is there is no effect. But if we are gonna use the third generation cephalosporin above 6, it will increase the incidence of bacteria. Second one, the alcohol-based hand rub. We can see here it is used, and we can use the alcohol-based hand rub up to almost 5 liter. Otherwise, it will be no effect after five to reduce the rate of bacteria. This piperacillin tazobactam on another hospital, we can see it. It is trending to make. It is a study when we are using before the threshold, before the 3, and if we are going to use it after 3, it will increase the resistance pattern of Acinetobacter baumannii. Aminoglycoside, can see here, if we are going to use it like 1.9, it will increase, or 0.84, it will increase the percent of incidence of carbapenem resistance Acinetobacter baumannii. So on this discussion, on this study, we saw a nonlinear relationship between the incidence of carb and alcohol hand rub and the population of use of particular antibiotic in 6 hospitals in Oman. The nonlinear analysis enabled generation of a threshold of the thresholds that can be used to guide the antimicrobial stewardship by providing a more reliable estimation of the association between antibiotic use and resistance. Our results support the aerial research findings that have been published, and during the threshold were found between identified antibiotics and carbapenem resistance Acinetobacter baumannii incidence. So each hospital infection control department monitor multi-drug resistance organism, and also they are having carbapenem isolation policy. They have hand hygiene audit and infection control procedure, and also the clinical pharmacist and microbiologist advise on antibiotic selection, dose, and duration for each unique cases. So in conclusion, the need for conducting customized analysis based on modeling data at each hospital is highlighted by identifying different thresholds for variation across hospital on those aspects, and it is possible to define goal for hospital antimicrobial stewardship using the identified threshold. It should be able to maintain prescribing diversity while finding the balance between the antibiotic use and carb incidence by establish the threshold. Thank you for your listening. If there is any question.
Thank you, Dr. Jana, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Once again, thank you, Dr. Jana, for presence and presentation. Hello, Dr.
Thank
Hongjia,
you.
are you ready with the presentation now?
Yes.
Okay, now I'm making you as a presenter. Kindly click on the screen button to share your screen.
It's work.
Yes, your screen is visible now. You can start your presentation again. Hello. Hello, hello, Dr. Chen.
Yes.
Yeah, your
Okay, can
screen
you
is
see my
shared
screen now?
now. You can start. Can you make it as a full screen, please?
Is it working now? Can you see my full screen?
Yeah, it is full screen now. You can start your presentation.
Okay. Hello everyone. My name is Hongxia Chen. I'm from Chongqing University Three Gorges Hospital. So today I will talk about the PR2 phosphatase enhances oncogenic phase 3 and KIT signaling while dephosphorylation of the E3 ubiquitin ligase at tyrosine 371. There are 7 contents in my presentation. Firstly is the background. Acute myeloid leukemia is characterized by the malignant transformation of myelocells from myeloblasts to a pathological cell clone. Within the United States, incidence of AML ranges from 3 to 5 cases per 10,000 population. 70% patients of 65 years or older will die of their disease within 1 year of diagnosis. The 5-year overall survival rate of AML around 29.5% in adults. Based on this bad prognosis, we need to find new therapy methods. As you know, there are 4 advances of the molecular target therapy. So our research purpose is to find the new molecular therapy targets to improve the prognosis of AML. That's PIL2, which is belong to the phosphatase of regenerating liver family, sharing more than 75% amino acid sequence identity. PRLs have been implicated in cancer metastasis, invasion, and progression, having oncogenic potential. Overexpression of PIL2 correlates with breast cancer formation and progression. PIL phosphatases are potential molecular targets in cancer. There are some studies found that PIL2 is overexpressed in pediatric acute myeloid leukemia, and its overexpression increases the cell cycle progression and enhances BML1 expression in hematopoietic cells. Our previous lab member Michi, he found that PIL2 is highly expressed in HSPCs. It decreased the proliferation, maintenance, and self-renewal. And he also found that PIL2 knockout showed decreased AKT and ERK phosphorylation. Based on all the preliminary data, our hypothesis is inhibition of PIL2 activity improves leukemia treatment through decreasing LIC maintenance and inhibiting the activation of downstream signaling pathways involved in LIC self-renewal and survival. By analyzing the TCGA data, we found that PIL2 expression is higher in intermediate and poor risk AML compared to the favorable risk AML. Its expression is also higher in dead AML patients compared to AML patients that are alive. PIL2 levels are higher in patients with cytogenetic and central nervous system relapse. We also found that PIL2 expression have reduced the overall survival in all AML, especially the patients bearing poor cytogenetic risk. This picture showing that the active signaling plays the majority role of the mechanism of AML, especially the FIL3 and KIT signaling, which we are very interested. So by analyzing the AML-seq data from TCGA, we defined PIL2 expression above median as high PIL2 expression group and below median as low PIL2 expression group. There are 7,900 genes upregulated and 948 genes downregulated in AML patients with high PIL2 expression. GSEA revealed that AML prognosis, LSC, and HSC gene signatures are enriched in AML patients with high PIL2 expression. Pathways associated with FIL3 and KIT, as well as its downstream factors, including STAT5, PI3K-AKT, and ERK, are enriched in PIL2 high group. We then employed the DGSE analyzers to group potential PIL2 target genes into specific pathways important for murine HSPC. So we found that in long-term HSC, receptor tyrosine kinase signaling, PI3K-AKT signaling, and ERK signaling gene signatures were significantly downregulated in PIL2 knockout fetal liver cells. receptor regulator activity, receptor complex, positive regulation of receptor tyrosine kinase signaling, and positive regulation of ERK signaling gene signatures were significantly downregulated in PR2 knockout fetal liver cells. Loss of PR2 significantly decreased AKT STAT5 and ERK phosphorylation in fetal liver cells and bone marrow lineage negative cells. Based on all the data above, we next focus on the role of PR2 in FIL3 signaling. AML patients with FIL3 mutation have higher PR2 expression compared to AML patients with negative FIL3 mutation. FIL3 mutation positive AML patients with high PR2 expression have reduced overall survival compared to patients with low PR2 expression. Taken together, this clinical data suggests that high PR2 expression may be a prognostic marker in FIL3 mutated AML. Next, we generate the sixth group of mice by using the FIL3 HADS, PR2 HADS female, and FIL3 IDD HADS, PR2 HADS male. Then we did the mature cells HSC, HSPC analysis, competitive transplantation, whole bone marrow transplantation. We found that the homozygous FIL3 IDD mice have increased the number of long-term HSCs, MPPs, and LSKs in their bone marrow. Loss of PR2 brought numbers of hematopoietic stem and progenitor cells back to wild-type levels. PR2 deficiency has modest impact on the short-term HSCs in FIL3 IDD background. Then we did the competitive transplantation and found the PR2 significantly decreases the engraftment of FIL3 IDD HADS bone marrow cells in primary and secondary recipient mice. Both FIL3 IDD HADS and FIL3 homozygous IDD mice developed to MPN with monocytic features. FIL3 IDD HADS and FIL3 IDD homozygous mice displayed dose-dependent development of progressive splenomegaly, whereas loss of PR2 significantly reduced the splenomegaly seen in FIL3 IDD HADS and FIL3 IDD homozygous mice, while there are increased number of LSKs in the spleen of FIL3 IDD HADS and FIL3 homozygous IDD mice. Loss of PR2 mitigated the effects. From the whole bone marrow transplantation experiments, we found that all recipient mice repopulated with FIL3 homozygous IDD bone marrow cells developed to MPN and died within 60 weeks after transplantation. However, loss of PR2 significantly extended the survival of FIL3 homozygous IDD mice, with 50% of mice still alive at 73 weeks following the transplantation. PR2 efficiency rescued anemia seen in the recipient mice repopulated with FIL3 homozygous IDD bone marrow cells, manifested by increased RBC counts and HGB levels in PB. Loss of PR2 rescued myeloid expansion seen in PB in FIL3 homozygous IDD mice. Recipient mice repopulated with FIL3 IDD HADS and FIL3 homozygous IDD bone marrow cells developed to MPN, manifested by the splenomegaly and infiltration of maturing myeloid hypoplasia in bone marrow, spleen, and liver, as well as accumulation of myeloblast cells in PB. However, these abnormalities were significantly reduced in FIL3 IDD HADS PR2 knockout and FIL3 IDD homozygous PR2 knockout mice. Recipient mice repopulated with FIL3 homozygous IDD bone marrow cells displayed splenomegaly, whereas loss of PR2 significantly reduced the splenomegaly seen in the FIL3 homozygous IDD mice. Next, we want to know how PR2 work on the FIL3 IDD leukemia cells. We did some experiments in vitro and vivo. We found that loss of PR2 significantly extended the survival of recipient mice transplanted with MV411 cells. Genetic inhibition of PR2 decreases the engraftment of MV411 cells in PB, bone marrow, and spleen of the recipient mice. Knockdown of PR2 decreases the phospho-FIL3 expression, AKT, ERK, and STAT5 phosphorylation in MV411 cells. We found that decreased phosphorylation of AKT, STAT5, and ERK in MV411 cells expressing SHPR2 isolated from anastomized at 4 weeks following the transplantation. Several images of luminescence showed that PIL inhibitor treatment dramatically decreased the leukemia burden compared with the control group. The radiance of the anastomized was significantly reduced after exposure to PIL inhibitor. Further, PIL inhibitor extended the survival of anastomized transplanted with human leukemia cells. The treatment also decreased the engraftment of human leukemia cells in PB, bone marrow, and spleen of anastomized. The treatment also decreases the phospho-F3 expression, AKT, ERK, and STAT5 phosphorylation in AMOE411 cells. Decreased phosphorylation of AKT, STAT5, and ERK in AMOE411 cells isolated from anastomized treated with PII at 4 weeks following the transplantation. Next, we found that the treatment decreased the proliferation of primary human AML cells in vitro in a dose-dependent manner. The treatment also decreased the colony formation of primary human AML cells with or without the FLT3 mutations, and also arrested primary AML cells with FLT3-ITD mutation at the G0, G1 phase of the cell cycle, and decreased the percentage of cells in AS and G2M phase, and increased the apoptosis of primary human AML cells with FLT3-ITD mutation. In vivo assay, we found that the treatment extended survival of anastomized transplanted with human CD45 positive leukemia cells. It also decreased the engraftment of human CD45 positive leukemia cells in PB, bone marrow, and spleen in anastomized at the end point of the treatment. We observed decreased phosphorylation of AKT, STAT5, and ERK in primary human AML cells isolated from anastomized following 3 weeks of PIL inhibitor treatments. Next, we focus on the role of PIL2 in KIT signaling. We found that knockdown PIL2 decreased the colony formation of both calcium-1 and SKN1 cells which bearing the KIT mutation. Loss of PIL2 significantly extended the survival of recipient mice transplanted with calcium-1 cells. Genetic inhibition of PIL2 significantly decreased the engraftment of calcium-1 cells in peripheral blood, bone marrow, and spleen in the recipient mice. Further, knockdown of PIL2 significantly decreased the splenomegaly seen in recipient mice transplanted with calcium-1 cells. The inhibitor treatment reduced the colony formation of both calcium-1 and SKN1 cells. The treatment dramatically decreased the leukemia burden compared with the control group, and also extended the survival of anastomized transplanted with calcium-1 cells. The treatment decreased the engraftment of human leukemia cells in PB, bone marrow, and spleen of anastomized. Finally, PII treatment significantly reduced the spleen rate of anastomized. Next, we found that both knockdown of PIL2 and PII treatment can lead to reduction in FLT3 protein level as a result of the decrease in FLT3 half-life in AMOE411 cells. The knockdown PIL2 treatment increased FLT3 ubiquitination in AMOE411 cells. The half-life of KIT in PIL2 knockout mast cells was significantly shorter than that of the PIL2 wild-type mast cells. Further, PIL2 knockout mast cells showed enhanced KIT ubiquitination compared to wild-type cells following the SCF stimulation. Because SIBO will mediate the ubiquitination and degradation of FLT3 and KIT, so we may think that the PIL2 will cooperate with the SIBO in AML cells. The SIBO becomes phosphorylated on tyrosine residues, including tyrosine 371, 700, 731, and 774 following the cytokine stimulation. So we next figure out how PIL2 associate with SIBO. The GSEA analysis revealed that high PIL2 expression is correlated with SIBO signaling in human leukemia patients. We used the GST pull-down and co-IP assays and found that PIL2 associated with FLT3 and SIBO in AMOE411 cells, with KIT and SIBO in calcium-1 cells. We next found that knockdown of PIL2 increases SIBO phosphorylation at tyrosine 371, whereas the levels of SIBO phosphorylation at tyrosine 700, 731, and 774 were not affected by PR2 inhibition in MOE411 and casimir-1 cells. We detect the ectopic expression of the catalytically inactive PR2 CSD mutant increases SIBO phosphorylation at tyrosine 371 in MOE411 and casimir-1 cells. In summary, FIL3-mutated AML patients with high PR2 expression have reduced overall survival. PR2 deficiency alters FIL3-mediated gene transcription in murine hematopoietic stem and progenitor cells. Loss of PR2 decreases the self-renewal ability of FIL3-ITD positive hematopoietic stem and progenitor cells. PR2 is important for FIL3-ITD-induced myeloproliferative neoplasm in mice. Genetic and pharmacological inhibition of PR2 decreases leukemia burden and extends the survival of mice transplanted with human FIL3-ITD and KIT-mutated cell lines. Pharmacological inhibition of PR2 reduces leukemia burden and extends the survival of mice transplanted with primary human AML cells. PR2 is a positive mediator of oncogenic FIL3 and KIT signaling in murine hematopoietic cells and human leukemia cells. PIL2 associates with and dephosphorylates SIBO at tyrosine 371 in FIL3-ITD and KIT-mutated leukemia cells. Next is our future direction. In our future, we will figure out how FIL3-ITD regulates the expression of PR2 in leukemia cells. How is the PR2 inhibition in FIL3-inhibited treated leukemia cells, like the combination therapy in leukemia cells? How did PR2 participate in other subsets of leukemia, like the mixed lineage arrangement leukemia? Our final goal is to validate that PR2 is a novel druggable target for AML in order to improve the prognosis of AML in the future. Next, I want to thank my PI, Emil. He teach me a lot and give me a lot guidance to finish my project. Thanks for the help from my lab members, and I also want to thank the collaboration from Chongqing University, Northwestern University, Indiana University, and Purdue University. Thanks for your attention. Hello?
Thank you, Dr. Shen. Thank you, Dr. Shen, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Once again, thank you, Doctor, for your presence and presentation. Now let's move on to the next presentation from Dr. Giorgio from Limashaw General Hospital, Cyprus. Hello, Dr. Georgios. Are you ready with your presentation?
I will be speaking on behalf of Dr. Georgios Kostandagis.
Hello, Dr. Daspo. Are you ready with your presentation now?
Yes.
Okay, now I'm making you as a presenter. Kindly click on the screen button to share your screen. Please introduce yourself before starting the presentation. Yeah, your screen is visible now. Can you make it as a full screen and start your presentation, please?
Just give me a second.
Fine.
Okay, so is it visible now?
Yes, it's perfect. You can start your presentation now.
Okay, thank you. Yeah. So hello everyone. I am Despa Verbido. I am a surgical resident in Cyprus, and I am going to present to you a case of generalized tuberculosis that we had in our clinic, presented as acute abdomen, and then we'll do a small literature review around this subject. So let's start with a few words about abdominal tuberculosis. Abdominal tuberculosis is defined as the infection of the gastrointestinal tract, peritoneum, abdominal solid organs, and/or abdominal lymphatics with Mycobacterium tuberculosis. The diagnosis of extrapulmonary TB is very difficult as it presents with non-specific clinical symptoms and radiological features, and it requires a high suspicion to make the diagnosis. Abdominal TB is considered as the great masquerade because it can mimic other diseases such as Crohn's disease, abdominal lymphoma, and abdominal malignancy. It is manifested usually by a certain complication such as intestinal obstruction or perforation. Few words about the epidemiology. It accounts for 15% of extrapulmonary TB cases and for just 5% of total TB cases. It's a rare, but it's a increasing incidence in both developing and developed countries. And it's most common in females less than 40 years old. The most common forms are luminal and peritoneal, but there's also nodal, visceral, and mixed types. The modes of infection, I think you all know them. So now the clinical presentation of abdominal TB depends on the site of infection. The most common, as you can see, is the ileocecal region. Patients can present with ileal perforation, stricture, or peritoneal tubercles. The most common symptoms are abdominal pain, weight loss, and fatigue. The aim of this presentation is to talk a little bit about the case that we had in our clinic, and then review of the current literature will follow. So 24-year-old female patient of Indian origin was transferred to the emergency department complaining about abdominal pain and fatigue and malaise. Her vital signs were fever, borderline arterial pressure, and she was tachypnoic. Upon clinical examination, we saw an acute abdomen with rigidity and rebound tenderness all over the abdomen. We initiated fluid resuscitation and we took blood tests and cultures as well. A Foley catheter was placed and the patient was placed on monitoring. We did the following chest x-ray, and from the chest x-ray we can see some cavities on the left upper lobe, and we can also see signs of ileus with distended small bowel loops. So we proceeded with CT scans. The CT scan showed evidence of hollow viscous perforation from the abdominal CT scan, and so the patient was transferred to the operating room. It's also worth mentioning that from the CT chest we can see some cavities, cavitary lesions over here, and so we had a high suspicion of tuberculosis just from the radiological findings. So again, the patient was led to the operating theater for exploratory laparotomy. The findings were a large amount of free intestinal fluid, foul smelling as well, nodules and adhesions all over the peritoneal cavity. We had some distended small bowel loops and a collapsed terminal ileum. And we also had ischemic loop with necrosis and perforations. So we proceeded with small bowel resection and primary anastomosis in this case. We did a meticulous washout, and however, the remaining small bowel had numerous nodules in the serosa, as you can see from this picture over here. The patient was later transferred to the ICU department. She was placed on antibiotics and ethambutol-isoniazid rifampicin in the next couple of days. Acid fast staining was negative, and tissue culture showed Enterobacter and Klebsiella pneumonia. And a couple of weeks later, we got back the results from the tissue culture and the bronchial aspirate that we sent, and it was positive for Mycobacterium tuberculosis. The patient stayed in the ICU department for 4 days. She didn't have any post-op complications, and she was later transferred to the tuberculosis sanitarium, where she stayed for 15 days. She was discharged clinically well and improved, and she received a total of 6 months of anti-tuberculosis treatment. So now let's do some literature review. WHO states that in 2021, an estimated 10 million people fell ill with tuberculosis, and a total of 1.6 million people died from tuberculosis in that year. The misconceptions on abdominal tuberculosis are mainly three: that abdominal tuberculosis is rare, which isn't. Abdominal tuberculosis is always associated with active pulmonary tuberculosis, which is not always associated, and I will show you later. And abdominal tuberculosis is a disease for the poor, which again it isn't. So approximately 15 to 25% of cases with abdominal TB have concomitant pulmonary TB, the rest don't. But it's quite important for us in identifying such lesions when we have a high index of suspicion. So a couple of facts regarding radiology. CT findings of peritoneal TB include peritoneal thickening, intraperitoneal fluid, lymphadenopathy, and omental caking. Absence of findings does not exclude extrapulmonary TB. PCR is much more sensitive than ELISA, and staining for acid-fast bacilli is negative in most cases. Now we're going to move on with a study I found, a prospective observational study with 70 patients included from 2009 to 2011 in India regarding patients with abdominal TB that presented as acute abdomen, the first presentation. So the patients most commonly presented with intestinal obstruction or perforative peritonitis. None of the patients had a previous history of tuberculosis. They all complained about diffuse abdominal pain, low-grade fever, anorexia, and disturbed bowel habits over weeks to months. On clinical examination, the patients had abdominal tenderness, muscle guard and rigidity, abdominal lump, and ascites. Acid-fast staining was negative again in all cases, and chest x-rays did not suggest the presence of pulmonary tuberculosis in any of the patients. Now, on laparotomy, because all the patients were led to laparotomy, on laparotomy the predominant sign of involvement was terminal ileum and ileocecal region, followed by proximal ileum and jejunum. The pathological changes demonstrated on laparotomy included hypertrophic variety of ileocecal tuberculosis and single or multiple sites of intestinal perforation. The surgical procedures included resection of the diseased segment and restoration of intestinal continuity with a primary anastomosis, a creation of a stoma as a two-stage operation, repair of the perforation, appendicectomy, etc. The choice of a surgical procedure depended on the site and the extent of disease, the status of the remaining gut, the general condition of the patient, and the surgeon's expertise and individual preference. Now, to conclude, abdominal tuberculosis is an increasingly common disease nowadays that still poses a diagnostic challenge. There is non-pathognomonic clinical symptoms and or radiologic features. So we usually have diagnostic delays, and the patients tend to develop complications due to that. We must have a high index of clinical suspicion just to make the diagnosis. We don't have a diagnostic lab test yet that is simple and cost effective that can be used routinely for abdominal TB. And early diagnosis means promising prognosis. Thank you very much for your attention.
Thank you, Dr. Despo, for your presence and presentation. Does anyone having any queries?
Thank you very much.
I hope there are no queries. Once again, thank you for your presence and presentation. Now we'll move on to the next presentation. The next presenter is Dr. Maroš Vodolkia Natalia from Belarusian State Medical University, Belarus. Hello, Dr. Maroš. Are you ready with the presentation?
Yeah, hello. I'm
Yeah.
very
Hi, Dr.
I'm glad
Natalia.
to I'm very glad to participate in your conference. I just try to share
Now,
my
just now I have made you as a present. I have made you as a presenter. Can you please click on the screen button to share your screen?
okay. Um, just give me a couple of minutes.
Yeah, okay.
So sure. Okay.
Yes, your screen is visible now. Can you make it as a full screen and start your presentation? And please unmute yourself. Sorry, we are unable to hear you. You are in a mute. Can you please make it as unmute? No, no, sorry, we are unable to hear you. Hello, Dr. Natalia. Can you please unmute yourself? Sorry, we are unable to hear you. You are in a mute. Can you click on the mic button in your GoToMeetings app to unmute yourself? Hello, Dr. Natalia. I have there is a technical issue from the Dr. Natalia's end. We'll wait for a few minutes. I hope it's taking lots of Talia. Now, meanwhile, we'll move on to presentation. The next presenter, the next presenter is Dr. Mazda Varadane from University Caria, Morocco. Hello, Dr. Mazda. Are you ready with your presentation?
Yes, hello.
Okay, Dr. Mazda. Now I'm making you as a presenter. Yeah. Now I'm making you as a presenter. Kindly click on the screen button to share your screen, please. Yeah, your screen is shared. Can you make it to the full screen and
Can I start?
it is perfect. Yeah, it is perfect. Now, can you please check your audio settings because your echo is very high. We are unable to hear your voice clearly. Can you please place your microphone?
It is okay?
Yeah,
It is
it is okay.
okay?
Now you can continue.
Thank
Can you please
you.
place your microphone a little bit far from your?
I can start.
Yeah, you can start. Perfect. You can start.
Good morning, everyone. Very pleased to have participated in this 14th European Congress in Infectious Diseases. Today, I'm going to talk to you about pyrovirus B19 in Morocco, seroprevalence of immunoglobulin Ag antibody in pregnant women in Marrakesh, Morocco. During this presentation, we will talk about a reminder, a few words of history of pyrovirus B19, pyrovirus B19 infection in pregnancy, fatal effects of pyrovirus B19, virus B19 virological characters, epidemiological studies, and we will continue with the material and methods, results, discussion, and we will finish with the closing part. Pyrovirus B19 and pregnant women. B19 is ubiquitous and contagious small virus discovered in 1975 by Yvonne Cossard. The pathogenic role of the virus was first identified in 1981 during erythroblastopenic attacks in patients with sickle cell disease. And in 983, it was responsible for infectious erythema or 50 shield disease. Acute pyrovirus B19 infection is a risk for pregnant women. Close and frequent contact with young children is a more risk occurring B19 infection during pregnancy. The other risk factors are working in the school, care centers, and other full stress jobs. Primary infection manifests as rash and arthritis. Pyrovirus B19 infection during pregnancy can cause severe anemia, hydrophytalis, miscarriage, and fetal death in utero. 30% of primary infection in pregnant women results in fetal infection. Pyrovirus B19 is responsible for 3 to 5% of spontaneous abortion, 7 to 15% of fetal deaths in utero. The risk of fetal maternal transmission varies according to gestational age. 0% of period preconceptional, 25%, 70 to 20 weeks of amenorrhea, 60%, 20 to 30 weeks of amenorrhea. B19 virological characters. Pyrovirus B19 is an enveloped small virus, single-stranded DNA virus with an icosahedral capsid. Its genome encodes for three major proteins. They are two structural proteins, VP1 and VP2, which up the capsid, and one non-structural protein in C1, which is responsible from viral replication. Concerning cellular tropism, the only known natural host cell of pyrovirus B19 is the immune erythroid progenitor. Like other non-enveloped DNA virus, the pyrovirus B19 life cycle includes the following stage: binding to host cell receptor, internalization, translocation of the genome to the host nucleus, DNA replication, RNA transcription, assembly of capsid, packaging the genome, and cell lysis is with release of the mature variant. The incubation period of the infection is 4 to 14 days. Viremia occurs approximately 7 days after inoculation and persists for up to 4 days. And rash appears by the 16 days. During the second week after infection, the viremia titer decreases and IgM antibodies are detected. These EGG can persist for years, while the AGM antibodies disappear 60 to 10 weeks. For epidemiological studies, pyrovirus is transmitted person to person by direct contact with respiratory secretion of infected person, placentary transfer, and blood transfusion. Infection with B19 is very common, and cases of infection have been reported all over the world in all seasons. Data on the seroprevalence of women susceptible to B19 infection in early pregnancy reports a value of 26% to 43% in European countries and Japan. Generally, seropositivity is low among young children, resists to around 50%. For materials and method study design, this research was at Burton Hospital of Marrakesh, Morocco. The study included 100 healthy pregnant women who come for routine follow-up at any gestational age and who have accepted to participate in this study. A questionnaire including the demographic information, occupation, gestational age, previous history of spontaneous abortion, number of pregnancy, and obstetrical characteristic of the study subjects was administered by the research team. Serological tests were carried out by searching for IgG antibodies via the pyrovirus Viclia at the bacteriology virology laboratory of the Abyssal Military Hospital in Marrakesh. Characteristic of the study population. A total of 100 pregnant women were enrolled into the study. The median age of the women was 27 years. Out of 100 women, 54% were in the third trimester, 38% in second trimester, and 8% in first trimester. A total of 96.8% women represented the urban population, and 79% had primary secondary school education, while 20% were illiterate. Moreover, 19% women had a history of spontaneous abortion. The seroprevalence of B19 IgG antibody among 100 women was 51%. The average age of pregnant women with positive and negative serology was 26 years, 28 years respectively. The seropositivity was variable in different age groups, but generally the high prevalence was observed in age group more than 26 years. Pregnant women in their second and third trimester had high IgG seropositivity 22 and 25 respectively, right than those in the first trimester, 4%. For risk factors associated with B19 seroprevalence, 8% of women tested positive of AGG B19 had at least one spontaneous abortion, and only one woman had a history of this in utero. 4% for the cases tested positive for anti-B AGG were employed, one of them working in a daycare center, and also 4% of them had a history of blood transfusion. 20% 9 of the women with a child under 6 years were tested positive. The husband's regular occupation was noted in 29% of cases. The absence of schooling was described in 4% of women. The results of logistic regression demonstrated a non-significant association between the prevalence of B19 EGG antibody and the demographic and obstetrical factors, except for the having a child under 6 years factor. For discussion, B19 infection is widespread. The prevalence of B19 varies in different parts of the world. Accounts B19 infection is a risk for pregnant women. This is the first epidemiological study conducted in Marrakesh investigating the seroprevalence of B19 EGG, which will provide an understanding of the pregnant women immunity to B19. Data on B19 epidemiology in Morocco are unknown. In this study, 51% of women who participated were positive for B19 EGG antibody, which was similar to the reported seroprevalence in pregnant women in several other countries such as Croatia, Spain, Iran, India, Tunisia, Libya, and Sudan. The seroprevalence of B19 in the pregnant woman population may be influenced by various demographic and obstetrical variables. Here in this study, we noticed a significant association between B19 seroprevalence and the having a child under 6 years. In conclusion, our study provided data from Marrakech City in Morocco on seroprevalence of B19 in asymptomatic pregnant women. In this study, 51% of the participating women were positive antibody, indicating a considerable circulation of B19 in Marrakech City. As B19 infection is not vaccine preventable, the only means of prevention is a reinforcement of hygienic precaution. Awareness needs to be generated in pregnant women about this infection, its consequences and methods of prevention. However, more study on the prevalence of B19 in women in Marrakesh and in different cities of Morocco, particularly in those with complications and adverse outcomes of pregnancy, are recommended. Thank you very much.
Thank you, Dr. Mazda, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Once again, thank you, Doctor, for your presence and presentation. Meanwhile, as we are moving ahead with the session, let's move on to the next presentation from Dr. Nasim Fahad from Salmania Medical Complex, Bahrain. Hello, Dr. Nasim. Are you ready with your presentation?
Yes, hello everyone. I'm ready with my presentation.
Yeah, thank you, Doctor. Now I'm making you as a presenter. Kindly click on the screen button to share your screen. Yeah, your screen is visible now. Can you make it as a full screen mode and start your presentation now?
Yes, can you see it as full screen model currently?
Yeah, it is perfect now. You can start. Thank you.
Hello everyone, my topic today is about sickle cell disease complication in adolescents and adult and new modalities of treatment. So this is the shape of the sickle cell disease that we see under the peripheral smear. Most of us are familiar with it. Uh, let's go back to the basic hemoglobin molecule. It consists of alpha chain, beta chain, iron, and they are in the helical shape. Why the sickle cell disease happens? The sickle cell disease is a phenotype, is the result of the substitution of valine for glutamine at the sixth amino acid position of the beta chain. So approximately 300,000 infants are born with sickle cell anemia every year. This number could rise to 400,000 by the year 2050. The prevalence of the disease is high throughout the large areas in sub-Saharan Africa, the Mediterranean basin, the Middle East, and India. Why it happens? Because of the malaria hypothesis. The malaria hypothesis was formulated by Helden in 1949 and Ellison by 1954. The remarkable level of protection that the sickle cell trait, heterozygosity of the sickle cell mutation in hemoglobin, provides against the severe anemia. Because of the slave trading and contemporary population movement, the distribution of sickle cell disease has spread far beyond its origins. In this map, we can see where sickle cell disease are more located. And the vast majority of these births happens in the countries are in Nigeria, Democratic Republic of Congo, and in India. So the problem with sickle cell disease, they come in S hemoglobin that becomes like an S shape, and this S shape blocks the blood fluid. This is the most common theory that we believe in. So what the complications happens in cardiovascular system, you can have cardiothoracic system, you can have chronic obstructive lung disease, left ventricular diastolic function, diastolic function, pulmonary hypertension, dysarrhythmia, sudden death, and for sure acute chest syndrome. In the nervous system, we can hemorrhagic stroke, venous sinus thrombosis, silent cerebral infarction in the brain, chronic pain, cognitive impairment, orbital infarction, proliferative retinopathy, and acute ischemia stroke in the brain. In the reticular endothelial system, we have the anemia, hemolysis, functional hyposplenism, and for sure splenic restoration. In the musculoskeletal system, we have the vascular necrosis, leg ulceration. In the urogenital system, we have papillary necrosis, proteinuria, renal failure, hematuria, nocturnal neuritis, and priapism. And the GI gastrointestinal system, we have cholelithiasis, cholangiopathy, hepatopathy, and mesenteric vasoocclusion. So the pathophysiology of the sickle cell disease is not just the blockage of the blood flow. It happens because of vascular endothelial dysfunction, functional nitric oxide deficiency, inflammation, oxidative stress and reperfusion injury, hypercoagulability, increased neutrophil adhesiveness, and platelet activation. So those, for the chronic complications, they are divided into two entities. One is because of large vessel vasculopathy, and those leads to cerebral vascular disease, pulmonary hypertension, priapism, and retinopathy. And the other entity is because of progressive ischemia, and those one leads to renal failure, bone disease, and liver damage. So other genotypes of sickle cell disease are due to compound heterozygosity of hemoglobin S gene and the other hemoglobin variants such as hemoglobin C, E, and D, and to many varieties of sickle cell with thalassemia, what we call sickle cell. The exception of hemoglobin S beta thalassemia, the compound heterozygous genotype with the sickle cell disease are usually less clinically severe than the genotype of sickle cell anemia. Alpha thalassemia reduces the level of hemoglobin in the cell, indirectly mitigating the hemoglobin as polymer-induced erythrocyte damage. So when we compare the fetal hemoglobin level and the alpha thalassemia, we know when the fetal hemoglobin is high, the painful crises are less. And when the alpha thalassemia is there, it increases the risk of painful crisis and some other complications like acute chest syndrome and osteonecrosis. So what other effects affect the sickle cell disease? The other effect A link between cold weather and acute complication of sickle cell disease was first described in the United States in 1924. Proposed mechanisms include cold weather causing increased infection and peripheral vasoconstriction, causing higher deoxygenation, decreased shear flow, and vascular steal effects. Both high and low humidity have been associated with increased hospital admissions for pain, and higher pain scores were associated with increased humidity in study in Canada. So, as we can see from this one, the weather, the air quality, and the others, all of those ones can lead to low effects of the sickle cell disease. While if you have the alpha thalassemia, hemoglobin F, low hemoglobin F level, all of those ones will lead to increase in severity of the phenotype of the sickle cell disease. Infections of sickle cell disease, significant morbidity and mortality among patients with sickle cell disease happen regardless of the age. Streptococcus pneumonia, osteomyelitis due to Salmonella, Staph aureus, gram-negative bacilli, and Mycobacterium tuberculosis, and acute chest syndrome with typical organisms such as chlamydia, mycoplasma, and viruses. Autosplenectomy, deficient splenic clearance of opsonized encapsulated bacteria results in a propensity to infection by encapsulated bacteria such as Strep pneumoniae, Haemophilus influenza, Salmonella typhi, non-typhi, and meningococcal species. So what has led to decrease in the childhood mortality of sickle cell disease? What measures were taken? Neonatal sickle cell disease screening, vaccination, prophylactic antibiotics, and the aggressive use of intravenous antibiotic therapy for febrile episodes, and the availability of contemporary pediatric critical care services. With such measure, before the advent of penicillin prophylaxis, the incidence of invasive pneumococcal disease was 6 episodes per 100 patients, with a peak within the first 3 years. Now it's much improvement. What are the mechanisms of immune deficiency? You can have the innate immune dysfunction by neutrophil dysfunction, splenic dysfunction, and reduced opsonization. Can have also because of adaptive immune dysfunction with decreased humoral immunity and impaired virus-directed immunity. Some mechanical factors as osteomyelitis of the bone acts like a nidus for bacterial proliferation. And the last, the nutritional, as I'm going to tell you in the next few slides about zinc deficiency. So it was found when you have zinc deficiency because of low dietary of the zinc, as zinc gets involved in many organs of the body. When the meiosis happens and there's an increase in the secretion of the zinc in the urine, you can have hyperzincuria, and this will lead to zinc insufficiency and deficiency, and this will increase in the increased number of hospitalization for vaso-occlusive crisis. Why zinc deficiency is important? Because it causes lymphopenia, reduced interleukin-2 production, it helps in adequate development of cell-mediated immunity, and with deficiency of zinc, the deficient in coordination of the innate and adaptive immune system. Other vitamins, supplementation of vitamin A, B, and magnesium has been demonstrated to decrease the frequency of infection, painful crisis, and emergency departmental visits. Cholecystitis, 92.3% of patients with cholecystitis were elder than 5 years. The pathogens of concern in cholecystitis include enteric gram-negative pathogens, enterococci, and anaerobic bacteria. Tazocine or piperacillin tazobactam and carbapenems. Antibiotics are considered the first-line therapies. Oral cavity pain in a sickle cell disease patient. The oral cavity is a source of infection and non-infectious complications. Orofacial pain in sickle cell disease may be due to vaso-occlusive in the facial bones and dental pulp or osteomyelitis in the facial bone. And this is where the dilemma happens between differentiation, whether this is a bone infarction or osteomyelitis. As I said, it is difficult to differentiate. Blood culture, MRI, and bone aspiration biopsy may help in the diagnosis. Colonization of the oropharynx with non-albicans, candida species, and unusual fungi has been observed in patients with sickle cell disease. Maybe it was suggested due to the penicillin effect, which affected the balance in the oral flora. So the guidelines from the National Heart, Lung, and the Blood Institute dictated that oral penicillin prophylaxis 125 milligram for patients below 3 years of age and 20 to 250 milligram for patients who are elder than 3 years, with a BID dose, twice daily dose, until the age of 5. So discontinuation of the penicillin by the age of 5 if there is no history of invasive pneumococcal disease or surgical splenectomy or pneumococcal vaccination has been adequate. So the current vaccination schedule, we follow the Streptococcus pneumoniae within 5 years, Neisseria meningitis within previous 3 years, Haemophilus influenza, and annual influenza vaccine. Yellow fever and Salmonella typhi is highly recommended for patients with sickle cell disease. So what is the definition, exact definition of acute pain or vaso-occlusive episode? It's a new onset of severe pain that persists for at least 4 hours, for which there is no explanation other than the vaso-occlusion. But there is another type of pain, which is the chronic pain, which is subdivided in 3 categories. The first, chronic pain without contributing sickle cell disease complications, such as leg ulcers or vascular necrosis. Chronic pain without contributing sickle cell disease complication, or it's a mixed presentation when there is an evidence of chronic pain of a sickle cell disease complication, but there is an apparently unrelated persistent pain that happens with them. So a vascular necrosis, in one study, a quarter of patients who underwent hip replacement surgery were between the median of age of 36. Priapism, probability of male patients with sickle cell disease experiencing priapism was nearly 13% above the age of 10, 50% by the age of 50, and almost 89% by the age of 30. And acute chest syndrome is characterized by pleuritic chest pain, fever, raised auscultation, and pulmonary infiltrate on chest X-ray. It can resemble other acute respiratory illnesses, including pneumonia, asthma exacerbation, or even bronchiolitis. Incidence is highest in children ages 2 to 4 years, but severity tends to be higher in adults in whom studies have found mortality rates to be up to 4 times higher than in children. So when we analyze the type of organisms that causes the acute chest syndrome, chlamydia and mycoplasma pneumonia were the most common, with almost like 50% of the time of the acute chest, and the other organisms were as listed in front of you. So what about IV hydration, acute chest syndrome? IV fluid administration is frequently a component of treatment of vaso-occlusive episode, but excessive fluids can cause pulmonary edema and can precipitate acute chest syndrome. Incentive spirometry is 10 maximum inspiration every 2 hours while the patient is awake to prevent atelectasis and the development of acute chest syndrome during hospitalization for vaso-occlusive episodes. Corticosteroid as a modality for treatment for acute chest has been shown in 3 placebo-controlled trials to reduce the length of hospitalization by 24 hours. But be careful, however, this was associated with significant rebound VOC and rehospitalization by 25%. And many concerns were raised about the side effects such as vascular necrosis, rebound VOC, and association with hemorrhagic stroke made a lot of doctors lose their enthusiasm when using steroids for sickle cell disease patients with acute chest syndrome. What about cerebrovascular accidents in patients with sickle cell? It was found that hemoglobin SS has the highest incidence with 4% among the adults. There is another entity called silent stroke, so silent cerebral infarcts. It is the most common infarct in sickle cell disease patients and can only be detected by MRI. Children with silent strokes typically present with no neurological signs or symptoms. However, any sickle cell disease patient who has progressive neurocognitive deficit should have an MRI screening because most common sickle cell disease anemia, they have silent infarct by the age of 14 with approximately 37%. Risk factors to develop silent infarcts are low hemoglobin, high systolic blood pressure, and male sex. Transcranial Doppler is a modality for screening for children for infarct, and it usually starts by the age of 2 and continue until the age of 16 with referral to a specialist when the results are shown abnormal. Acute splenic sequestration crisis is defined as sudden splenomegaly, a reduction in hemoglobin concentration by at least 2 grams per deciliter, and a normal elevated basal reticulocyte count. The spleen enlarges within a period of hours, trapping a large portion of circulating erythrocytes and acutely worsening the anemia and circulatory failure. And pulmonary hypertension is another complication that commonly seen in adolescents and adults, with all of the hemolytic diseases such as sickle cell disease, even the Arab disease and thalassemia. They found here pulmonary hypertension is always increased. Pulmonary fibrosis, as you can see from this CT, there is radiological evidence of pulmonary fibrosis due to multiple episodes of acute chest syndrome. You can note the subpleural honeycombing fibrosis denoted by the arrows you can see. Renal complication of sickle cell disease, it's estimated that 16 to 18% of overall mortality in sickle cell disease is related to renal complications. The most common renal complication in sickle cell disease is hypostrinuria, which is the inability to concentrate urine, which leads to urinary frequency, enuresis, and increased risk of intravascular volume depletion. Microalbuminuria is the first manifestation of chronic kidney disease, and all patients with sickle cell disease should be screened for proteinuria starting annually from the age of 10. Many other complications happens in the kidney, not just because of infarction. It can bleed because of iron deposition, decrease in the glomerular filtration, and abnormality in the medullary and distal tubules, and can lead to a lot of complications in the kidneys. Hematuria is a common kidney manifestation and typically is asymptomatic and self-limited. It is often unilateral, and left kidney is more commonly affected. Renal papillary necrosis frequently happens in both sickle cell disease and sickle cell trait. Is most frequently found incidentally during routine renal imaging evaluation. ACE inhibitors, current publication using ACE inhibitors as prophylactic for proteinuria and macroalbuminuria. The recommendation is using an ACE inhibitor when the PCR protein creatinine ratio is above 100 milligram per millimicromole. And studies has detected macroalbuminuria as early as 4 years. However, the recommendation to start screening by the age of 7 is considered as an acceptable age. As I told you, this is a list of a lot of renal complication can happen due to sickle cell disease, and we have to keep in mind that it increases the possibility of medullary carcinoma. So this photo just summarizes some of the complications: the retinopathy, the pulmonary hypertension, the vascular necrosis that happens in adult, and pigmented gallstones. Why it happens, the pathogenesis, as I mentioned earlier, it is not just because of occlusion of the vessels. It's a big mechanism of inflammation and activation of the hemostatic system with decreasing of the nitrous oxide. So with sickle cell disease, as I mentioned, it leads to vaso-occlusion, anemia, and hemolysis, but there is inflammation, hypercoagulability, increase in oxidative stress, and defective in arginine metabolism. And upon deoxygenation, the sickle cell hemoglobin is insoluble and undergoes polymerization and aggregation of the polymers into the tubule fibers, and then this will lead to sickling of the RBCs. Multiple inflammatory cytokines such as interleukin 10 and 14 and 4, macrophage, inflammatory protein, and tumor necrosis factor alpha were all elevated as a baseline. So the recommendation for a treatment nowadays to use hydroxyurea. So who are the patients recommended for? Patients who have more than 3 or equal than 3 moderate to severe pain episodes in 12 months period. Patients who have a history of a stroke and contraindication to chronic transfusion as a alternative modality. Children who have history of acute chest syndrome or symptomatic anemia. and infants and children 9 months of age and older who are asymptomatic or have infrequent pain episodes. Keep in mind, hydroxyurea has teratogenetic effect. It affects the infertility and possibility of increasing the risk of malignancy. Another two medications, decitabine and 5-acetazidine. The DNA methylation carried by enzyme DNA methyltransferase 1. Decitabine, it's a prodrug for 5-acetazidine, have been found to deplete this enzyme. In animals, 5-acetazidine produces increase in hemoglobin F level 20 times much more than hydroxyurea. But why were we not using them? Because of the poor availability, negligible solid tissue distribution, a very brief half-life, and the formation of uridine degeneration products that could potentially damage the DNA and cytotoxicity, and the teratogenic effect and carcinogenesis are real concerns with the use of those two medicines. And another modality in prevention of the oxidative stress, using the L-glutamine. Sickle cell RBCs absorbs and utilize the glutamine to a far greater extent than the normal RBCs. L-glutamine improves the cellular defense against oxidative stress. So when we use the L-glutamine, the frequency of VOD episodes decreased by 25%, and the incidence of acute chest syndrome decreased by 50%, and the side effects were almost negligible. Preventing the adhesions. So selectins, especially B-selectin, which is an upregulated in sickle cell disease, are responsible for the initiation of the static adhesion of the sickle cell cells to the surface and ensuring the vascular obstruction that is seen in crisis of inflammation. Crizanlizumab, a humanized monoclonal antibody, is one agent. It blocks the cell-to-cell adhesion by targeting the B-selectin. The drug was administered by intravenous infusion and was shown to have a relatively long 30-day half-life. Another drug, which is the itavopivat, which increases the pyruvate kinase in the hemoglobin levels and decreases the vaso-occlusive crisis. By using the itavopivat, it leads to decrease in 2,3-DPG and increases ATP, resulting in increase in hemoglobin oxygen affinity and improving sickle cell function. Another modality to improve the flow dynamic is the poloxamine 188. It's a non-ionic block copolymer surfactant. Has been shown to improve the microvascular blood flow in sickle cell disease by decreasing blood viscosity. How it does it, it's still not well understood. However, it seems that it blocks the aggregating interaction of cell to cells and cells to protein in the blood. Preventing the polymerization, voxelotor is a small molecule that it is binding to hemoglobin S, increases the oxygen affinity of the hemoglobin S molecule. Voxelotor therapy inhibits polymerization of the molecule and can prevent damage to the red cells. When it was used, hospital admissions for VOC crisis declined by 60%, and chronic pain was described as a background has shown to be decreased. Stem cell transplantation. Transplant has been performed for most part in the patient who have suffered from stroke, who have multiple episodes of acute chest syndrome, or have had recurrent vaso-occlusive crisis more than 3 equal to 3 episodes of hospitalization per year. What are the limitations to using transplant? The probability of an individual having a matched sibling donor is only 16 to 20% among minorities, and 8 to 8 allele match is sought. Myeloablative conditioning has remained the standard of care for hematopoietic stem cell transplantation. It has been associated with toxicity that have included veno-occlusive disease of the liver and neurotoxicity such as seizure, stroke, and brain hemorrhage. Referring patient to transplantation by itself is considered a challenge and it needs to be overcome, because it was suggested just that in one retrospective study, as using hydroxyurea, it was found that patients with hydroxyurea may have a better survival than those who had allogenic stem cell transplantation. To keep in mind, in chimerism and sickle cell disease, 20% is necessary to upgrade the sickle cell phenotype and with only 3.25% chimerism is the lowest donor chimerism considered to be acceptable to prevent sickle cell disease complications. Another modality of treatment is the gene therapy with lentiglobulin B111. The gene therapy of lentiglobulin consists of an autologous transplantation of hematopoietic stem cell and progenitor cells transduced within the lentivirus vector to modify the beta-globin gene and producing the anti-sickling effect. A lot of studies are being done on gene therapy on sickle cell disease. This is just a summary of the new modalities of treatment, and those are my references, and thank you all.
Hello, Dr. Nasim. Thank you for your presence and presentation. Does anyone having any queries? I hope there are no queries. Once again, thank you, Dr. Nasim Fahad, for your presence and presentation. Thank you. Now we'll
Thank
move
you
on
all.
to the Thank you. Now we'll move on to the next presentation from Dr. Natalia.
Okay. Good morning again.
Okay, now
Okay.
Dr. Natalia, now I'm making you as a presenter. Kindly click on the screen button to share your screen.
Okay. So now you hear me
Yeah. Yeah,
and
your screen is
you.
visible now. Can you make it as a full screen and start your presentation, please?
Okay. Okay. So I can start. Yeah.
Yeah, you can start.
Yeah. I will a little talk quickly because of very short time. We try to estimate our experience to manage to treat COVID patients with pneumonia admitted to hospital. And first of all, I would say that I have no any conflicts of interest in this study because of it was not well organized, of course. It was in the start of pandemic, and our vision of disease was transformed from respiratory distress syndrome to multi-organ disease, surely with multi-organ injury, and the blood clotting is main reason, main reason for damage of many organs in human body. And sure that we don't know exactly which is direct way of possible impact or possible contribution of virus COVID disease, but sure is that the hypercoagulable state is important not in only arterial blood, but also in venal blood and vessels, and the different mechanism and different agents were involved and still involved in thrombus formation. And as we can see, platelets and von Willebrand factors, the main agents which are involved in thrombus and forming fibrin and damage of organs. And of course, different visual content in patients with arterial bed thrombus, like in this picture, in patient with COVID pneumonia and left atrial appendage thrombus. in the heart, and patient with venous thrombosis and floating thrombus in deep femoral vein. So, but the main complications regarding the study, regarding the published study, were seen in patients on general on of course at first days of admission, but most of them were revealed between 10 and 20 days of admission, with 50% of thrombus diagnosing in first 24 hours after admission. What we can see in published papers that 7, 14, and 21 days, 21st day, were most important in patient. Unfortunately, regarding the guidelines for treatment of patients with COVID pneumonia, most of them were discharged at 14 days after admitting. After the starting of disease, not really after the starting, but we can see that this most important day, 7 day, is also very important. Regarding the venous thromboembolism, it is also was clearly shown in published papers that intensive care unit patients demonstrated most significant rate of thrombosis than in patients with general department. And the number of deaths was dependent on the age of admitted patients, and general strategy was directly applied for preventing of thrombus formation using the low molecular weight heparins. Or heparin users demonstrated also more favorable results if it was indicated in exactly the right person and right blood data regarding the coagulation and thrombus product degradation. So, but if we will talk about, for example, the DDMers, not all patients had favorable results, especially if they were treated without indication for heparin using, as it is shown in this picture. Because of because of bleeding risk and complication, very significant complication, which demanded quite different treatment in this patient in terms of inflammation syndrome. So the aim of our study was to assess hemostatic disorders in patients with CT-proven COVID pneumonia admitted to hospital and treated with low molecular weight heparins. Of course, it was not randomized and well-organized study, but also it was like observational study, which is also very important in pandemic. And I also want to remind you what was in that years. And in our country, it was second wave in November, December of 2020, with quite a lot of confirmed cases and quite a lot of deaths officially demonstrated in official statistics. Unfortunately, not all patients were included in this study because it was a specific study. Adult patient, totally 170, and age 62 years old, mostly men patients, but mostly female patients. With male patient about 40%, with mild, moderate, or severe clinical stage of pneumonia and comorbidity in half of patients. They were included in study during November, December 2020, and the study was performed in Transform, so-called Transform maternity hospital. Totally 800 patients were admitted. 8 of them died. 2 months duties in this time. 2 months duties were managed by gynecologists, cardiologists, neurologists, general physician, neonatologists, anesthesiologists. But as you can see, the most of physicians were not doctors, were gynecologists, which was, I think, which was not only our country problem or this hospital problem, but it was a problem for whole world with management of therapeutic patients by different specialties. So the comorbidity included mostly ischemic heart disease, arterial hypertension as combination, obstructive lung disease, pulmonary disease, diabetes mellitus, and other diseases with very low eventual rate. Among methods, we use blood polymerase chain reaction at admission, lung CT, in a day of admission or second day of admission, after admission, and laboratory tests at first 5 to 7 and 9 to 11 or later days of admission because of indication with hematologic assay also and blood morphology. Groups were selected regarding the clinical severity of pneumonia, regarding the full criteria, and treatment included routine administration of low molecular weight heparins, and also optionally in mostly about a half of patients, about a half of cohort were treated with steroids. In hospital, only one of cohort, only one patient had severe pulmonary embolism with respiratory support. If we return to criteria of group selection, it is shown in these slides that it was conscious, breathing rate, heart rate, blood pressure, oxygen saturation, and white cells number for selection of patients. Surely there are risk factors of thromboembolic events in COVID, pneumonia, and COVID-19. As most important risk factor is intensive care unit and treatment with respiratory support. Also, history of thromboembolism, number of white blood cells, and mean DDV. And this is very important to analyze, but the data which we analyzed in our study were very exciting because of the different results among groups and also in cohorts in all. While we try to estimate DDMER levels, we found that patients with DDMERs higher than 500 milligrams per milliliters were in a start of the assessment at first or second days of the hospital stay. Among 15% were higher than 500 levels, and about 6% of person had high level. And surely it could be an indication for low molecular weight heparins, but all patients were treated with heparins with past days. And during the hospital stay, we can see that the number of patients regarding the diameter of balls is the number of patients with higher level, with increased level of DDMERs increased. But if we will see the number of patients in whom DDMERs were estimated, we can see that from first day to 9 days to the end of hospitalization, the number of patients with DDMERs estimation were dramatically decreased from 170 to 38 at 9. Also, if we will try to compare the dynamics or the absolute number of absolute level of dedimers at the first 5 and 7 and 9 days of hospital stay, we can see that patients of group 1 with mild pneumonia had no difficult changes in dynamics of dedimers, but the patients with moderate pneumonia demonstrated the increasing of level dedimers at 5 days and with continuous increasing at 9 days. And patients with severe pneumonia had very, not very, but higher level of dedimers also with continuing increasing during the hospital stay. But this dynamics didn't show us the real statement, because the patients were quite different in the groups, and the level of dedimers were quite different from normal to very high to, for example, to 8,000 of milligram per milliliter. These slides represent the dynamic in whole group in patients with complete follow-up, and it seems that patients from first to fifth day had slight increasing, not significant, but slight increasing of level dedimers with a little bit lower level at 7 days. But the number you can see here is the numbers of patients who had really estimation of dedimers during the hospital stay. Fibrinogen A dynamics was also very different in groups and in total cohorts, and patients of group 2 demonstrated also increasing of dynamics, as well as patients of group 3 at 5th and 9th day, which is was demanded to add to treatment heparins, not in preventive dose, but in more significant dose. But what we found in the analysis of activated thromboplastin time, partial thromboplastin time in patients who were treated with heparins and with titrated dose of low-weight molecular heparins and the increasing dose, that this parameter was unchanged during the hospital stay, during the treatment of patients by the heparins, and it was very difficult to explain, because there were not so many publications regarding the COVID patients and regarding the, any possible adverse effect in COVID patients during the administration of heparins, also low-weight molecular heparins. But we can see also the decreasing of level hemoglobin in patients at day 9, and it could be possible to explain this because of impact of heparins and infection and any other factors, also intradermal or subdermal bleeding like hematoma. It could be possible to explain, but we didn't find any correlation between the level of hemoglobin and the dose of heparins in the study in this patient. In spite, we revealed clearly see that the patient had deep venous clotting, blood clotting, and also the same patient had intradermal, subdermal hematoma. Of course, inside of injection, but unfortunately, this example is not very representative because we could see larger and deeper hematoma with next treatment by any additional antibiotics to prevent inflammation inside of hematoma. So we suggest now, after analyzing, we suggest that it was a sign, there were a sign of heparin resistance, but actual observed, because we know that the high level of fibrin gene A can decrease the real PPT time in patients treated by heparins. And in terms of our finding, we conclude that COVID-19 is followed by increasing fibrinogen A level in patients despite of the administration of prevention doses of heparins. But more significant changes were revealed in patients with moderate to severe pneumonia. Different dynamics of fibrinogen A, D-dimers, and APPT time in patients treated with heparin cannot be explained only by severity of pneumonia or steroid use, because we also didn't find any correlation in the using of steroids or in dose of steroids in patient and the level of fibrinogen A, D-dimers, or any other parameters in this study. And routine blood clotting indices are seek as a laboratory control in COVID pneumonia patients, also in patients treated with heparins in preventive doses. Thrombotic complications in COVID infection, COVID pneumonia should be investigated more detailed in the frame of the prevention by heparins and effective treatment. Thank you. If you have any questions, I'm ready to answer.
Thank you, Dr. Natalia, for your presence and presentation. Does anyone having any queries?
Okay.
You can unmute yourself and ask your queries. I hope there are no queries. Once again, thank you, Dr. Natalia.
Yeah, thank you. Thank you again for the invitation. Yeah.
Thank you. Now, as per the schedule, let's continue our talks after the lunch break. We will be back with after 30 minutes from now. Stay connected.
This conference will now be recorded.
Hello. Am I audible? Okay, fine. Hello. Okay, thank you. Is the screen visible? Uh, okay, I'll be presenting my presentation. Hello, everyone. My name is Nidhi Nautiyal, and I'm a PhD scholar working in the area of stem cells and regenerative medicine. I have been working in exploring the role of bone marrow during chronic liver injury or liver cirrhosis. So I'll be presenting my work like restoring bone marrow hematopoietic stem cell reserve and augmenting regression of fibrosis and regeneration in animal model of cirrhosis. So before proceeding with the work, let's give a brief description of liver function. As we all know, liver is the largest organ and carry out most of the metabolic function. It involves in detoxification of many drugs, medicines, alcohol. It is involved in metabolism, maintaining the immune system, fighting against the pathogen of bacteria entering into the body, provide protein synthesis, maintain the body homeostasis, blood sugar production in the bile, cholesterol, and many other functions. So when we say liver cirrhosis, there are the many causes which are like alcohol, viral, obesity, diabetes, high cholesterol, and genetic. The chronic insult from all these injuries lead a healthy state of liver to enter into disease state that could be NAFLD, which is like non-alcoholic fatty liver disease, where the hepatocyte, the principal unit of liver, is filled with fat. This NAFLD condition enter into another cirrhotic condition, which is NASH, which we call it non-alcoholic steatohepatitis. Other form of liver disease like hemochromatosis, hepatitis, as we are well aware of hepatitis A, B, and C, and alcoholic hepatitis. All these type of liver disease finally enter into a state called liver cirrhosis. Liver cirrhosis is further categorized into decompensated state and decompensated state. So when we say decompensated state of liver disease, it is the end stage of liver disease and has been like known either for the death and liver failure as the ultimate result. Till now, only the orthotropic liver transplantation has been known the curative for decompensated state of liver cirrhosis. So it has not been what leads to compensated cirrhosis to enter into decompensated stage. If we say about the mortality and prevalences of liver cirrhosis, it has been known cirrhosis because of hepatitis B has been the major cause of death and has been increasing over the year. So what is the state of compensated and decompensated state? It is very well known like people from compensated state is more prevalent in male as compared to the female and is found to be more of compensated cases than decompensated state. So what is liver regeneration? We all are aware of that liver have the capability of regenerating itself. So whenever there is an injury to the liver, it follows three types of regeneration. First, the tier one, which is a self-replication of the mature parenchymal cells like hepatocyte divide and proliferate for the lost hepatocyte. The other one is the HPC mediated regeneration, which is the hepatic progenitor cells mediated regeneration, where it the hepatic progenitor either divide into biliary epithelial cells, hepatocytes, or other cholinergic differentiation of the cells. The third one, or the tier 3, is the bone marrow mediated regeneration. So when we say the bone marrow is involved in the liver regeneration, it provides different type of the cells like hematopoietic stem cell, mesenchymal stem cell, epithelial progenitor cells, which help the injured liver to clear the damage, provide the paracrine support for parenchymal and non-parenchymal cell regeneration. It helps in the rescue of the lost non-parenchymal cell mass and also involve the remodeling of extracellular matrix, thereby allowing the liver to enter into the regenerating state. But whenever we provide whole bone marrow therapy in cirrhotic patients, the effect is only transient and are only limited to the patient with the optimal bone marrow reserve. So bone marrow is not like fully found to be functional in cirrhotic cases, which we found in one of our previous studies, where we have shown that with the severity of the disease, like being categorized by the MELD score, and rise in the MELD score tell us about the severity of the cirrhosis. So, with the severity of the cirrhosis, the bone marrow microenvironment, mostly the CD34 positive hematopoietic stem cells, nestin positive MSC are severely affected in cirrhosis condition. So, based on our data, we raise two questions. So, question one is what happened during the transition phase from compensated to decompensated state, and is the liver failure is the cause or consequence of bone marrow failure has not been known till now. So, we aim to understand the relation between the bone marrow failure and liver regeneration in chronic liver injury. For this, we use T57BL6 mice and induced cirrhosis via a successive dose of CCL4, and post 3 weeks of chronic liver injury, we sacrifice the mice for biochemical studies. Like we first check for the progressive liver injury based on the AST, ALT. These are the marker for the liver injury. Total bilirubin tell us about how much of the liver is injured during the process. So we found that week 10 to week 15, there's a maximum rise in the progressive injury as compared to week 3 and week 6 of chronic liver injury. So in literature, or it has been said that during cirrhosis progression to hepatic decompensation, the main reason is the portal hypertension. So when it's looked in the portal pressure of these mice, and it is found that from week 10 to week 15, there's a maximum rise in portal hypertension as compared to the healthy. This portal hypertension being known for the development of the ascites. So we look for the ascitic level in such mice and measured through SAG value, which is the serum ascites albumin gradient. And more than one of SAG is being known for the reason of rising ascites due to portal hypertension. Thus, our model showed liver failure and development of non-acute decompensation by week 15 of chronic liver injury. Next, we looked into the histopathological changes with the progressive injury. As people earlier used to say that fibrosis is the reason for rise in portal pressure, thereby ascites. So first, we compare the fibrosis through different stainings like mesenteric, serous red, collagen 1, and alpha SMA for myofibroblasts. And we found that the level of fibrosis increases from week 3 to week 10. Interestingly, from week 10 to week 15, the fibrosis remains same. So what could be the reason? So we looked into the change in inflammation through HNE staining, and it is found that from week 10 to week 15, there is rise in inflammation, like there are most of the infiltrating cells present in the liver. Thus, fibrosis remains constant while inflammation increases from week 10 to week 15 of chronic injury, which may be the reason for rise in portal pressure and leading to ascites, the features of hepatic decompensation. So, the next we check liver proliferation with the hepatocyte death, because liver has the ability, whenever there is a hepatocyte loss, the hepatocyte regenerate to a new one. So we did tunnel pulse staining to know the cell death, and it is found that from week 6 to week 10, the majority of the cell death remain to the portal area or the vasculation, and those are mostly of the immune cell. But at week 15 of chronic liver injury, there is a massive hepatocyte death, both in the cytoplasmic and in near the vasculature. Thus, there is a progressive increase in hepatocyte death during the transitions from week 10 to week 15. Then we looked into the hepatocytes proliferation with the severity of the disease, because the lost cell is always replaced by the new cell. And we found that from week 6 to week 10, there is 73% fold increase in PCNA positive. PCNA stands for the proliferative cell nuclear antigen, and basically used to stain all the dividing cells. So we calculated PCNA positive for the hepatocyte. Interestingly, again, from week 10 to week 15, there is a massive decline in hepatocytes proliferation. That is, a loss of hepatocytes proliferation will increase hepatic death. So what we found, like from healthy liver to compensated state, which is like reversible, there is a rise in the portal pressure, increase in fibrosis, increase in inflammation. But whenever the compensated cirrhosis progresses as decompensated cirrhosis, the portal pressure increases to much more fold with the development of the ascites. The fibrosis remains the same, the inflammation rises where the massive hepatocyte death has been found with the loss of the regeneration. Therefore, the liver failure is the failure of liver regeneration. So, when we are saying like bone marrow has been defective in cirrhotic cases, we looked into the bone marrow hematopoietic response during disease progression. So, we checked for the HSPCs, which are the hematopoietic stem cell progenitor cells, and stained with LSK, that is a lymph negative, SCA1 positive, and c positive, and is found to be maximum at week 15 of chronic liver injury as compared to week 3, and compared with the vehicle control. So when we say LSK, LSK is categorized as LTHSC, STHSC, and MPP. LT stands for the long-term hematopoietic stem cell progenitor and are the main progenitor population of the hematopoietic stem cell, which give rise to the short-term hematopoietic stem cell, which remain for a short interval of time, giving rise to most of the myeloid multiple progenitor. This MPP is for the divide to give rise to either myeloid or lymphoid progenitor. So on this scale, we dissected LSK into MPPs and LTHSC and found that it is the MPPs which are responsible for increasing LSK percentage, whereas the long-term hematopoietic stem cells found to be decline at week 6 to week 10 and then week 10 to week 15. That is, loss of LTHSC occur prior to the liver regeneration failure. It has also been found in many literature, like bone marrow is majorly in bone marrow. Nestin positive MSC are majorly responsible for supporting the MSCs, HSCs, and MSC form a supportive role for hematopoietic stem cell renewable and maintenance. So we looked into the nestin positive MSC cell in these set of mice, and it was found that from week 3 to week 6, though the nestin positive MSC rises, their stemness declined from week 3 to week 6. So loss of nestin positive MSC arises much ahead than bone marrow LTHSC population. So we address, can we restore the bone marrow hematopoietic stem cell reserve so that it can rescue the cirrhotic bone marrow HSC? For this, we did intrafemoral bone marrow infusion of healthy bone marrow cells from GFP mice and sacrifice mice at different time interval. And it was found that the LSK population goes to near about healthy at day 11 and 21 as compared to the vehicle control. We also checked for the LTHSC population. It was found that intrafemoral bone marrow infusion rescues the native LTHSC population as compared to the control set of mice, while the donor population gave the transient effect and declines and reached to zero at day 21 of transplantation. To check the mechanism, we did the mass spec or proteomics analysis of these LSK cells isolated at 24-hour and day 11 of chronic injury, and it was found that in BMT set of mice from 24 to day 11, there is a down regulation of apoptosis, cells proliferation, whereas there is an upregulation of glycolytic process. Glycolysis is basically the majorly required for hematopoietic stem cells stemness and their maintenance, where the cell-cell communication is found to be upregulated in such cases. That is, dampening of the inflammatory response and enhanced glycolysis in HSC might have helped in self-renewal of native LTHSC post-BMT. So we next again looked into the nestin positive MSC during the process, and it was found that from 24 hours there is maximum number of CFU being found in BMT set as compared to healthy. However, at day 11, the number of CFU reduces and reaches to healthy. There's a transient establishment of MSC supportive niche, which might have contributed to increase in repopulation of native LTHSC post BMT. So what are the changes in liver? When we are saying the bone marrow, HSC and MSC are getting restored, is there been any change with the liver? So we first looked into AST, ALT, and total bilirubin to compare the liver injury, and it is found to be down at day 11 of post BMT as compared to control set. The fibrosis decline, where the hepatocyte proliferation found to be increased in such cases. That is, there is an accelerated regression of fibrosis in liver regeneration. Similarly, we did the proteomics analysis of liver tissue, and it was found that most of the metabolism being increased at day 11 post BMT, whereas we majorly found difference in the innate immune function in both the cases. So we looked into the innate immune response of the liver, that is the kapha cell activity, and it is found that The F4/80, which is used to stain through IHC for liver macrophages, found to be enhanced in these. So before going into the BMT, we first looked at the F4/80 expression in disease set in the progressive model, and the innate immune function found to be compromised with the severity of the disease, whereas their phagocytic activity declined from week 6 to week 15 of chronic liver injury. However, this expression is again preserved in BMT set of mice as compared to the control set of mice. That is, restoring bone marrow reserve augmented the innate immune function in cirrhosis. So we next address, can bone marrow infusion, that is an intrafemoral infusion, can halt the onset of early decompensation? To address this question, we first look into the changes in the bone liver. Like first, like after week 12 of chronic liver injury, we give intrafemoral bone marrow infusion of approximately 4 million cells. And from day 0 to day 18, we again gave the CCL4, continued the CCL4 injury till 5 doses at 0.5 ml per kg of the body weight. And we sacrifice the mice wherever the ascites become visible in these set of mice, and measure their SAG value. These set of mice also showed that there is a decline in the liver injury following the AST, ALT, total bilirubin, and ammonia level in BMT as compared to the control. Again, we looked into the histopathological changes. There were reduction in fibrosis measured through serious red staining in BMT as compared to control. There were massive hepatocyte death in control set of mice who received CCL4 progressively till for 5 doses post week 12 of chronic liver injury, where the BMT animal showed no changes or no hepatic death. Similarly, there was more of the PCNA positive in BMT set of mice as compared to the control. That is, restoring bone reserve ameliorated the progression to decompensated cirrhosis. So, what is a systemic organ changes? Because whenever we say there is a decompensation, there is always a secondary organ dysfunction found in either in patient or in the mice. So we look the kidney changes. Kidney in a decompensated state of cirrhosis, the ATN, that is acute tubular necrosis, being more of like ATN is more occurred in such cases, and we measured this ATN through terminal positive staining and found to be maximum in control as compared to the BMT. Similarly, we did the creatinine. We analyzed the creatinine serum level, and it is found to be reduced in BMT as compared to control. Again, we did the HE for lungs, and the control set show most of the RBCs infiltration in lung section with more of the fibrosis as compared to the BMT set. So we concluded that there is a progressive loss of bone marrow hematopoietic reserve preceded the regeneration failure during the progression of chronic liver injury. Intra bone marrow infusion rejuvenated the bone marrow stem cell reserve. Intra-bone marrow infusion also augmented the regression of fibrosis, accelerated the liver regeneration, and prevented the early onset of decompensated cirrhosis. In summary, whenever we are saying there is a progressive liver injury, there is a loss of MSC occur much ahead than LT-HSC, which might be the reason for compensated state of liver to enter into the decompensated cirrhosis, which is categorized by the ascites, ammonia, increase in the portal pressure, and loss of liver regeneration. Whenever we do bone marrow rejuvenation through intra-bone marrow infusion, the glycolysis increases in these LSK, where the inflammation and apoptosis decline, whereas the liver showed the most of the OX4s and innate immune function with the regression of fibrosis and inflammation. Thank you. Okay. Hello.
Thank you, Dr. Nidhi, for your presence and presentation.
Okay. Thank you.
Does
Thank
anyone
you for
having
the
any
invitation.
queries? Does anyone having any queries? I hope there are no queries. Once again,
Thank you. Thank you for the
Dr.
invitation.
Nidhi, for your presence and presentation.
Thank you.
Thank you. Now let's move on to the next presentation from Dr. Mamata Banu Alice from University of Mysore, India. Hello, Dr. Mamata. Are you ready with your presentation?
Uh, yeah,
Hello, Dr. Mamata.
Hello, am I audible?
Yes, Dr. Mamata. Now I'm making as a presenter. Kindly click on the screen button to share your screen. Yes, Dr. Mamata, I have made you as a presenter. Please click on the screen button. Open the GoToMeetings app and click on the share button on your screen. Yeah, my camera screen on your GoToMeetings app.
Uh,
Yeah, your screen is shared. Yeah, your screen is shared. Can you open the PPT? Your PPT.
uh, is now PPT visible?
Again, your screen was on off mode. Kindly click on the share button on your GoToMeetings app. You'll get a pop-up windows. Kindly select your PPT that. Then you will able to share your screen clearly. Your screen is shared now. Yeah, your PPT is okay. Okay. Okay, you can open your PPT and make it as a full screen. If you are getting any toggle, please go. You can move the toggle side. Yeah, in full screen.
Is it visible now?
Mm. Yes, you can start your presentation. Is it visible? Perfect. You can start your presentation.
Okay. Good evening, everyone. I am Dr. Mamta Bhanu, working as Assistant Professor in University of Mysore. I would like to thank for the opportunity given to me by the Coalesce Infectious Disease Group. So my topic today is my presentation topic is anti-tuberculosis drug and mechanism of action. So tuberculosis, that is the most important communicable infectious disease in the world, caused by the Bacillus mycobacterium tuberculosis. Mycobacterium is intrinsically resistant to most antibiotics and grows more slowly than any other bacteria. So the cell wall of this Mycobacterium tuberculosis is made up of a lipid-rich polysaccharide, which are impermeable to many antibacterial agents. That is called a mycolic acid. So as a result of this poor penetration of drugs, they develop resistance and are termed as multi-drug resistance. So these are some of the anti-tuberculosis drug, and these drugs are classified based on the treatment mechanisms. So there are two types of drugs, that is we call the first line drugs and the second line drug. So the first line drug includes isoniazid, rifampicin, ethambutol, streptomycin. So all these are the first line of drugs which have a very mild effect. And the second line of drugs includes amikacin, amino salicylic acid, capreomycin, ciprofloxacin, levofloxacin, etc. So the first line of drugs, they only kill active bacteria important in the early stages of infection, but the second line of drug, they hinder the growth of the mycobacterium, and that strengthen the treatment in case of resistant bacteria. These are less efficient and generally more toxic than the first line of drugs. So this is have a very adverse effect on the patient. So there are these are the mechanism of the drugs. So the general mechanism is shown in the diagram. So this is the mycobacterium cell bacterial cell. So many of the antibiotics they work on the cell wall. They inhibit the cell wall synthesis like isoniazid, ethambutol, ethylamide, and cycloserine. So all these some of the drugs they works on cell inhibition of cell wall synthesis. So that directly affects the bacterial growth. And some antibiotics that is moxifloxacin that act on the DNA replication that stops the replication so that the bacteria will further stop growing. And some other antibiotics like streptomycin, amikacin, so kanamycin, all these acts on the translation machinery that is that inhibit the protein synthesis of the mycobacterium. So the overall inhibition of the bacterial infection. And some other antibiotics like amino salicylic acid that inhibits that the folic acid uptake to the bacteria, so which again affect the bacterial growth. And rifampicin antibiotic have a role in inhibiting the RNA synthesis, so that is also have a transcription machinery. And these are some of the mechanism. We'll go in detail. So the anti-tuberculosis drugs, taking up with the streptomycin. This is an antibiotic that is used to treat number of bacterial infections via the intravenous injection through vein or muscle. So this infections include like tuberculosis, Mycobacterium avium complex, and brucellosis, plague, and rat bite fever. So all those. So for active tuberculosis, it is often given together with the other antibiotics like isoniazid, rifampicin, and pyrazinamide. So this streptomycin works by inhibiting the protein synthesis. So it is an inhibitor of protein synthesis, that is a translation machinery. So how it inhibits is it inhibits the small 16S rRNA of the 30S subunit of the bacterial ribosome. So bacterial ribosome contains the 70S, 50S larger subunit and the 30S smaller subunit. So that goes and binds to the 60S RNA of the 30S subunits, and that by interfering the binding of the formyl methionine tRNA to the 30S subunits. So this lead to the coding misreading. So eventually the inhibition of protein synthesis and ultimately the microbial cell stops the synthesis. This is the diagram of the ribosomes and the mRNA, the translation process. So where we can see the interaction of the streptomycin in the 30S subunit. There is a recognition site for the streptomycin. So that blocks the 16S rRNA. So the misreading of the frame takes place so that the wrong protein codes and the overall process, the protein synthesis process is inhibited. So the next drug is the rifampicin, that is the antibiotic used to treat several types of mycobacterial infections, including Mycobacterium avium complex, leprosy, and in combination with other bacteria, antibacterial to treat latent or active tuberculosis. The PDB structure that is downloaded. And mechanism here is that inhibits the transcription, that is the RNA synthesis. So transcription is a cellular process during which RNA is synthesized using DNA as a template. RNA polymerase is the main enzyme that is involved in the transcription process. So this acts via the inhibition of DNA dependent RNA polymerase, that is an enzyme leading to the suppression of RNA synthesis. So if this transcription is blocked, obviously the cell is going to die, the mycobacterium. So in this way, the rifampicin stops the transcription process, and that inhibits the cell. So this is the DNA template and the RNA polymerase enzyme. That is where the rifampicin is going to bind and inhibit the RNA synthesis. So this is the aliphatic chain that is important for the biological effect, that is going to distort the shape of the enzyme. So if the enzyme shape is distorted, so the enzymes are very specific in nature. So if the shape is distorted, there is no receptors comes and binds to the enzymes. So hence the process gets halt. The next antibiotic we are discussing is isoniazid. So this is the antibacterial prescribed medicine, and that is approved by the Food and Drug Administration for the prevention and treatment of tuberculosis. Uh, uh, so this acts as a prodrug. So uh, prodrug is a medication or a compound that, after intake, is metabolized into pharmacologically an active drug. So instead of administering a drug directly, a corresponding prodrug can be used to improve how the drug is absorbed, distributed, metabolized, and excreted. So this mycobacterial catalase peroxidase, that is CATG, converts this isoniazide into an active metabolite. So a primary action of isoniazid is to inhibit the biosynthesis of mycolic acid. Mycolic acid is a long branched lipid that form the part of the mycobacterial cell wall. So it is a component of the cell wall. So this inhibits by inhibiting the cell wall synthesis, so which acts as a prodrug. So this is the cell wall of the mycobacterium, that is a lipid-rich cell wall that is called the mycolic acid. And this mycolic acid is composed of N-acetyl glucosamine and N-acetyl uramic acid, D glutamic acid, M diaphilic acid, and alanine, D alanine. So this mycolic acid synthesis will be stopped by the this prodrug. So the cell wall is inhibited. So if the cell wall is not synthesized, the bacteria will not survive. So this mycobacterium is going to die. So in this way, it halts the synthesis of mycobacterium. The next drug is the ethambutol. This is the synthetic water-soluble height-stable compound. This inhibits mycobacterial arabinosyl transferase, that is an enzyme. So this is the structure of the ethambutol from the PDB. So it is an this works by what inhibiting the enzyme. So it is an inhibitor of mycobacterial arabinosyl transferase. So that is encoded by EMBAD genes. So which are involved in the polymerization reaction of arabinoglycan. That is again an essential component of mycobacterial cell wall. So this again acts by inhibiting the cell wall synthesis. So by inhibiting the cell wall synthesis, this drug works. This is the cell wall, cell membrane, where we can see the genes EMBA and EMBB. So here it binds and stop the enzyme. So the enzyme reaction, uh, the enzyme, it acts as an enzyme inhibitor. So thus the cell wall synthesis is inhibited, and this way the drug works. The next drug is pyrazinamide. So this is pyrazine is used therapeutically as an anti-tuberculosis agent. The enzyme pyrazinamidase is mycobacteria cleaves off the amide portion of the molecule by producing pyrazoic acid. which is a bactericidal. So this is how it acts. Um, so and next is the amikacin. So amikacin, this is given as a in the intravenously as an injection. It is used to treat serious bacterial infections in many different parts of the body. So amikacin is a semi-synthetic aminoglycoside antibiotic that is um, derived from the kanamycin A. It is an active against a broad spectrum uh, gram-negative infection, gram-negative bacteria. This belongs to the class of the medicine known as aminoglycoside antibiotics. It works by killing bacteria or preventing their growth. So, since bacterial growth is remarkably rapid in body, drugs like amikacin have to act fast. It is to be used with precaution and as advised by the doctor. So the mechanism is again it is going to inhibit the transcription. So it is going to bind with the 30S ribosome translation. So the translation process is halted, the protein synthesis is inhibited with this drug. So this binds to the 30S bacterial ribosome subunit, resulting in interference with a reading of the genetic code and inhibition of protein synthesis. So, it ends its premature protein termination. So, and incorporation of incorrect amino acid. So, amikacin as well as the rest of the aminoglycosides are generally bactericidal and probably have an additional mechanism of action which has yet remained undetermined. Aminoglycosides demonstrate bacterial killing that is concentration dependent and also have a post antibiotic effect. So this has adverse effect on the kidney. So and this is also given in combination with the other drug, amino salicylic acid. So this is an antimicrobial agent used with the anti-tuberculosis drugs. So most often it is given with the isoniazid for the treatment of all the forms of active tuberculosis due to susceptible strains of tubercle bacilli. Amino, Amino-salicylic acid is a bacteriostatic, so against Mycobacterium tuberculosis, and this prevents the multiplying of bacteria without destroying them. This also inhibits the onset of bacterial resistance to streptomycin and isoniazid. So this mechanism of action is there are two types of mechanism that is responsible for the amino-salicylic acid, bacteriostatic action that is against Mycobacterium tuberculosis. So this amino-salicylic acid initially inhibits the folic acid synthesis. So without a potentiation of anti-folic compounds, the binding of the para-aminobenzoic acid to petridine synthetase acts as a first step in folic acid synthesis. So amino-salicylic acid binds with the petridine synthetase with greater affinity than para-aminobenzoic acid, effectively inhibiting the synthesis of folic acid. This is essential for the cell wall of bacteria. As bacteria are unable to use external sources of folic acid, cell growth and multiplication get slow down. And secondly, this amino salicylic acid may inhibit the synthesis of cell wall component mycobactin. This mycobactin is a component of the mycobacterium, so thus reducing ion uptake by Mycobacterium tuberculosis. So there's two types of mechanism is involved in this amino salicylic acid. One is first it inhibit the synthesis of the folic acid. So and then later on it inhibit the synthesis of a cell wall component, that is mycobactin. So and that reduces the ion uptake. So the next drug is the um, capreomycin. This is an aminoglycoside antibiotic used as an adjunct drug in tuberculosis. This is given along with other antibiotics, so like an adjunct. Cyclic peptide antibiotic. This is an cyclic peptide antibiotic similar to the biomycin. So, and this particular antibiotic is produced by the bacteria Streptomyces capreolus. So this is thought to inhibit the protein synthesis. So many antibiotics are against this mm, translation machinery. So that is going to bind with the 70S ribosomal unit. Capreomycin also binds to component in the bacterial cell, which results in the production of abnormal proteins. So these proteins that are necessary for the bacterial survival. So therefore, the abnormal proteins which kill the bacteria before the production of this abnormal proteins is ultimately fatal to the bacteria. So in this, how by inhibiting the translation machinery, that is going to act. So this is the drug. So this is how, like how amikacin, biomycin, and capreomycin, kanamycin all act by stopping the translation machinery. So this is the translation process. It comes and binds to the 70th subunit, the ribosomes, and that halts the protein synthesis. So the next drug we are discussing is ciprofloxacin. Ciprofloxacin is a second generation fluoroquinolone used to treat various susceptible bacterial infections. It is formulated for oral, intravenous, and intratympanic ophthalmic administration for a number of bacterial infections along with the mycobacterial infections. This inhibit by inhibiting the enzyme topoisomerase. So this topoisomerase is known as a DNA gyrase. So this inhibits the relaxation of the supercoiled DNA and promotes breakage of double-stranded DNA. Ciprofloxacin acts on bacterial topoisomerase 2, DNA gyrase, and topoisomerase 4. This ciprofloxacin targeting of the alpha subunits of the DNA gyrase that prevents it from supercoiling, the bacterial DNA that prevents the DNA replication. So this enzyme is involved in the replication process where the bacteria has to stop the supercoiling. So the next drug is clofazimine. So clofazimine is a rifanoside antimicrobial bacteria used to treat leprosy and also the TB. The clofazimine sold under the brand name Lamfrin, the medication, and used along with the rifampicin. This works by binding to the guanine basis of the bacterial DNA, so thereby blocking the template function of the DNA and inhibiting the bacterial proliferation. It also increases activity of bacterial phospholipase. So that is an enzyme phospholipase A2, leading to release the accumulation of lysophospholipid, so which are toxic and inhibit the bacterial proliferation. So this is going to block the guanine residues basis in the bacterial DNA. So hence is lethal to the bacterial proliferation. So this clofazimine that interact with the respiratory chain and interaction with phospholipids. So this reduce cyclic lysophospholipid interfering with the ATP production. So hence that is lethal to the bacterial proliferation and that inhibit the growth of bacteria. The next drug we are discussing is cycloserine. This is an analog of the amino acid D-alanine with a broad spectrum antibiotic and lysogenic activities. Cycloserine is a broad spectrum antibiotic used as a second line agent. This is an second line antibiotic for the treatment of drug resistant tuberculosis. So this is always used in combination with other tuberculosis agents because many of the drugs are not they doesn't work alone. They are always used in combination. And this D-cycloserine interferes with the bacterial cell wall synthesis, and this competitively inhibit the enzyme. Um, L-alanine racemase and D-alanine. So D-alanine ligase that is thereby impairing peptidoglycan inflammation necessary for bacterial cell wall synthesis. So this agent is bactericidal or bacteriostatic depending on its concentration at the infection site and the susceptibility of the organism. In addition, this cycloserine is an oxidatory amino acid and partial against at the glycan binding site for the NMDA receptor in the central nervous system. So binding to the central NMDA receptor, this may result in amelioration of neuropathic pain. So this cycloserine this inhibits the cell wall synthesis and the bacteria wouldn't survive. So these are the mechanism where it inhibits the two enzymes that is alanine enzyme hence so that is blocking the cell wall synthesis. These are the few drugs, anti-tuberculosis drug that are used. So in conclusion, the low concentration of anti-tuberculosis drug should be dealt with extreme caution as it may influence the pathogen's drug susceptibility and the short course treatment strategy for fighting TB. The anti-TB drugs could also serve as frequent adverse effects. So, female those with the previous history of ADRs to anti-tuberculosis drugs and Afghani patients should be considered as a high-risk group as per the survey. The new drug here urgently needed and with less toxicity, with no adverse effect. We need more anti-tuberculosis drugs. Uh, thank you. Thank you for your attention.
Thank you, Dr. Mamata, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Once again, thank you, Dr. Mamata, for your presence and presentation.
Thank you, ma'am. Thank you for your attention. Thank you for giving
Thank
me the
you.
opportunity.
Thank you very much. Now let's move on to the next presentation from Dr. Hamza Islam from Punjab Medical College, Pakistan. So, Dr. Hamza, are you ready with your presentation?
Okay, I am sharing.
Okay, Dr. Hamza, I'm making you as a presenter. Kindly click on the screen button to share your screen. I have made you as a presenter. Kindly click on the screen button to share your screen. Your screen is shared. Can you please open your PPT and start your presentation, please?
Uh, is my screen sharing or not?
Yeah, your screen is sharing, but please open your PPT and start your presentation. Your screen is shared. Can you please open your PPT from here now?
I am opening it. Is it visible?
No, your GoToMeeting app is visible. Kindly select your PPT while you're sharing your screen. When you click on the share button, you will get different apps to select your PPT. Then select your PPT over there and start your presentation. You'll get a pop-up window when you click on the share button to share your screen. There you select your PPT app.
There is not an option for
Because when
sharing the
you're
PPT.
no one stop sharing and click on the share, you'll get a window. There you have to select your PPT. Choose your app there.
There is no option for sharing it. The PPT
Your
is
screen is shared. Your screen is shared, but you're not opening the PPT. Your screen is shared. We are able to see your screen, but you are in a GoToMeeting app.
the screen is shared, but the slide is there is no option to open the slide.
Because you are selecting the GoToMeeting app to share, in that you need to select the whole entire your device. Then only you can open the PPT and it will be visible to us.
Let me check from here.
If possible, kindly, yeah. Now open your PPT, please. Open your PPT.
Yes,
Open your PPT now.
I have opened it.
Yeah, it's opening. Hope we see that. Yeah, it is opened. Can you make it to the full screen and start your presentation now? Make it to the full screen and start your presentation now. You can start. We are able to see your screen and we are able to hear your voice.
Okay.
Perfect. You can start.
So my topic for presentation is multiple myeloma and renal failure, mechanism, diagnosis, and management. So the abstract of the study is that the multiple myeloma, it is the second most common hematological malignancy that involves monoclonal immunoglobulin producing plasma cells. Renal failure is one of the most common and most serious complications of multiple myeloma that can be caused either by excess immunoglobulins that are nephrotoxic or some other causes like hypercalcemia infections. So in this review article, we have discussed the pathogenesis and described the different diagnostic tools to diagnose renal failure in multiple myeloma and explain different treatment modalities to treat renal failure in multiple myeloma. So actually, we studied different studies from the last 10 years on PubMed, and we arranged the studies in a review article where we have seen the different pathogenesis and the treatments with renal failure and the multiple myeloma. So introduction and the background of the study is the multiple myeloma is a hematologic malignancy that is characterized by the pernicious proliferation of monoclonal plasma cells that destroy the bone marrow microenvironment and results in overproduction of monoclonal immunoglobulins, immunodeficiency, and osteoclast hyperactivation. After non-Hodgkin lymphoma, multiple myeloma is the second most common hematological malignancy, and it contributed to around 15% of hematologic malignancies diagnosed in 2010. Multiple myeloma is more common in men than in women, and the incidence is twice as high in African Americans as in Caucasians. So multiple myeloma is usually a disease of older population, with 65 years being the median age for diagnosis, with less than 3% of patients presenting earlier than 40 years. The potential risk factors for developing multiple myeloma are obesity, ionizing radiation exposure, chronic antigen stimulation, genetics, and environmental exposures like certain occupations, farming and agriculture, genetic mutations like with the chromosomes between 4th and 14th chromosome translocation, and between 14 and 16, 14 and 20 chromosome translocation, and deletion on the 17 chromosome and gain on one chromosome number 1 Q or P53 mutation are associated with development of high-risk multiple myeloma. It is a multi-step process that involves the initial formation of a plasma cell clone and then malignant transformation of that precursor into plasma cell myeloma that is thought to be the final malignant stage of the disease process, which starts from a relatively benign disease called monoclonal gammopathy of undetermined significance. The disease presents with anemia, recurrent infections, renal insufficiency, osteolytic bone lesions, and hypercalcemia. So multiple myeloma is suspected when the serum paraprotein rises above 30 gram per liter on serum electrophoresis and is confirmed by the bone marrow plasmacytosis of more than 10% on bone marrow biopsy. Treatment of multiple myeloma includes chemotherapy, hematopoietic stem cell transplantation, and most commonly used classes of drugs are alkylating agents, melphalan and cyclophosphamide, proteasome inhibitors, bortezomib, carfilzomib, immunomodulatory drugs, thalidomide, lenalidomide, and corticosteroids, dexamethasone, and prednisolone. Multiple myeloma is a multifaceted disease, and about 25% to 75% of patients of multiple myeloma develop renal failure from the disease itself or other unrelated causes. Renal failure was the second most common cause of death among the patients of multiple myeloma before the era of unlimited therapy. This review article is going to explore the pathogenic relationship between multiple myeloma and renal failure, with an emphasis on the diagnosis and management options for the same. The pathogenic relationship between multiple myeloma and renal failure. So this is a diagram where it is shown that multiple myeloma is going to damage the kidney tubules and causing interstitial fibrosis and tubular rupture. Multiple myeloma is going to cause malignant transformation of monoclonal plasma cell and excess serum free light chain production and filtration through glomerulus into the proximal convoluted tubule. That is going to causes excess endocytosis of light chains in proximal convoluted tubule, and it is going to create NF-κB and mitogen activate kinase that further initiates the inflammatory cytokines like interleukin 6, interleukin A, TNF alpha, and TGF beta, and transforming factor beta metalloproteinases that's going to cause interstitial fibrosis. So on the second side, on the right side, we see that excess serum free light chain production and filtration to glomerulus into the proximal convoluted tubule causes the endocytosis capacity of the proximal convoluted tubule gets overwhelmed, light chains damage the proximal convoluted tubule and causes apoptosis and necrosis of these tubules. And on the other hand, it also causes it also reaches to the distal convoluted tubule of these nephrons and bind to the TAM-Horsfall protein, which causes the hard waxy cast formations seen on the biopsies, and tubular obstruction reduces
Hello, Dr. Jean. Hello, Dr. Hamza. Are you there? I hope there is a technical issue from Dr. Hamza. Then now, meanwhile, we'll move to the next presentation. The next presenter is Dr. Sara Amari from Kadi Ayar University, Morocco. Hello, Dr. Amari. Hello, Dr. Amari Sara. Are you ready with the presentation?
Hello, Clara. I'm here.
Yeah, thank you, doctor. Now I'm making you as a presenter. Kindly click on the screen button to share your screen.
Okay.
I have made you as a presenter.
1 minute, please.
Okay. Yes, your screen is shared.
Okay, can I start?
Yeah, you can start your presentation.
Okay, thank you so much. Hello, everybody. It is a pleasure for me to be here presenting my work entitled Pneumococcal Triads and Antibiotic Resistance Among Healthy Preschool Children in Marrakesh, Morocco. For this, I will proceed with the following outline
introduction, subjects and methods, results and distribution, and finally a conclusion. Firstly, the bacteria was named as Diplococcus pneumoniae and then reclassified as Streptococcus pneumoniae due to its similarities to Streptococcus genus. It was differentiated from other streptococci by its morphology, the presence of a specific polysaccharide capsule, her solubility to dubin, and her sensitivity to optocin. Worldwide, Streptococcus pneumoniae is known to be the causative agents of many serious diseases, such as pneumonia, bacteremia, meningitis, and middle ear infections. How does Streptococcus pneumoniae affect the body? The main way people spread Streptococcus pneumoniae into others is through direct contact, person to person, via respiratory droplets, or by autoinoculation in a person carrying the bacteria, and this bacteria can spread to other organs and cause otitis media, pneumonia, meningitis, and bacteremia. Antigenic structure. Due to his specific polysaccharide capsule, there is actually 101 distinct capsular types, and the 10D and 24F were the last one discovered. Virulence factors. Streptococcus pneumoniae had a multiple type of virulence factors that promote adherence, invasion of host tissues, and allow it to escape host immunity, including the polysaccharide capsule, tetrapeptidoglycan cell wall, pneumolysine, autolysine, and many surface proteins, PD, immunoglobulin A1, and hydrogen peroxide. The objectives of this study is firstly to determine the colonization rate of Streptococcus pneumoniae among healthy children under 5, also to identify the prevalence of serotypes circulating in mortal children after introduction of vaccination, and to evaluate the antibiotic resistance of this bacterium against different drugs. Subjects and methods. It was a prospective study conducted between November 2020 and February 2022. At the inclusion criteria, we only included healthy children aged between 6 months and 5 years, and we excluded all children that have an antibiotherapy during the last 7 days. Consentment containing information about social demographics and vaccination status and antibiotic consumption was completed and signed by parents. For method, we firstly do a nasopharyngeal specimen using a sterilized swab. Then the specimen was treated in CNA agar supplemented with 5% of blood and incubated at 37 degrees for overnight. After, the identification of the bacteria was performed following the standard microbiological protocol, including alpha hemolysis, gram staining, optician sensibility, and base solubility for bacteria that show resistance to optocin. And then we do an antibiogram for different type of antibiotics, And also we do a thiotropium using agglutination test, relapse pneumo test, and then a DNA extraction using triagent kit and serotyping following the introduction, the deadlines and deadlines of CDC by real-time polymerase chain and multiplex PCR endpoints. Results. Of the 645% children included in this study, 24% were aged under years old, 43% were aged between 1 and 2 years old, and 33% were older than 24 months. Concerning the genders, 54% were boys and 46% were girls. 56% were breastfed for at least 2 years, and 80% were children that haven't reached a daycare before, and 55% were children having siblings. Antibiotherapy and vaccination. Among the participants, 28% had received an antibiotic treatment during the last 3 months, and all children have received at least 2 doses of the vaccine during the enrollment. Pneumococcal triage and serotypes. Of the 345 children included in this study, 35%, which means 228, were carriers of Streptococcus pneumoniae in their nose. And we have identified 29 distinct cell group types were found among 149 Streptococcus strains. 8 strains were non-treatable but CPSA positive. Serotype 14 were the most one detected, and it represents approximately 70% of all the detected serotype, followed by serotype 3 and serotype 50F, which represent approximately 5% each, and then serotype 11 and 23B, which represent approximately 4% each. PTB vaccination, which are colors in blue, represent 22%, and non-vaccine serotype represent 58% approximately. Antibiotic resistance. The non-susceptibility of the Streptococcus pneumoniae was tested against 11 different antibiotics. Penicillin, concerning the penicillin, 59% of pneumococcal strain were non-susceptible to penicillin, 26% non-susceptible to amoxicillin, and 20 are resistant to ceftriaxone. Resistance rate to clotrimazole was 31% approximately, 20% for tetracycline, 10% for vancomycin, and 18% for erythromycin. All strains were susceptible to chloramphenicol, vancomycin, gentamicin, and norfloxacin. Multi-drug resistance was detected among 27% of pneumococcal strains. Discussion. In study conducted in Morocco before the introduction of pneumococcal conjugate vaccine, the carriage rate was between 14 and 46. Our study was the first one to determine the triage rate of Streptococcus pneumoniae in healthy children, and it represents 35%. Our results was consistent with other studies conducted on healthy preschool children after introduction of pneumococcal vaccination, proving that the prevalence of Streptococcus pneumoniae nasopharyngeal carriage had decreased over last years. Serotype distribution, as PCV or pneumococcal conjugate vaccine has been given to children since 2012 in Morocco, it is expected to induce a remarkable decline in the rate of serotype responsible for triage and disease. Our results showed that vaccine serotype traveled 22%. Similar to our study, many results showed that vaccine serotype, specifically 10-valent serotype, had decreased after introduction of vaccination. Also, inversely, we showed that non-vaccine serotype have increased significantly. This change in the distribution of serotype had been explained by the phenomenon of serotype replacement, which can be defined as a partial replacement by non-vaccine serotype. This study has showed an effect of vaccination against vaccine serotype causing invasive infection in children. Also, the impact of on the national invasive infection incidence varied internationally due to serotype replacement. This phenomenon can be explained by two reasons. The first one is the expansion of non-vaccine type lineage to partly fill the niche vacated by vaccine type lineages. And the second one is within lineage expansion of non-vaccine serotype, which can explain it as a concomitant increase in non-vaccine serotype and decrease in vaccine serotype within a lineage of pneumococcal vaccine after pneumococcal conjugate vaccine introduction, usually through expansion of existing non-vaccine type components rather than contemporaneous capsular switching. Also, this study proved that maybe the serotype replacement could erode the benefits of the pneumococcal vaccine in the long term. Concerning the antibiotic resistance, generally several studies have reported an increase in antibiotic resistance due to self-medication and lack of guidelines for regulating the use of antibiotics. As we see here in this figure, Streptococcus pneumoniae is the fourth bacteria showing high rate of resistance. Beta-lactams and macrolide are the treatment of choice for pneumococcal infection, which may explain the high resistance rate against this type of drugs. Also, multi-drug resistance remains as a serious problem since this prevalence is increasing over the years. Conclusion, this study identified a significant decline in pneumococcal carriage and an increase of non-vaccine serotype strain in healthy children. Antimicrobial resistance was observed to several commonly used antimicrobial including beta-lactams and macrolide. Continued follow-up show an interest in controlling the epidemiology of pneumococcal triage and resistance in Morocco. Thank you so much. Thank you so much.
Thank you, Dr. Sarah, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Once again, thank you, Dr. Sarah Amari, for your presence and presentation. Now let's move on to the next presentation. The next presentation is from Dr. Rabia Islam from Punjab Medical College, Pakistan. Hello, Dr. Rabia, are you ready with your presentation? Hello, Dr. Rabia Islam.
Hello. Hello, are
Yes, Dr.
you hearing me?
Rabia. Yeah, you're audible. I'm making you as a presenter. Can you click on the screen button to share your screen?
Yes.
Yeah, please open your PPT. Please open your PPT.
Yes, I am opening it. Mhm. Is it visible?
Yeah, your PPT is visible. Can you make it as a full screen mode and start your presentation now?
Okay. Thank you so much. Um, Hello everyone. My name is Dr. Rabia Islam, and I graduated from Punjab Medical College. Currently I'm working as a medical officer in Allied Hospital. And my topic of presentation is cirrhosis and coagulopathy, and the mechanism of hemostasis changes in the liver failure and their management. So the abstract of the article is that cirrhosis is an end-stage liver disease that can cause changes in any component of the hemostasis system. So the coagulation disorders are caused by the various factors, including decreased clotting and inhibitory factor synthesis.
Hello, Dr. Rabia. Hello, Dr. Rabia. Dr. Rabia. Hello, Dr. Rabia, making you as a presenter. Kindly click on the screen button to share your screen. Okay, you can continue with the presentation. Hello, Dr. Rabia, you're not. Can you please switch on your mic, please? Okay, I think there's a technical issue from Dr. Rabia's end. Meanwhile, we'll move to the next presentation. The next presenter is Dr. Mauna Gliddi from University of Fax, Tunisia. Hello, Dr. Mauna, are you ready with your presentation? Hello, Dr. Mauna. Gliddi Mauna. Can you please switch on your mic? Okay, Doctor, kindly share your screen. Hamza, we have made you as a presenter. Kindly please open your PPT and start your presentation.
Okay, is it visible? Hello, is it visible?
Your screen is audible. Your screen is visible, and your voice is audible.
Okay. So the abstract of the study that I was previously, the topic was the multiple myeloma and renal failure, mechanism, diagnosis, and management. The abstract was the multiple myeloma is the second most common hematological malignancy that involves monoclonal immunoglobulin producing plasma cells. Renal failure is one of the most common and most serious complications of multiple myeloma that can be caused either by excess immunoglobulins that are nephrotoxic or some other causes like hypercalcemia, infections. So in this review article, we have discussed the pathogenesis of renal failure in multiple myeloma and described the different diagnostic tools to diagnose renal failure in multiple myeloma and explain different treatment modalities to treat renal failure in multiple myeloma. We have studied from about 10 to 15 years previous studies and the review article from the PubMed cited studies. So introduction and background. Multiple myeloma is a hematologic malignancy characterized by the pernicious proliferation of monoclonal plasma cells that destroy the bone marrow microenvironment and result in overproduction of immunoglobulins, immunodeficiency, and osteoclast hyperactivation. After the non-Hodgkin lymphoma, multiple myeloma is the second most common hematologic malignancy, and it contributed to around 15% of hematologic malignancy diagnosed in 2010. Multiple myeloma is more common in men than in women, and the incidence is twice as high in African Americans as in Caucasians. So, multiple myeloma is usually a disease of the older population, with 65 years being the median age for diagnosis, with less than 3% of patients presenting earlier than 40 years. The potential risk factors for developing multiple myeloma are obesity, ionizing radiation exposure, chronic antigen stimulation, genetics, environmental exposures like certain occupations, farming, agriculture, and genetic mutations like translocation between 4 and 14 chromosome, and between 14 and 16 translocation, and between 14 and 20 translocation, and deletion on the 17 chromosome and gain on one chromosome Q or P53 mutation are associated with the development of high-risk multiple myeloma. It is a multi-step process that involves the initial formation of a plasma cell clone and then malignant transformation of that precursor into plasma cell myeloma that is thought to be the final malignant stage of the disease process, which starts from a relatively benign disease called monoclonal gammopathy of undetermined significance. The disease presents with anemia, recurrent infections, renal insufficiency, osteolytic bone lesions, and hypercalcemia. And multiple myeloma is suspected when the serum paraprotein rises above 30 gram per liter on serum electrophoresis and is confirmed by a bone marrow plasmacytosis of more than 10% on bone marrow biopsy. Treatment of multiple myeloma includes chemotherapy and hematopoietic stem cell transplantation, and most commonly used classification of drugs are alkylating agents, melphalan and cyclophosphamide, proteasome inhibitors, proteasomib, and carfilzomib, immunomodulatory drugs like thalidomide, lenalidomide, and corticosteroids, dexamethasone, and prednisolone. Multiple myeloma is a multifaceted disease, and about 25 to 75% of patients of multiple myeloma develop renal failure from the disease itself or other unrelated causes. Renal failure was the second most common cause of death after infection among the patients of multiple myeloma before the era of unlimited access to dialysis. So this review article aims to explore the pathogenic relationship between multiple myeloma and renal failure with an emphasis on the diagnosis and management option. Am I audible?
Yeah, Dr. Hamza, you're audible. Can you please switch to any other device because we are unable to access your device? There's a lot of disturbance from your device.
Is not my screen shared?
No, your screen is not shared, and I think you have a network issue, so we are unable to see your presentation clearly. Continue with the presentation.
Yes, I am continuing from there. Okay, so we are discussing pathogenic relationship between multiple myeloma and renal failure. Multiple myeloma causes malignant transformation of monoclonal plasma cells, which is going to cause excess serum free light chain production and filtration through glomerulus into the proximal convoluted tubule. So what is it is going to cause in proximal convoluted tubule is the infection, inflammation, and release several cytokines like interleukin 6, interleukin 8, TNF-alpha, TGF-beta, metalloproteinase, NF-κB, mitogen-activated kinases, and all going to damage this proximal convoluted tubule that causes interstitial fibrosis in the nephrons. On the right side, we see that these free light chains are also going to cause the endocytosis capacity of proximal convoluted. It gets overwhelmed and it causes damage to the proximal convoluted tubule and causes apoptosis and necrosis. While passing from proximal convoluted tubule to the distal convoluted tubule, it also binds to the TAM hotspot protein and it causes hard cast formations, tubular obstruction, reduction of heart, and reduction in interstitial blood flow, which overall causes tubular rupture. So, diagnosis of serum protein and 24-hour urine protein lactophoresis immunofixation have been used to diagnose and monitor disease. However, these tests are not always reported promptly, and in a patient with oliguria and renal failure, 24-hour urine specimen is often difficult to obtain. Furthermore, since the para-protein band contains a complete immunoglobulin made up of two heavy chains associated with two light chains, so in light chain only multiple myeloma with renal failure and non-secretory disease, these tests are not helpful. So the serum light chain assay is a same-day analysis and it helps with the reclassification of non-secretory multiple myeloma owing to its ability to identify previously hidden determinants of light chain. So serum-free light chain assay carries prognostic value. For example, high serum-free light chain levels at baseline indicate more aggressive disease and therefore poorer prognosis. And this assay, along with the serum protein electrophoresis and immunofixation, can accurately diagnose all myeloma cases without the need for urine collection. So B2 microglobulin B2M is the light chain of the major histocompatibility complex class 1 that is expressed on the surface of most nucleated cells. Identification of serum B2M is correlated with the multiple myeloma tumor load, and the level more than 6 mg per liter indicates poor prognosis. Renal biopsy should be considered early on the course of the disease, particularly when the serum creatinine rises above 30% of normal, since it can be of great diagnostic and prognostic value. For example, it is the renal histology that provides the initial diagnosis of multiple myeloma in a patient presenting with renal failure, and several histological hallmarks like degree of the renal fibrosis strongly reflect the possibility of renal recovery. So salient features on the biopsy of helped to know the treatment response, for instance, progression of signs of chronic damage like sclerosed glomerulus, interstitial fibrosis, and edema that is going to change in intertubular cast numbers and so on. So management, general measures. So renal failure in multiple myeloma is a medical emergency. Therefore, in this setting, various potential mechanisms of renal failure should be addressed simultaneously. NSAIDs, contrast dyes, loop diuretics, furosemide, aminoglycosides, angiotensin-converting enzyme inhibitors, and angiotensin II receptor inhibitors and other nephrotoxic agents should be avoided. Hydration, along with urine alkalinization, slightly decreases the concentration of the light chain and increases their solubility. Chemotherapy for multiple myeloma should be started as soon as possible with the drugs that are not excreted through kidney. Hypercalcemia should be treated with aggressive hydration along with calcitonin, and bisphosphonates can be initiated once the renal failure improves. Other one, if the general measures are done, the other thing is renal replacement therapy in cases where hydration is not tolerated, as well as cases where no improvement is found despite taking all the aforementioned general measures. Renal replacement therapy or dialysis may be needed. 28% of dialysis requiring multiple myeloma patients receive hemodialysis, whereas 12 patients have peritoneal dialysis, and although both are equally effective, the latter can increase the risk of bacterial peritonitis with long-term use. Hemodialysis should be considered as an effective treatment method in serious complications of hypercalcemia like confusion, cardiac arrhythmias, as well as clinically significant tumor lysis syndrome refractory to rasburicase. Plasmapheresis: only 25% of total free light chains can be removed by plasma exchange over a 3-week period. In addition, within a few hours after each pheresis session, rapid plasma refill occurs. That is why the benefit of adding plasma exchange to chemotherapies in improving GFR, dialysis dependence, or death is quite uncertain. However, in patients who experience a rapid decline in free light chain levels, renal outcomes are improved. In a study conducted by Leong et al., patients who had 50% or more fall in serum-free light chain recovered from dialysis. Plasma exchange has a clear indication in hyperviscosity of plasma, usually seen with IgG3, IgM, and IgA myeloma. Chemotherapy: conventional chemotherapeutic regimens to treat multiple myeloma with renal failure are vincristine, adriamycin, and dexamethasone. Or the other regimen is vincristine, cyclophosphamide, melphalan, and prednisone. Over the past decade, substantial improvement has been seen in treating multiple myeloma patients with renal failure with the invention and usage of certain novel drugs like proteasome inhibitors, bortezomib, and thalidomide and lenalidomide, which have demonstrated positive responses both in the first-line treatment and relapse cases of multiple myeloma. Bortezomib, a potent boronate peptide and the reversible proteasome inhibitor, is considered to be an important therapeutic step forward in the treatment of multiple myeloma. So these are the studies about different chemotherapeutic drugs for the treatment of multiple myeloma with renal failure. So these studies conducted in different years by different scientists, and we have seen that Like the study Chan Khan et al. In the 2007, 24 multiple myeloma patients with dialysis-dependent advanced renal failure received bortezomib or bortezomib-based combination therapy. The result of this study, that overall result is that 75%, and the 4 patients recovered from dialysis. Um, am I audible? Am I audible? Am I audible?
Yeah, you're audible.
Okay, so the conclusion of this study by this Chan Khan et al. Is that a bortezomib or bortezomib-based regimen can be used in dialysis-dependent multiple myeloma patients with manageable toxicities. So another study in 2011 by Leal et al. 59 patients with various degrees of renal insufficiency with escalating doses of bortezomib, like different doses 0.71 and 1.3 milligram doses were adjusted, and the results were found that highest doses of bortezomib was well tolerated among all the patients. Toxicities were mild. No significant difference in bortezomib clearance regardless of creatinine clearance. So the conclusion found is that no dose reduction of bortezomib is necessary in multiple myeloma patients with renal dysfunction. And at all in 2007, 30 patients. Is the screen sharing? Hello?
Hello, Dr. Hamza.
Yes, is the
Hello,
screen visible?
doctor. Yeah, your screen is visible.
Okay. So
Yeah, you can continue.
okay,
You can continue with
another
your
study,
presentation.
yes, another study by the Chen et al. In 2007, 30 patients were enrolled with different renal function statuses and based on creatinine clearance were given a single 25 milligram dose of lenalidomide. So the result found was that the mean urinary recovery of unchanged lenalidomide declined with creatinine clearance value. And the conclusion of the study is lenalidomide dose reduction should be considered for patients with creatinine clearance less than 50 milliliter per minute. And another study in 2010 by Rousseau et al. 1996 patients of multiple myeloma with dialysis-dependent and renal insufficiency were randomly treated and they are allotted different groups: Group A, Group B, and Group C. Group A includes conventional chemotherapy patients, and Group B with lenalidomide, and Group C with a bortezomib-based regimen. And the conclusion of the study is that the bortezomib-based regimen may be the preferred treatment for newly diagnosed multiple myeloma patients with renal insufficiency. So all of these studies in the different years concluded that in the early cases, bortezomib is effective, and in those cases with creatinine clearance less than 50 millimeter per minute, lenalidomide, that another chemotherapeutic agent is considered. If all these therapies fail, then the last option is renal transplantation. Particularly patients with Myeloma-associated renal failure achieve a sustained complete hematologic response but still remain dialysis dependent, and these patients are considered as renal transplant candidates regardless of whether hematopoietic stem cell transfer is performed. However, creatinine has to be achieved at least 3 years before renal transplantation, otherwise relapse can occur within 40 months, and the pre-transplant counseling should be done, addressing the risk of kidney transplant that include multiple myeloma relapse and disease progression, possibly as a result of the effects of immunosuppression, monoclonal immunoglobulin-mediated graft dysfunction, and infection. So the conclusion of this study, renal failure in multiple myeloma is a medical emergency that requires prompt, accurate diagnosis and management. Serum electrophoresis and immunofixation, along with serum free light chain assay, can accurately diagnose almost all cases. Renal biopsy should be considered early since it has diagnostic and prognostic value. While managing such cases, various causes should be addressed simultaneously. Dialysis should be considered in patients failing to respond with general measures. Multiple myeloma directed therapy should be started as soon as possible that includes chemotherapy and hematopoietic stem cell transfer. As per the study reviewed in this article, novel chemotherapeutic agents are considered to be superior to conventional drugs. Bortezomib, which is a proteasome inhibitor, can be effectively used in multiple myeloma patients with renal dysfunction, and no dose reduction is required. However, this is not true for other variable drugs like melphalan or thalidomide. The idea of receiving simultaneous kidney and bone marrow transplant from HLA identical sibling donors need to be studied further. So in patients with complete remission from multiple myeloma for at least 3 years, kidney transplantation alone remains an option with its own risk of multiple myeloma relapse and progression. Regarding serum-free light chain removal, plasma exchange has no additional benefit over chemotherapy. Successful renal failure management in multiple myeloma patients remain a challenge in high-risk patients, necessitating additional evidence from future research. The need of hour is for highly personalized treatment and collective decision. Finally, we strongly feel that the link between multiple myeloma and renal failure requires a deep insight research studies to be conducted to develop a more structured and direct approach to diagnose, manage, and prevent these conditions. However, up till now, the role of dialysis, chemotherapy, and hematopoietic stem cell transfer seems integral in the management of renal failure in multiple myeloma patients.
Thank you, Dr. Hamza, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Now let's move on to the next presentation from Dr. Mauna Lidhi. Hello, Dr. Mauna, are you ready with your presentation?
I'm ready.
Yeah, now I'm making you as a presenter. Kindly click on the screen button to share your screen.
Okay, 1 minute. I'm working on it. Okay.
Yeah, make it as a full screen and start your presentation now.
It is now full screen. Could you see the
Yeah, perfect. You
presentation?
can continue.
Okay,
Yeah.
thank you very much. May I present myself? My name is Mona Jlidi. I am a PhD student from the Center of Biotechnology of Sfax, Tunisia. I will present a part of my research, which is in vitro assessment of spore former strain as a potential probiotic against aquaculture bacterial disease. My presentation contains introduction, general finding, some results, discussion, and finally conclusion and prospect. Aquaculture is the farming of aquatic organisms, including fish, mollusks, crustaceans, aquatic plants. World production of fish was around 178 million tons in 2020. 49% are from aquaculture. Fish farming has applied in Tunisia since 18. It is the fastest growing industry which makes a significant contribution to the rising demand for animal protein.
In order to provide nutrition and food security, the fish varieties are cultivated at high density. Intensification of fish farm damage not only aquatic animal by high stress condition, but also environment by changing in the structure of aquatic habitat and in water quality. Diseases and deterioration of environmental condition are recognized as a major constraint on production and trade. Intensive fish are caused by intensive fish farming lead to massive loss caused by disease outbreaks such as Vibrio, Iromonas, and uh, in marine aquaculture fish such as turbio, sea bass, gilsibrim. This pathogen form biofilm, which is mono or multi-species community attached to surface and embedded in polysaccharide matrix, activated by quorum sensing. Then the bacteria who are more resistant to antibiotic innate immune defense and express more valence factor. Quorum sensing is the molecular strategy used by bacteria to monitor and regulate the size and density to their own population. Did you hear me? Could you hear me, please? Quorum sensing systems are mediated by a small diffusible signal that regulate virulence, biofilm formation, inter and intra-species interaction, and antibiotic resistance. To sort out this problem, vaccine chemotherapy causes environmental problem associated with additive chemical. Antibiotic may have the risk to public health, which have a risk to public health. Antibiotic may damage, may propagate and persistence of bacterial strain. So necessary of an effective alternative, probiotic. Probiotic is a live microorganism that offer a beneficial effect in the host when ingested in a required amount. Safety, functional, and technology feature must be into consideration in the selection. We have a problem. Did we have a problem? Could I continue? We have a problem. Hello. Could you everyone listen to me?
Yes, I listen to you.
Could I continue?
I suppose.
Okay. Functional criteria: tolerance to low pH and Bilsal, antagonist activity, addition to the intestinal mucosa, technological criteria such as extracellular enzyme production, and finally safety criteria, which is antibiotic susceptibility and safety.
لا هو اتصل علي بيقول لي مين متصل على النيرس قالت على دوز الاوجمانتين قلت له يمكن من ان بيشنت
There is
لا
sound.
مفيش حاجة. يلا
What happened? I listened to someone else. Okay. I suppose there is no problem. And finally, safety criteria, which is antibiotic susceptibility, safety, and no pathogenic bacteria. Selection of an appropriate strain seems the key to step to achieve the benefit of probiotic. Probiotics are isolated from endogenous and exogenous microbiota, such as gastrointestinal tract, skin mucus, aquatic environment. The search of potato probiotic should continue as the increased demand for sustainable and environment-friendly aquaculture. Probiotic main probiotic bacteria such as Bacillus, Lactobacillus, and for many probiotic yeast we have Saccharomyces boulardii. For mechanism of action, probiotic could have the modification of microbial population, aggregation with pathogenic bacteria, competitive addition to epithelial receptor, competitive for nitrogen. So for fish, we have the bacteria could control disease, growth promoter, improvement for digestion, improvement for the immune system, source of nutrition, improve water quality, and promoter for the production. So the aim of this study is the isolation and purification of marine bacteria as well as the study of their morphological and biochemical characteristics. And second, screen for bacteria with potential probiotic property and carry out their in vitro safety assessment using a subtractive procedure. Isolation of 38 spore former strain, 30 strain from intestinal mucus, and 8 strain from skin mucus of Sphaerotheca aurata. We have chosen to study the probiotic potential by a subtractive screen method based on a series of in vitro tests. All the strains are gram-positive catalase plus and sporulation plus. For screen of antimicrobial activity, only 24 strain, 6 strain from skin mucus and 18 strain from intestine, enough the growth of at least 2 or more of the 9 pathogens. The strongest inhibition was found by D6 and D9. They have strong antibacterial activity against Vibrio angularium, Vibrio harvey, Staphylococcus aureus, and the moderate activity against Lactococcus garvey, and finally, absence of activity against Vibrio vulnificus. Based on total score, only 9 strains, the strongest pathogen inhibitory strain, were selected and analyzed for extracellular antimicrobial activity assay and for various probiotic potential. For antimicrobial activity for cell-free supernatant, all their 9 strains have a good activity against all the pathogen. Inhibition may be due to the production of hydrogen peroxide, organic acid, and bactericin. So, we assign the nature of antimicrobial activity. The antimicrobial activity of cell-free supernatant exerted by all the strains persists after adjustment of the pH and heat treatment. This activity disappears and partially or completely after proteinase treatment. So this result confirms that the proteinase nature of all antimicrobial compounds. For enzyme extracellular enzyme production, majority of isolate strain produce protease and lipase activity. Only D4 and D6 produce amylase activity. For acid and bile tolerance of the isolate strain, all the selected strain remain viable after 3 hours of exposure to pH 2 and pH 3, but no one could tolerate pH 1. Tested strain also withstood bile concentration from 0.5 to 5% after 3 hours. D6 and D9 show the highest viability of selected strain in gastrointestinal tract condition. For autoaggregation and co-aggregation, autoaggregation for selected strain increased from 60 to 80. D6 and D9 exhibited the strongest autoaggregation ability, which is 90% for D6 and 58%, 85% for D9. Excuse me. After 6 hours of incubation, there is a strong correlation between autoaggregation and cell adhesion to the digestive tract, which is one of the major criteria for good probiotic bacteria. Aggregation probiotic bacteria may help not only in adhesion and colonization, but also the modulation of immunity system. For co-aggregation, all tested strains were able to co-aggregate with pathogen significantly, showing co-aggregation percent above 40%. D6, D9 exhibited the strongest co-aggregation ability after for the majority of indicator pathogen used and after 4 hours. Autoaggregation and co-aggregation is an indirect method for adhesionability of a probiotic strain. Co-aggregation capacity is considered as a way to exclude pathogen from the host. This ability can increase the computation of epithelial cell receptor and may protect GAT against undesirable microorganisms. For antibiotic resistance, in vitro safety assessment, all strains are sensitive to the majority of tested antibiotics except chlorphenicol and fosfomycin. D6 and D9 are sensitive to all antibiotics. This result may ensure the inability and scarcity to transfer antibiotic-resistant genes to get bacteria from strain D6 and D9, so their safety for further aquaculture application. The safety criteria of the selection of probiotic strain are the absence of homeolytic activity and antibiotic resistance. So for homeolytic activity, which we have no or gamma alpha, are considered to be safe. Beta hemolysis is considered harmful. Only D6 and D9 showed gamma hemolysis. Hemolysin is considered as a virulent factor due to its ability to initiate infection by entering small lesion to the mucous membrane and skin of any host. For conclusion, from all this isolated strain, we have strong antibacterial activity against fish pathogen, exert extracellular antimicrobial activity against all the indicator, tolerate gastric low pH and bile salt, have high autoaggregation co-aggregation ability. For in vitro assessment, all selected strains are sensitive to antibiotic, but only D6 and D9 showed the safety assessment, which is absence of homeolysis. Bacillus subtilis D6 and Bacillus subtilis D9 may be considered as potential fish. Prospective study in vivo the effect of this probiotic strain. And finally, study the stability of strain in manufacturing process. Thank you for your attention.
Thank you, Dr. Mauna, for your presence and presentation. Does anyone having any queries? I hope there are no queries. Let's move on to the next presentation from Dr. Shubhangi Pangal from Regional Occupational Health Center, India. Hello, Dr. Shubhangi. Are you ready with your presentation?
Yeah, I'm ready.
Okay. Now I'm making you as a presenter. Kindly click on the screen button to share your screen, please.
Yeah, yeah. Is it visible?
Yeah, it's visible. Can you make it
Yeah,
as a
okay.
full screen and start your presentation, please?
Yeah, yeah. Hello, myself Dr. Shubhangi Pingle, and I'm going to talk on lead toxicity, associated proteins, and its role in Alzheimer's disease, dementia in industrial workers. Here in India, we can find lot of anomalies, and people are working enormously in recycling of the batteries, and they are taking out all the batteries, recycling and using many more times and doing it lot many times. And if you notice, a small children also get involved in this kind of activities. So these are all unorganized sectors, and no one having a watch on it, and no one is controlling. So it's enormously going on nearby. So I am working in India in the Karnataka region, and there are a lot of recycling industries where people are working from the age group of very small 14 to 70. So, and they are having enormous exposure of lead, and lead is a big toxicant heavy metal, as you all know. I'm working in Regional Occupational Health Center, Bangalore. So my institute's mandate is working on occupational diseases. So sticking to that, I'm working on toxicity of heavy metals on industrial workers. So how the lead toxicity can be identified in population? First of all, lines, gingiva, and long bones. If you can see here in the tooth, in the teeth, there in the gingival portion, you can see lines as well as deposition of lead in the bones are too much. So, secondly, encephalopathy and erythrocytes basophilic stippling. If you can see here, it looks like a basophilic stippling, but it is not. These are the RBCs, which are looking like a stipplings of the basophils. Then, if you can see, abnormal colic and anemia is very common. These are the microcytic cells, RBCs you can find in the lead exposed workers, and dropping of foot and twist is very common feature of the lead exposed workers. So my study's aim was uh, to assess the proteomic profiling with Alzheimer's disease and dementia among the lead exposed workers. Lead is known for neurological diseases, and its association is being known for the Alzheimer's disease and dementia. So if you see the percentage of lead in the children, it is greater than 10 microgram per dl. Even in the 1 or 2 microgram per dl concentration, dementia and lot of issues, cognitive issues in the children were noted, and the dead limit is threshold limit is already reduced. Still in India, being unorganized sectors or more, you can find it is in higher population, almost 100 million to 300 million population, that to more than 10 microgram per dl. So if you see at adults, there is again a concentration of 5 microgram dl to 7.5 microgram dl. If you see the comparison of a children and adult, you will see that deposition of lead in children is more as compared to adults, and that's why the lot of cognitive issues are being noted in children. So their IQ goes down, and their lot of health issues according to neurology is being noted. So death rate due to lead exposure, this data is of 2019. It is huge. You can see 50 to 75 deaths in 1 lakh population. So how it gets absorbed in adults and children, as I told you now, 10 to 15% absorption in the adult and 40 to 50% in the children through oral absorption. In pulmonary, nearly 100%, which is alarming, in the children is being observed, and 30 to 40% in adults. Dermal absorption is common. So in adults, 95% deposition is being done in the bones, but then in 70% bone deposition is observed in the children's. The excretion rate in the urine is 65% and 35% in the bile. So as I told you, what is basophilic stippling? If you see this RBC, the deposition of lead you can see, and it is not looking like a basophilic stippling. Earlier studies, people used to make mistakes when basophilic counts used to get more in the lead exposed workers. Then how it comes like more basophilic count when people studied and started searching, or in children's even when they're licking the cradle, which was painted by lead paints. So it is observed that lot of 50-40 basophilics were present in the blood of the children's and paint workers. So how it is happening? Actually, it is nothing but a lead which is deposited in the RBCs and looking like basophils. So its route of absorption is gastrointestinal tract, skin, and respiratory, where it gets deposited in the bloodstream and excretion through urine and bile. So it gets deposited in the tissues, hard tissues as well as soft tissue. If you consider hard tissue, it is like teeth and bones, and when soft tissue, it is not nervous system. So if I wanted to give you a schematic picture of full absorption of lead, then I can tell you soft tissues, hard tissues, and RBCs. Here it goes an increasing of the concentration of AL enzyme, and then here basophilic stipplings were observed. So anemia and impairment of hemoglobin synthesis was mostly observed in the lead exposed workers. And if you see that bone and the teeth deposition, accumulation in the bone marrow and replacement with the calcium is very common, and it ultimately affects on the heme synthesis. In soft tissue, it affects on the liver, kidney, and brain, neurological system. It affects on the cyclic AMP, cyclic and adenylate cyclase, and blocks the neurotransmitter. How it goes to the and it crosses the blood-brain barrier and deposits in the brain. That's how the neurological issue starts. And if you see the lead mechanism toxicity on protein, RNA, and lipids level, you can see how it acts as a toxicant at different levels at the DNA and RNA level, also at the protein level. Also, it is ultimately the ROS oxidative damage, which is being noted in so many reports. So, as I'm working on proteomics, we have identified that there are lead binding protein, inhibitory protein, and stimulated protein. So, these are different 23 proteins which are being noted in the binding, inhibition, and stimulation. So in this, binding and inhibitory proteins are more important, as I wanted to correlate it with the Alzheimer's and dementia, GATA protein, and many proteins which are very important, and these are affecting neurons. So I'll go by one. So it is affecting on different levels like binding, inhibition, and stimulation. So ultimately it acts at different cellular level and affects the cellular health. So if I talk about binding protein, Metallothionein protein, as we all know, which is very, very important for free radical acceptor and oxidative stress stimulates in its expression. So, to maintain the reactive oxygen species, metal detoxification, metallothionein is very, very important. The presence of metallothionein in placenta can prevent the passage of lead into the fetal circulation and presumably protect the fetus against the lead toxicity. Lead is able to interfere with the nucleotide excretion repair through the inhibition of ape endonucleases. This inhibition often introduces critical DNA mutation and consequently prompts apoptosis. So here you can see how it goes and bind and how it affects. Am I audible? No. Hello.
You're good.
Yeah. Yeah. Okay. So another proteins are lead interacting protein. Synaptotagmin 1 is one of the very important protein. Lead interacts with the synaptotagmin domain but prevents its binding by the syntaxin, a protein required for presynaptic membrane fusion. Thus, the spontaneous release of neurotransmitters induced lead does not occur directly through the interaction between lead and synaptotagmin. So this is very important protein. Again one more stimulatory protein we can see here. It has a DNA binding ability, so it is also has a transcription. It is a transcription factor. Even at low level indicates its role on the perturbations of differentiation process of neuronal cell. Calmodulin is biggest mechanism where lead is interacting and interfering. So it is a calmodulin is a calcium binding protein. Lead bind and undergoes conformational changes in appropriate activation of several proteins like PKC and N-methyl deep aspartate glutamate receptor. So, and another protein kinase C, which are helpful in the learning and cognitive functions. There is another protein. Now these are inhibitory proteins. Gata protein development of neuron system is required. Early growth response protein, which is required for the nervous system development and modulation of synaptic plasticity. Lead could increase EGR1 DNA binding in early life and possibly the development of pattern or the brain areas influenced by EGR1. So this is a map where you can see systemic, neuronal and cellular levels, which I explained already. So if you can see here, these are the basophilic stippling. Looks like basophil, but this is RBCs. So these are the effects of lead toxicity. Then if you see the mechanism of neurotoxicity, lead neurotoxicity, this is a general mechanism, which is this is a general mechanism of neurotoxicity. And in another case, if you find lead blocks the calcium, and then in another case, if you find lead causes inappropriate signaling because of lead binds here and calcium does not bind at that place, and so the lead crosses the blood-brain barrier. So lead can also cause aberrant neurotransmitter release when calcium is not present. So if you see here, this lead is being bind over here at the calcium, and that's why the synaptic exchange of messages cannot be possible. That's how the neurotoxic effects are there. So, and in our studies, it is also observed that the glial cells and the myelin sheath is also being absent, and it is of 14 to 21 kDa, which is yet to finalize as the studies are still continuation. So I performed some 1D and 2D electrophoresis, and then I understood that 30 to 40 kDa is being present only in control, not in experimental. Very few concentration of 30 to 40 kDa is being present irrespective of lead level. So we wanted to go, what is a 30 to 40 kDa molecule, which will be helpful in identifying early diagnostic markers for lead exposed workers. And here you can see this 14.3 kDa is only present in control, not in other samples. This is also irrespective of lead level. So this is also very important, and we are trying to make it as a diagnostic kit for lead diagnosis in early stage. And this is the myelin sheath protein probably. Studies are yet to come up with the results. We are in the process. So this 30 to 40 kDa and 14 kDa is our target to identify what are all we can develop early diagnostic markers for lead toxicity, as lead toxicity is very common and biggest huge problem in India. So we did some string analysis, collagen analysis integrity pathway, and we found there is a lot of correlation with different protein molecules. Also, we tried with the gene ontology, and this is the spectral data. This is the spectral data which we can get M by Z ratio of our proteins, which are very significant. And these are some of the proteins list which which was different than other studies, which still in the process to identify what is its role, where it will be important, what kind of a pathway it followed, and whether it is upregulated, downregulated, and still we are in the process to identify its correlation, and we are still doing our studies. So these are the data which we got from the exposed workers as compared to control. So there is huge down regulation and up regulation of proteins, and we get something which is very very interesting, which are directly connected with the Alzheimer's and dementia. So our study shows the effect of lead battery recycling exposure workers by proteomic approaches accounts for 14.3 kDa, absence of protein in 85% exposed population. This is really a huge um, amount of absence of a protein. So this has definitely a bigger role, and we can go for development of our kit for early diagnosis with this, because it is only present in the control samples, not in the exposed population. Also, 30 to 40 kDa is being present in the 30% population. So the number of proteins affected by lead probably is much higher in occupational settings. Need to work on dozens of downstream targets. The study is needed to better understand the dynamics of systemic and other effects of lead poisoning. Thank you so much for patient listening. Thank you so much.
Thank you, Dr. Shivangi Pillai. Does
Yeah.
anyone having any queries?
The signals name and the rest.
I hope there are no queries. So once again, thank you, Doctor, for your presence and presentation.
Thank you so much, ma'am.
Thank you,
Thank
Dr.
you so much
Shivangi,
for
for your
inviting me.
presentation.
Right.
Yeah. Now let's move on to the next presentation from Dr. Amreen Aisha from Faisalabad Medical University, Pakistan. Hello, Dr. Aisha, are you ready with your presentation?
Yes, I'm here. Hello. Can you hear me?
Okay, now I make, yeah, you're audible. Now I'm making you as a presenter. Kindly click on the screen button to share your screen.
Yes. Can see my screen?
Yeah, your screen is visible. Can you make it as a full screen?
Yes, I'm up to. So here I am, Dr. Amreen Aisha. I am basically a researcher, and also I am teaching in a medical college in Faisalabad Medical
Dr.
University,
Aisha, can you
Pakistan.
make your full screen mode, please?
Yes, I'm. Can you hear me?
Yeah, you're audible, but your presentation is a minimized mode. Can you please make it?
Now
Yeah,
I.
it is your full screen now. Yeah, yeah, you can. Perfect. You can start now.
Okay. So I'm Dr. Aisha Amreen. My presentation or my research work is on the dermal cancer induction and leukemic experimental model, via improvised strategy of dose and time-dependent DMBA. So first we are going to introduce our carcinogen, which is going to induce the cancer among the rodent model, which we used is the albino rats. So DMBA is a polycyclic aromatic hydrocarbon which is recognized as a carcinogen. It's among the group of PAH. So DMB induces very quickly the sort of cancer, and PAH are known as carcinogens for causing neoplasia in rodent experimental models for cancer studies. Our objective was to induce two types of cancers. One was to induce the blood cancer, the leukemia, and the other was the dermal cancer in vivo model of albino rats. Here are the types of cancers which we are going to induce in skin under the basal cell carcinoma or in the leukemia where the changes will be experienced or exposed by the blood samples. The methodology we adopted was basically to differentiate between the normal or healthy rats or between the leukemic, non-leukemic or infected skin bearing rats. So we grouped them into the three albino rats groups. One was the leukemic rats group and the second was the non-leukemic, means the control, which were bearing the normal rats, while the third group that was infected, which had the infected skin with the MBA. In an in vivo study, an emulsion of chemical 712 dimethyl benzanthrazine, which is the name given to DMBA, 0.5% concentration in the olive oil as an emulsion was administered as a pulse dose of 40 mg per kg into the caudal vein of the rats. This was the regime followed for the induction of leukemia. And with the mean age of 90 plus minus days, so along with it, the LD50 determination was done at the 45 mg 45 mg per kg body weight. Afterwards, that induction, the rats were kept and observed. Their feeding behavior, their physical characteristics were documented. Later on, after development of leukemia as well as the skin cancer, the histopathological studies of liver, spleen, and blood were performed, and hematological parameters estimation for the tumor and leukemia was also performed. So what's the basics of DMB carcinogenesis? The DMBA, or we can compare it with the UV exposure, as all of us know that maximum exposure to UV or prolonged exposure to UV initiates the skin cancer. So DMB performs here the same function, the same thing, that it initiate the carcinogenesis by performing or undergoing the genetic changes which are irreversible. These genetic changes, which mostly take part in the specific genome or the specific part of DNA, that promotes the further genetic changes, and after promotion the progression of the cancer is very devastating. So initiated cell, clonal expansion, epigenetic changes all lead to the skin tumor associated angiogenesis, and these can be of two kinds, where here we experience a squamous cell carcinoma. This is the main, you can say, the performance of a single that cell that is genetically transformed into carcinogenic cell that undergoes a specific type of alteration, and the altered tissue microenvironment mainly promotes the unfunctional or non-functional cells, which are basically the carcinogenic. So they grow multiply, and the growth of focal proliferative lesions with altered tissue architecture, which may be exposed in the form of polyps, nodules, or papillomas on the skin surface. These altered tissues, or the organization of these altered tissue, leads to emergence of a genomic milieu, which inside a focal lesion, the tumor microenvironment. As you can see, the different types of cells, they gather up and form the tumor, which also supported by the hypoxia, acidosis, WBCs, infiltrate, then altered extracellular matrix, and further, which all contribute to progression of the skin cancer in cases of genetic changes. And likewise, in the case of okay, the dermal cancer here, the results are shown here. Before that, the main pathway, the DMBA is following. It transforms the pro-inflammatory pathway triggered on with the help of cytokine secretion and NF-kappa B pathway, while turning off the p53 caspase 3 or apoptotic procedure, apoptotic process that is being halted, while constant multiplication and tumor initiation leads to the skin cancer in this form of skin cancer. Likewise, in tumor, not only in the skin cancer type, DMBA, as we have experienced, if it is injected intravenously to the caudal vein, which is very much exposed or prominent in the tail region, we found that DMBA not only proceeds for the skin cancer, it also uh, uh, causes the it also causes the genetic changes, and these genetic changes, with the help of SIPE, it leads to the tumor initiation and the pathway that is triggering not only in the skin but also when injected through the blood, it leads to the changes in the lymphocytes, or it changes these lymphocytes may be increase in number, or they are multiplied in such a way that much of the cells that are not functional, but they are more and more in number. So tumor, either they expose themselves in the form of tumor, or they um, contaminate the blood with with this cancer of blood that is known as leukemia, which can be lymphocytic or myeloid, whatever the differentiation may be. After performing the experiment, we not only slaughtered the rats, and we uh, retained their organs and preserved them, and after autopsy they were remained with the histopathological study as well as hematological study. In hematology, we considered the main these main you can say the parameters: WBCs, neutrophils, monocytes, lymphocytes, hemoglobin, and platelets. As you can see, the WBCs and neutrophils, the leukemic rats had the maximum and significant level of WBCs and lymphocytes, while infected skin bearing rats had the um, much higher level of WBCs along with the high level seen in the neutrophils as well, while the monocytic study showed that there was a significant difference between the leukemic and the normal individuals, while the skin and the infected skin bearing rats, the I group, that was also in that had also the increased monocytes level. Similarly, lymphocyte study that clearly described that the rats had been induced with leukemia, and the skin cancer infected that are expressed in the dark gray, they had also the significant level of lymphocytes. Next, hemoglobin level was not merely changed because hemoglobin level was very much uncomparable. While in the case of platelets, the platelet levels were very much high in the leukemic rats, and then the infected skin bearing rats had the comparable level of platelets with that of the normal or non-leukemic rats. Next comes to the histopathology. Histopathology of organs and blood was conducted. Among them, four of the things were considered. One was the blood, then and the organs which were preserved for histopathology were spleen, liver, and bone marrow. This spleen, liver, and bone marrow was compared with the normal healthy individuals or healthy rats. As you can see, there was a plastic accumulation of lymphocytes and neutrophils seen in the bone marrow as well as on the um, blood smear. So, or also the spleen and liver showed some sort of coughing and infusion, and histopathology of liver was highly depicting the pathology of the uh, individuals. Now come the results. The results are very much expressive here. The rats were irritated and ferocious, particularly those that had the skin cancer, because they were so much irritated. I personally examined and seen we had to change their bandages, and after that, the skin was very much damaged and scaly, or some portion was very sensitive. So as the condition of the wound or the skin, the rats were very much irritated. Next, the initial dose resulted in the 86.66% survival rate. But after a while, 76.92% survival after second dose of TMB with 15-day of interval. And among all the models, 35.66% developed the skin cancer, and which had the clear signs which could be examined by examined with the comparison with the normal skin. And the pathological examination showed that the typical nodular hyperplasia, strenuous hemopoiesis, and splenomegaly and hepatomegaly. These were the two main characteristics which were seen in both in the case of cancer of skin and in the case of leukemia as well. And coagulativity was very much necrosed, and necrosed hepatocytes was examined. Above all that, there was one thing that I want to mention, that why we need to induce the leukemia on such on the rodent model. Initially, we had been trying to make a project that was for the treatment of leukemia, and already developed leukemic rats were out of our range. So I decided myself that there should be any other way to induce the cancer inside the rodent model in albino rats or mice, which can serve for the further therapeutic study. So that was the main theme for the research that would lead to many of the which could lead to identify or suggest the best therapeutic regimes for the treatment of the cancer or for the treatment of the leukemia, skin cancer, whatever the sort of cancer that is being induced. So in both the cases, by chemical carcinogen or by the carcinogen or chemical carcinogen or by the X-rays or UV, the DMBA was more safe and the results were more profound, and the results could be achieved earliest. So I found DMBA as a perfect source for carcinogenesis. Thank you. Any questions or queries you can ask me, please. Can you hear me? Okay, Alan, did you get my sound?
Uh, yes, you're audible.
Okay. I tried my best to fix my connection, but I can't understand what happened. It's a perfect one. I'm really want to explain my apologies that if any audible problem is there. So any questions over there? Are there any query related to my research? Excuse me, can you hear me?
Yes, we can hear you, but where is the organizer?
The organizer or the convener, I think he or she must be busy. So we can conduct next. Who is the next person? He can start over there.
I think it's Ahmed Sadek.
Yes, Dr. Shagufta is there.
Yeah. Should I go
Now it's
ahead?
your turn.
Yeah. They have messaged me that you go ahead with your presentation.
Okay, I have done my presentation. If there are any questions, then I welcome you.
Share it. So I think there are no questions. Thank you, Dr. Aisha.
Thank you.
Thank you. Thank you for a wonderful presentation. Should I go ahead with my this screen share and all? I think I should.
Sure.
Yeah. I think I
Yes, you
should go
should.
ahead.
Yes, come on.
Okay. Thank you so much.
Thank you.
Do you have the permission to share your screen?
No, I don't have. They have to do it. That is what I'm waiting for.
Oh, okay.
Yeah. So I think the organizers, they are busy somewhere. I will just message them. Yes. Share my screen.
Hello, Dr. Shagufta.
Yeah.
Am I audible to you?
Yeah. You are
Sorry for the
audible.
inconvenience caused.
Yes.
Okay,
Should I?
now thank you, Dr. Aisha, for your presence and presentation. Now I'm making you as a presenter, Dr. Shagufta. Please click on the screen button to share your screen.
Okay. Thank you. Thank you. It's not working. I'm still not a presenter. Not able to share it.
We are doing 1 second, doctor.
Okay.
There's a technical issue from my end. Sorry for the inconvenience.
Okay. No issues. Okay. Please.
Now you are a presenter. Kindly click on the screen button to share your screen, Dr. Shagufta.
Okay. Thank you.
Yeah, your screen is shared now. Can you make it as a full screen and start your presentation now?
Okay. So is it clear now? Visible, and am I audible also? Can you see my screen?
Yes.
Yes, yes, your screen is visible. You can continue.
Okay. 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 Thank you. Thank you so much. Unmute everything. Very good evening to all of you, and I'm a big thankful to the organizers for giving me an opportunity to present my work in the prestigious conference of European Congress on Infectious Disease. I will be highlighting my experience on cutaneous leishmaniasis in the extreme North Indian Center. It's a tertiary care hospital, and the challenges that we face in a resource poor setting. As we all know that neglected tropical diseases, they are communicable diseases, basically a set of 20 disease groups, and they prevail in tropical and subtropical regions. And they affect more than 1 billion population, mainly those living in the poverty and in close contact with infectious vectors. Leishmaniasis is one of the most relevant neglected tropical disease as per WHO. Predominantly, it is a group of disorders anthrozoonosis caused by protozoan parasite of genus Leishmania. The organism is both viscerotropic and dermotropic, and the clinical presentation is as a result of complex interplay between the immune response of host, protozoa, and vectors. So this results in a spectrum of disease ranging from localized skin to mucocutaneous disease and to a fulminant form, that is visceral leishmaniasis. Cutaneous leishmaniasis again has further like many types. It can be localized, which presents in the form of nodules and ulcers on the skin. It is diffused cutaneous leishmaniasis, which is a progressive and fatal disease. And then we have mucocutaneous form, and then we have post-Kala-Azar dermal leishmaniasis that occurs in concurrent with the visceral leishmaniasis. The disease is transmitted to the mammalian hosts by the bite of infected sandflies. They act as a vector, and we have different types. Two main types are phlebotomous and Lutzomia. Phlebotomous acts as a vector in Old World and Lutzomia in New World. Distribution-wise, leishmaniasis is divided further into two broad groups. We have Old World cutaneous leishmaniasis and New World. Old World, it is mainly seen in the Asia, Middle East, and Africa and other North African countries. And if we go for the like the world scenario of the disease, about the cutaneous leishmaniasis only I will be discussing. At present, we have 1.5 to 2 million new cases occurring every year, and 350 million are at the risk of acquiring the disease that are living in the neighboring areas. And the total disease burden is at about 12 million. The 90% of cutaneous leishmaniasis, it is mainly being reported from Afghanistan, Algeria, Brazil, Colombia, Iran, Pakistan, and other Middle East countries. Brazil has a high burden of both visceral and cutaneous leishmaniasis, whereas mucocutaneous, it is mainly reported from Bolivia, Brazil, and Peru. Now, more than 20 species are being implicated in the disease causation. In Old World, we have Leishmania tropica and major, and Leishmania infantum also at some places, but it is mainly the Leishmania tropica and Leishmania major. If we go for about the like epidemiological forms, we have the disease. It shows two these epidemiological forms. It is one is anthroponotic and one is zoonotic. Anthroponotic is only humans are the whole like they are the sole source of the disease, and the transmission is by these vectors, and this it is one from one person to another. Their Old World, in we can see this zoonotic form also, but there is no established there is some evidence of the animals being playing a part in the disease transmission, but it has not been established. Now, why we are discussing the disease? We know that cutaneous leishmaniasis, it is showing an escalating trend. The number of cases, the incidence overall is increasing, as well as the extension of disease to previously non-endemic newer areas. The spread is occurring to newer areas which were not earlier involved. So the disease is gaining epidemiological importance. Now, certain risk factors are now said to be responsible for this spread and increase in the incidence of the disease. It is being attributed to any factors that alter the distribution, survival, and population of vectors and reservoirs, like there is increased density of sandfly in human dwelling environment, activities through which humans are invading the habitats of these sandflies. So overall, any kind of activity that brings humans close to these reservoirs and vectors. So we have vector related risk factors, like when there is vector displacement through deforestation, construction activities, building of dams. Climate change also is said to be one of the important factor. Humidity and moisture, they provide a good environment for sandfly, vector sandfly growth. Now, then we have certain individual related host factors that play a part, might be playing a part, though there are so many factors like low socioeconomic status, poor housing facilities. We have rural areas with proximity to forests, then poor domestic sanitary conditions, malnutrition, overcrowding, then massive displacement and migration of people, immunosuppression, drug resistance, and so many. All these factors, they contribute um, to the increasing incidence of the disease that we are now seeing. Now, about the life cycle, we know that there is a sandfly stage and human stage. So once the promastigotes, they are, sandfly takes a blood meal and it injects promastigote form of the parasite into the human dermis. These promastigotes, they are then phagocytosed by macrophages, and within these macrophages, there is further multiplication and transformation into amastigotes, and there is spread to other tissues and cells. The disease, like leprosy, it shows a spectral behavior. On the one end, we have good cellular response depicted by positive leishmania skin test. This is the localized cutaneous leishmaniasis, localized form. But while on the other side, we have energic form or lepromatous form, which is diffuse disease that shows a progressive and coarse and fatal outcome, and it displays a negative leishmania skin test. So this disease severity and these clinical manifestations, they are mainly determined by the immune response of the host. So if we see that on the we have in the diffuse cutaneous leishmaniasis, there is complete energy to the skin test, and on the localized side the skin tests are positive. So there is normally there is a balance between Th1 and Th2 cytokines, but here you will either there is a exaggerated Th1 response or Th2 response is exaggerated, or and that results in the enhanced disease severity. So once the different clinical manifestations, they are determined only by a host immune response and also by the species of parasite. So the balance between pro and anti-inflammatory mediators plays a vital role in clinical presentation as well as outcome of the disease. Accordingly, the disease shows transition from one form to the another. Normal this balance, it is disturbed, and an exaggerated Th1 and Th2 response can lead to the severe disease pathology. So we have two types of immune response in that play part in leishmaniasis. The initial is immediately after infection. The Leishmania parasite is phagocytized by immune cells that are recruited to the sites, and they are neutrophils. Then we have monocytes and macrophages and dendritic cells. So they are the part of innate immune response, and the immediate contact of parasite is with these cells only. And these cells, they actually there is release of they play a part in controlling the infection. They try to control the infection. There is release of reactive oxygen species, nitrous oxide, etc., that help in the clearance of organism and controlling the infection. But once the innate immunity plays a part, later on there is activation of adaptive cell immunity in the form of Th1 and Th2 cytokine profile. So effective Th1, that there is release of interleukin 12, interferon gamma, TNF alpha. They all migrate, lead to activation. They activate the maturation of naive T cells, and this Th1 cytokine, it triggers a strong inflammatory response, leading to macrophages, activation of macrophages against the parasites, and leading to clearance of the organism. So it is the Th1 response that controls the infection. But later in the disease course, there is activation of Th2. If there is early activation of Th2 response, that will lead to the progression of disease. So Th2 is associated with the progression and severity of disease, and Th1 with the clearance and control of the infection. And it is mainly through the nitrous oxide and reactive oxygen species. They are the two main microbicidal mediators that are involved in controlling the Leishmania infection. Now, if we let us see what is the scenario of leishmaniasis in India. India, we all know it is done for visceral leishmania, visceral form of the disease. For it, India contributes to 40 to 50% of the global burden of visceral leishmaniasis, and the states endemic for visceral leishmaniasis are in eastern India, Bihar, Jharkhand, West Bengal, and Uttar Pradesh. But about the cutaneous leishmaniasis, the initial reports were only from dry and arid regions of Rajasthan. Later on, Himachal Pradesh was highlighted to be endemic for the disease. And of late, now Jammu and Kashmir, Union Territory of Jammu and Kashmir, it has emerged as a challenging focus. Jammu and Kashmir is located in the extreme north of the India and is on one side surrounded by Pakistan, Afghanistan, Sri Lanka, China. So it shares borders with all these countries, and in all these countries, cutaneous leishmaniasis is quite rampant. It has two divisions, Jammu and Kashmir, and 10 districts are in each district. In each division, with a population of around 11 million, and it has two main tertiary care hospitals. We have Government Medical College Jammu and Kashmir that caters to the population of these two divisions. So here we started collecting the data of these cases. The initial first report that was published, it was based on 36 patients in 2009. Since then, we have been collecting the data, and a bicentric hospital-based study was carried out, and we were able to publish this data of about 1,300 cases in the International Journal of Infectious Disease. Area-wise, 71.34 patients, they were from Jammu division, that is located across this Chenab river, which flows through the Himalayan range, and rest of the cases, they were from Kashmir division. This is the year-wise distribution, and it is the disease is showing continuously an uprise in the incidence, except in the last, like when there was a pandemic, and that time only we saw a dip in the number of cases, and now again we are seeing increase in the number of cases reporting to us. Now, how we are diagnosing these patients, it's only mainly on the clinical suspicion only, and that high index of suspicion is important. We have to be aware then only. Clinically, we are using two these criterias. One is by Bari and Rahman, and another is by Kuba. Both of these state that patients with exposed who have asymptomatic lesions on exposed sites of the body, they are multiple in number, and they are asymptomatic, and they are not responding to conventional treatment. There are similar lesions in the family or neighborhood, neighboring neighborhood, and then there are some atypical pictures like volcano, satellite papules, subcutaneous, and iceberg nodule. So both these criteria are being utilized, and we are trying to diagnose our patients on this basis only. Then most of our patients, they come from extreme rural areas, and which are like the settlements near the forest areas. None of our patients so far has given any history of travel to endemic areas. And this shows that so there is a local transmission of the disease is taking place, and the role of local vector and local species, locally prevalent species, needs to be investigated. Age wise, again, it is important. Most of our patients, they are young population, less than 20, followed by 20 to 40 years. And exposed parts of the body, face, neck, and dorsum of hands, they are mainly involved. And patients usually come with multiple lesions. And if we see, most of the patients, they come to us late in the course of disease. That is, after they usually come to us within 7 to 9 months, followed by 10 to 12 months. So they come to us late in the course of disease and with large and atypical lesions. This shows there is lack of awareness about the disease in our population. And also in the the first contact is with the local healthcare facility where general practitioners are there. So they are also not aware of the disease and not able to diagnose. And also there is dearth of dermatologists in the rural areas, in the peripheral areas. So this all leads to the delay in the diagnosis. Morphological type, we are getting mainly nodulo-ulcerative, but then many atypical pictures, these presentations are also coming to us. So this is the commonest presentation, classical one we are getting, but atypical presentations are also being reported. So here is the common presentation. The patients come to us with asymptomatic lesions on the exposed parts. They are shiny, asymptomatic, erythematous and edematous papules and nodules and plaques. This is also one factor that contributes to the delay in the diagnosis or delay in seeking the health care, as the lesions are asymptomatic. Here again, you will see these lesions, and the ulceration is typically localized to the center of the lesion. There are multiple lesions on the face. Family history is usually positive. Multiple members of the family can be affected, a mother and child. Here you can see, here again you can see siblings are in a family, they are affected. So similar kind of lesions on the face and eyelids. Here again you will see the patients, they have these lesions on the nose. So this was the common presentation and classical, but atypical presentations also are being reported from our place, and they have been reported in the literature also from endemic as well as non-endemic areas. The atypical presentations, they are being attributed to multiple causes, like presence of host immunosuppression, comorbidities, pregnancy, and certain environmental factors and strains of the species parasite. But so far no significant association has been seen between these atypical presentations and other factors that were being highlighted. So this further explanation needs to be sought to address the diversity of disease forms. These are few of our patients that came to us with wart-like lesions, verrucous lesions, or squamous cell carcinoma-like lesions on the face. We had these huge lesions on the nose, rhinophyma-like presentation. Here we can see the lesions mimicking cutaneous tuberculosis with a lot of scarring and deformity. Here again, extensive plaques with ulcers and scars on the face, and mimicking simple bacterial infections or other cutaneous disorders. Even we were also able to elicit a sign in these patients, that is tin tag sign. This was also published. In few of our middle-aged elderly patients, they come to us again late in the course of disease with chronic form of cutaneous leishmaniasis. They present with large swellings and plaques on the face which are indurated, and this is erysipeloid form. It has been reported in the literature, and these patients, they usually give history of use of topical steroids, again that are being prescribed by the local quacks or practitioners in the surrounding, like in the nearest this healthcare facilities. So these are usually steroid modified picture. The lesions are flat and they lose the nodularity. They are quite atypical in presentation. They don't respond to bacterial antibacterial therapies, and on histopathology only we are able to demonstrate granulomatous infection, and then that gives us a clue towards the cutaneous leishmaniasis. Then we have some chronic forms. And this one of our patients, she had 5-year duration of the disease, and she came to us with this boggy swelling on the nose. This was leukoid form of leishmaniasis. In pediatric age group, children are they're quite they are now being shown to be at a greater risk. Maybe they are not like they are exposed to the parasite due to outdoor activities in this age group, and probably there is lack of immunity to the parasite at this early age. So the disease is quite common in pediatric age group, and in them we see mainly the lesions, they are impetiginized, and they just resemble any other bacterial infection. Pyoderma like presentation is there. So we have like pus filled lesions, we have furuncles, we have boils, or we have pustules, and then we have impetigo like lesions. It is just like any other bacterial infection on the skin, and but they will not respond to antibiotic. There is lot of purulence, and so it is very important that after a course of antibiotic, if you suspect cutaneous leishmaniasis, and you call them for a follow-up and investigate them further. Like in this patient also, multiple lesions, she was being prescribed antibiotics repeatedly, she was given, but again these lesions, they would heal a little and then again ulcerate and show a lot of pus discharge. So they are usually misdiagnosed as bacterial infections. So and a follow-up after a course of antibiotic is very important. Mucosal involvement in this old world leishmaniasis as such we don't see, but when the lesions are they are occurring at the mucocutaneous junction, adjacent mucosa will be involved. Like in these patients, lip involvement was there, and again they were like being misdiagnosed as simple cellulitis, insect bite, herpetic infections, etc. Overall, cutaneous leishmaniasis, it has a varied clinical presentation, and it needs to be differentiated from many other common and uncommon skin conditions in acute stage, from simple bacterial viral infections, chronic fungal diseases, malignancies, vasculitic disorders, and other cancers. So then we have some disseminated form. We don't see American or mucosal leishmaniasis, or we don't see mucocutaneous leishmaniasis in our place. So I'll be skipping this. It is again very difficult. It is disfiguring. There is a risk of dissemination to mucosa, and it can be fatal. Now, increase in incidence and varied clinical presentation underlines the importance of high index of suspicion among clinicians, especially in non-endemic areas. Awareness about the clinical presentation is very important for correct diagnosis, especially in non-endemic areas. If we go to diagnosis, we face many challenges. As the clinical presentation is varied, then we have to differentiate it from the commonly occurring disorders that mimic it. Like tuberculosis in our setup, it is such a relevant health issue, and in all these patients we have to evaluate them, and we have to rule out tuberculosis first. Multiple species are involved, then there is co-infection with other microorganisms, and most important is that there is non-availability of DNA based tests which are very sensitive and specific. So at present, we are diagnosing them. We have to rely only on clinical details, epidemiological and clinical criterias, and this is to be supported by laboratory testing. Laboratory testing, we have a battery of tests now there, and the selection of these tests, it depends upon available infrastructure and resources rather than on the diagnostic accuracy of these tests. And multiple tests should be employed routinely in all these patients, in one patient. So we have microscopy, we have culture, we have immunological tests, serological, and then we have some DNA based tests. Parasitological diagnosis is considered gold standard in the diagnosis, and it is based on demonstration of amastigote form of parasite in the biopsy and smears or aspirates. So we will take sample, and we have to demonstrate the amastigote forms. It has high specificity, it helps in the confirmation of the diagnosis, but overall sensitivity is less. For this, sample has to be taken from edge of the lesion. We can take patch biopsy, we can just scrape the lesion and take the scrapings, or we can just take aspirate from the lymph node. And we have to prepare these smears. We have different methods of preparing the smears. We will just take the tissue and crush it between two slides. In the middle, we have to slightly apply some pressure so that the tissue cells and juice, it spreads on both sides. Then we have to dry the slide and stain it with Giemsa. Or we can just take touch imprint preparations. The cut surface of the tissue has to be just roll on, or just a contact is required on the slide. We don't have to press it. Or we can just give a nick with the sharp edge of the blade and scrape the walls, take the serous part of the serous fluid and spread it on a slide and dry the slide, again subject it to the Giemsa, or we can take aspirate from the regional lymph node. So finally these slides, they are prepared, they are air dried and subjected to Giemsa staining, and they are examined for presence of investigote forms of this, that is Leishmania donovan bodies, which are oval shaped. They have a characteristic dot appearance or dot and dash appearance. All fields have to be examined before labeling them as negative. So here like we can see some immune cells, and these dot like structures, they are suggestive of Leishmania infection. Here again, we can see that dot-like structures. They are Leishmania donovan bodies in Giemsa stained smears. Sensitivity is quite like it is moderate only, and a sensitivity of 40 to 80% is being reported from old world. But overall, it is a rapid, simple, and cheap method of diagnosis. And the sensitivity, it varies with the age of the lesion. In early lesion, there are more chances of reporting these smears as positivity is more, but with the chronicity, they are usually negative results. Or we can just demonstrate them from regional lymph node, and then we can take biopsy from the edge of lesion. Biopsy helps in diagnosis also, and also to differentiate between the conditions mimicking cutaneous leishmaniasis. So, and it shows a spectrum actually, and again it varies with the age of the lesion. Early, if we take, there will be only diffuse lymphoplasmastic infiltrate, but if the lesions are more than 1 year duration, we will then get only granulomatous infiltrate. Granuloma will be there. Initially it will be ill defined, and later on well defined epithelioid granulomas. So this is the diffuse lymphohistiocytic and plasma cell infiltrate, and later stages we will get this well-defined granulomas. Now, positivity for LD bodies in both smears and on histopathology. It varies. Early stages, less than 6 months duration, it will be more positive, and later on, when the disease is more than 6 months duration, positivity will go down, and this difference is quite significant. Like in our study also, the positivity was 82.65, but later on it was 53.66, and on histopathology again. And in both in a few patients, both slit skin smear and histopathology, we were able to demonstrate these positive LD bodies. This was again early stages, it was more, and less in later stages. Now, histologically, again, we need to differentiate it from other granulomatous diseases like leprosy, sarcoidosis, lupus vulgaris, histoplasmosis. For this also, we need special stains, we need PCR-based tests that should be ideally performed on paraffin-embedded tissues or these histopathology blocks. But again, in our setup, availability and affordability is an issue. Then we have culture. It is as such not done. It requires a complex laboratory structure and technical skills. Some modifications have come up, but we don't have the availability is not there. And then Leishmania skin test is used for diagnosis, but it has mainly epidemiological importance. Serological tests, many serological tests, they have come up in recent years. We have ELISA, Western blot, we have direct agglutination test, we have indirect fluorescent antibody test. Many recombinant proteins have also been generated. Nitrocellulose paper strips impregnated with these recombinant antigens like RK39. It is also being now highlighted its use in field conditions. They are commercially available, but all these currently available immunological tests, they are not recommended for diagnosis of cutaneous forms of leishmaniasis because the levels of circulating antibodies, they tend to be low, and there are reports of cross reactivity with other parasites. Now, finally, polymerase chain reaction, PCR-based assays, they are currently the most sensitive and specific diagnostic test for detection of Leishmania species. They are useful in situations like in cutaneous form where parasite load is less. the sensitivity and specificity is very high. And several these PCR based modifications, they have high sensitivity, and they also are helpful in typing of Leishmania species. We have now recently loop mediated isothermal amplification. This is a modification of PCR and is being validated as an alternative method of diagnosis. It is faster and needs only basic laboratory equipment. Another is multi-locus enzyme electrophoresis. It allows identification of the Leishmania organism by electrophoretic mobility of various intracellular enzymes, and is now being regarded as a reference standard for identifying the species of Leishmania. But to overall, the confirmation of diagnosis in resource poor setting, we have to rely only on epidemiological criteria, clinical diagnosis, routine basic investigations like GIMSA stents, slit skin smears, and histopathology. We have started using dermoscopy. It has a polarized mode and a magnification of 10x. In the diagnosis, it is of some help only, and it helps in to some extent. It does help us in differentiating from other granulomatous disorders. Dermoscopic changes, they vary with the stage of the disease. In early stages, we will get only ill-defined erythema, but later on we may get some specific changes like white starburst pattern, perilesional halo, and that they are of some help. These changes have been now described in many studies, and they are of some help in our clinical setup. But they can only be used as a supplementary tool. They basically reflect the histopathological background of the condition. So basic knowledge of histopathology is important to understand this technique. Now, if we go to the treatment part, there is a concept that there is a concept of spontaneous remission in a large proportion of cases in old world cutaneous leishmaniasis. But what we suggest from our experience, that we should treat all the cases. Treatment should be offered to all the cases, and proper wound care is very important, and it has to be continued throughout the course of the disease. When we are treating with specific drugs, appropriate wound care has to be given to the patient. Like topical antibiotics, oral antibiotics are important, ophthalmology consultation, ENT consultation when lesions are in the adjacent areas. The one study, it has highlighted the use of this time, that is tissue debridement, control of infection and inflammation. Then we use of these hydrocolloid dressings and non-adherent dressings and maceration, etc. It has to be cleared with this technology, time based like this technology. The significant improvement was seen in the clinical, this overall clinical picture. Like in one of our cases, she was she was a pregnant female with 3 months amenorrhea. We were not able to give the drugs which are quite toxic and teratogenic, but only appropriate wound care was applied and given. And we were able to control like her lesion. There was significant improvement, and the treatment was then delayed, and she could we could handle her with topical treatments only, and we could delay the treatment. Now, going to the specific treatment, we have antimonials. They are the mainstay of treatment. They are systemic and topical. And then in the systemic, we have trivalent antimonials, we have pentavalent, we have sodium stevogluconate, and then can be given intravenous. Intravenous has to be given in hospitalized patients also. And if large amount, it needs to be diluted in 200 ml of 5% dextrose and to be delivered in 1 hour. Intramuscular is quite painful, but only it's usually to be avoided. But intralesional is now being documented as the first therapeutic line in localized cutaneous leishmaniasis in old world. But with the systemic, the cost is an issue. But most the important thing is that these drugs are not now available. Unavailability is one major factor. Then there are reports of resistance to these drugs now, and a huge side effect profile of these drugs, especially the cardiac arrhythmias. Then we have bone marrow related and kidney related side effects, like effect on the renal function derangement. So these drugs, they have to be given under stringent, like continuous cardiac monitoring has to be done, or they have to be given in as indoor if we have to give them systemically. So patient needs to be admitted, hospitalized, and even we give, in some elderly patient, we would also take our patients to triage unit or ICU and give them under continuous cardiac monitoring. Local administration, there are only few side effects, and especially in childhood age group, some pain, which can be avoided by use of topical anesthesia, etc. So topical therapies, if we go to non-antimonials, we have other topical therapies, like we have 15% paramomycin is given, with gentamicin sulfate, imiquimod has been given, and then topical miltefosine and dapsone. In intralesional, liposomal amphotericin B is also has shown a good efficacy. Then we have various physical modalities, CO2 laser, cryotherapy has shown good response, and liposomal amphotericin B parental. Then we have many oral drugs that have been given, but at present there are no randomized control trials, and there is the evidence about these and some comparative data. It is very less, especially from the old world. Overall, if the lesions are few, they are smaller in size, they are not localized on face or around the joints, there is no immunosuppression, or especially in the children and elderly and debilitated comorbid patients, we should go for local treatment, which can be given in the form of intralesional sodium stibogluconate, intralesional liposomal amphotericin B, with or without cryotherapy, or we can go for 15% paramomycin and 12% methylbenzethonium ointment. Now, if lesions are multiple, larger in size, on cosmetically sensitive areas, there is mucosal dissemination, there is lymphangitis, there is immunosuppression, systemic treatment has to be given. So we can give sodium stibogluconate IV or IM for 20 to 30 days, with or without pentoxifylline, or liposomal amphotericin B, and even there is oral miltefosine has been given in cutaneous leishmaniasis. Some alternative drugs are there. Pentamidine has been given, fluconazole and itraconazole. So treatment needs to be individualized. But the reports of spontaneous resolution are there in old world cutaneous leishmaniasis, and the effectiveness of local therapies also are there. So this all has resulted in local therapies now being considered as the first line of treatment in old world form. And these different treatment options must be based on leishmania specific species, geographic region, and clinical presentation. So this is how we give. This is the lesion, and we start at different angles. And this is the drug. This is sodium stibogluconate. Again, now not easily available. Intralesional liposomal amphotericin B we have also given in our patient, and efficacy is at par with the sodium stibogluconate intralesional. These are few of our patients, like this elderly female. She had a 5-year duration of lesion, and here not only 20, but we had to give the systemic drug for 30 days. We took her to ICU, and there we would give the treatment, and the response was at the end of 1 month quite good. In this patient, intralesional sodium stibogluconate was given, and another case where intralesional amphotericin was given. So all these patients, we can see the lesions, they heal with milia formation and scarring. Another elderly patient where we had to extend our treatment to 1 month. He had used topical steroid and other immunosuppression, and there was this extensive lesion on the face. This is at the end of treatment. Another patient where systemic treatment was given. In this patient, along with the antibiotics, she was again treated with systemic intravenous sodium stibogluconate for 21 days. So the response with both modalities, intralesional and systemic, it is almost same. In our study, it was based on 1300 cases. There was no significant difference between the response to treatment with two preparations, but mean duration to clearance of lesions, it was less with this intravenous form. With intravenous, it was 2.4 plus minus 0.6 weeks, and intralesional, it takes long. And there was no significant difference in terms of number of lesion or size of lesions. So the response was same with both the modalities. Post-treatment scars are quite disabling, and especially in childhood group, they have a psychological impact on the patient. So we are now treating these scars with fractional CO2 laser. Now there are many factors that may affect species is important, like Leishmania major and Mexicana. They tend to heal spontaneously and they overall show good response to treatment. Site of lesion is important, morphology or appearance. Bacterial superinfection also tends to delay the response or interfere with the response to treatment. Host factors like immune status is important, and which modality and route of administration is being used. So these are the recommended regimes by WHO. And assessment of response to treatment is important. We have to monitor these cases for 6 to 12 months after the treatment for any recurrence or relapse. The response has to be assessed only clinically. No repeat parasitological testing is important are needed. So first 2 weeks there will be some paradoxical increase in regional inflammation. This has to be explained to the patient. But by the end of 3 months there is complete reepithelialization and healing of the patient, lack of inflammatory findings, no ulcer, no induration. We also are using dermoscopy now in monitoring the response to treatment. Initial picture is this, and later at the end of 12 weeks we can see there is some difference. In this patient also dermoscopic evaluation was done, and at the end of treatment only scar and pigmentary changes are there. Here again on the lip. Therapeutic failure, many factors can lead to therapeutic failure. There is worsening of these lesions while on treatment, or there is incomplete healing or relapse. So it varies with it is the predictors of therapeutic failure. They are again host immune response is the most important factor. If patient is on immunosuppressions, there is prior history of incomplete treatment, or we are not giving appropriate dose, history of local trauma, and some other factors. So intralesional therapy at present in old world cutaneous leishmaniasis can be considered as a preferential form, evading the toxicity associated with the systemic administration. So for mucocutaneous form, we don't see these patients here. We have to individualize the treatment, and systemic form is always to be given in the form we can give pentavalent antimonials, amphotericin, lipid formulations of amphotericin, and oral miltefosine has also shown good results. In addition, supportive treatment is to be given to all these cases. Nutrition, anemia has to be attended, high calorie, high protein diet, bacterial infection has to be treated. And prevention and control measures in the area, they are very important for this education, counseling, and some control measures with the help of local healthcare facility. Immunotherapy is role of immunotherapy, especially in combination with the specific drugs with antimonials and other immunomodulators. They have also been given and have shown good result, but evaluation using randomized control trial is still needed. Vaccines, many vaccines are being highlighted. They have come up in recent years. We have whole Leishmania extract, subcellular fractions, we have individual antigen based vaccines. But again, there is no consensus at present, like how effective they are and what should be used. So to conclude, it is quite common in non-endemic areas also, and the clinical manifestations are extremely diverse and atypical. And these atypical and varied manifestations, this is basically outcome of interplay between parasite infection and host immune response. So I just wanted to draw the attention to Jammu and Kashmir, that is extreme North India, and as a to highlight the area as a new focus of endemicity that should be of considerable public health interest. So it was a comprehensive clinico-epidemiological profile. But further studies in this direction, like discerning the predominant Leishmania species, disease reservoirs, vector control strategies in the region, they are needed. The limitation again, it is diagnostic methods with high sensitivity and specificity like PCR, they are not performed due to non-availability at our institution. So in resource poor setting, confirmation of diagnosis is still based on these traditional tests only, and then different treatment options are now available. They have to be individualized, and there is a roadmap that has been like by WHO has started this roadmap to eliminate the neglected tropical diseases, and this is between 2021 to 2030. And so the funding by WHO agencies to carry out research for species identification in newly identified endemic focus of the disease. Non-availability of drugs is a major issue in developing countries. Antimonials are still effective if given under supervision and proper monitoring, but they are again not available. So WHO agency, based agencies, they need to give attention to the disease, make drugs available on the lines of MDT like we give in leprosy, especially in the resource poor countries. Attention and support for control activities through various control programs, it also needs to be encouraged. So I have no, for this we had no financial support and I had no conflict of interest. Thank you. Here.
Thank you, Dr. Shagufta, for your presentation. So anyone having any questions? Okay, no questions then. Thank you once again for your presence and presentation.
Thank you so much. Thank you.
Thank you. So our next presenter is Dr. Rabia Islam from Punjab Medical College, Pakistan. Hello, Dr. Rabia.
Hello, am I audible?
Yes.
Hello.
Yes. So I'm make you the presenter. Yes. Please share your screen with us.
Is my screen is visible?
No, no, it's not visible. Yes, now it is visible. You can make it a full screen.
Okay. Can I start now?
Yeah, but it is not visible properly. Can you please make it a zoom out like something it should be visible? You can make it a full screen.
I have made it full screen. Now is it
Yes,
visible
now it
now?
is okay. Yes, now it is okay. Please continue.
Okay, thank you so much. Hello everyone. My name is Dr. Rabia Islam and I graduated from Punjab Medical College, Islamabad, Pakistan. Today my topic of presentation is cirrhosis and coagulopathy, mechanism of homeostasis changes in the liver failure and their management. So the abstract of my article is that as we all know that cirrhosis is an end-stage liver disease that can cause changes in any component of the hemostatic system. Coagulation disorders are caused by the various factors including decreased clotting and inhibitor factor synthesis, reduced clearance of activated factors, quantitative and qualitative platelet defects, hyperfibrinolysis, and increased intravascular coagulation. This article discusses the pathogenesis of coagulopathy, multiple studies related to its clinical presentations, and also highlight additional problems in the diagnostic and therapeutic approach to this group of patients. And multiple management options have also been discussed in this article for the bleeding and thrombosis in the liver disease. So introduction and background. As we know that cirrhosis is thought to be the stage at which the fibrotic liver disease becomes irreversible, and fibrosis represents the final pathological pathway in the development of the chronic liver disease, regardless of its etiology. So since the liver is the site of synthesis for most procoagulant and anticoagulant factors, it also plays a crucial role in hemostasis.
As a result, patients with a decreased liver synthetic capacity are more likely to experience bleeding, particularly gastrointestinal bleeding and coagulopathy caused by the liver synthetic dysfunction. They are also at risk of thrombosis, primarily in the subclinic circulations, particularly when platelet counts are increased by transfusion or drug therapy. Patients with liver disease have bleeding tendencies with prolonged coagulation screening test results, particularly the prothrombin time, international normalized ratio, that is the PT over INR ratio, the apparent reduction of many liver-derived coagulation factors, for example, factor 2, factor 5, 7, 9, 10, and 11, and decrease in the platelet count, all of which lead to a perceived hypocoagulable state. Furthermore, it is becoming increasingly clear that patients with liver disease have hypercoagulable components in their homeostasis status, increase in the von Willebrand factor, factor 8, and decrease in the anticoagulant proteins. Until now, treatment has consisted of low molecular weight heparin and vitamin K antagonists. According to the preliminary data, novel non-vitamin K antagonist oral anticoagulant can be used safely in patients with liver cirrhosis. Pathogenesis. Given the liver's critical role in the coagulation process, liver disease results in a wide range of hemostasis issues, including quantitative and qualitative platelet abnormalities, reduced yield of coagulation and inhibitor factors, formulation of abnormal clotting factors, decreased removal of activated factors by the reticuloendothelial system, and hyperfibrinolysis. So both acute and chronic liver disease, liver damage can have a considerable impact on the synthesis of the pro and anticoagulant proteins as well as the platelets. So this diagram shows how the factors contributing to the clotting and how the factors contributing to the bleeding in the liver functions. So the factor that promotes clotting are the increase in the amount of von Willebrand factors and decrease in the plasminogen factor and protein C and antithrombin, and also increase in the factor 8. The factors which promotes bleeding include thrombocytopenia or platelet function defects, decrease hepatic clotting factors, and increase TPA, decrease inhibitors of fibrinolysis. So pro-hemostatic and anti-hemostatic drivers in the different phases of homeostasis in chronic liver disease patients, and which can cause cirrhosis, like defects in the primary homeostasis in the liver disease can happen, defects in the secondary homeostasis in the liver disease. And in the secondary homeostasis, there are 3 different factors that can contribute. These are defects in the procoagulant pathway, defects in the anticoagulant pathway, and disorders of the fibrinolytic system. Now the next diagram shows how the homeostasis phase actually causes the different pathways to contribute to the liver cirrhosis. As we have discussed so far, that the primary homeostasis also contribute to the cirrhosis, and the factors which include are the pro-homeostasis driver and anti-homeostasis driver. So its diagram shows that how primary homeostasis, in which the pro-homeostasis driver, that is high von Willebrand factors and a low Adams TS13, and the anti-homeostatic drivers, in which the low platelet count can contribute to the cirrhosis of the livers. So the second, if we can see that in secondary homeostasis pathway, the blood coagulation factors, in which the pro-homeostasis drivers, which are the low anticoagulant factors and low antithrombin protein C, and high procoagulant factor 8. Whereas in anti-homocysteine drives, we can see that the low procoagulant factors and fibrinogen and factor 2, 5, 7, 9, 10, and 11 can contribute to the liver cirrhosis. Whereas if we can see that the fibrinolysis pathway, there are also pro-homeostatic drivers and anti-homostatic drivers. In pro-homeostatic drivers, low plasminogen and high PAI content can cause the cirrhosis, and the high there is an anti-homocysteine drivers, high TPA and low TAFI and the low plasmin inhibitors can contribute. Next, clinical manifestations. For many decades, bleeding was considered a major clinical issue, whereas inadequate clotting is now recognized and associated with alteration in the homocysteine balance. Bleeding can be broadly classified into the two types: portal pressure-driven bleeding with little relevance to the homocysteine pathway, and the second is the mucosal or laceration wound bleeding with the constituents of the premature clot dissolutions or hyperfibrinolysis, referred to an accelerated intravascular coagulation and fibrinolysis in the liver disease. Observational studies in the general population have found that the patients with the liver disease have higher risk of VTE than patients who do not have liver disease. So, however, portal venous thrombosis is the most common thrombotic complication, and its prevalence varies widely. In compensated disease, it ranges between 0.6 and 5%, but in advanced disease, it can reach up to 20 to 25%. So this table shows studies related to the incidence of the thrombotic events in the cirrhotic patients. So these are all those 4 studies that I have included in the article, in which the Wu et al. Shows that this study, the population subjects are the discharged patient with cirrhosis, and this study showed that the venous thromboembolism was associated with increased mortality in patients with cirrhosis. And cirrhotic patients with age less than 45 years are at high risk of venous thromboembolism than those without liver disease, and venous thromboembolism prophylaxis should be considered. Whereas the Sogart et al. Study include patients with liver disease with no underlying cause of the venous thromboembolism, which concluded that patients with liver disease have an increased risk of venous thromboembolism, and the risk of the deep vein thrombosis was higher than the pulmonary embolism. And the study, Goulet et al. Shows hospitalized patients with cirrhosis, and it concluded that the both incidents of the deep vein thrombosis and pulmonary embolism and comorbidity were higher in cirrhotics patients. And partial thromboplastin time and serum albumin were independent predictor of the deep vein thrombosis and pulmonary embolism in cirrhotics. Notably et al. Study have recruited hospitalized patients with cirrhosis and have concluded that approximately 0.5% of the admission of the cirrhotic patients results in a new thrombotic events, and the low serum albumin was a strong predictor of increased risk of VTI, venous thromboembolism, independent of the INR. So, invested parameters parameters includes that the in clinical setting, reliance on the conventional coagulation tests such as the prothrombin time, INR, and activated partial thromboplastin time is routine to assess bleeding risk. The other risk of conventional laboratory investigations is platelet count and fibrinogen level. Fibrinogen level have emerged recently as potentially more appropriate than INR as an indicator of bleeding risk when combined with platelet levels. Alternative coagulation tests such as the vasoelastic test and thrombin generation assay in cirrhosis have been described as potentially more accurate, and the whole blood test including thromboelastography, rotational thromboelastometry, which is Coalesce and sonoriometry, are referred to as vasoelastic tests, and they can be an excellent way to imitate the in vivo studies of the homeostasis pathway. Ultrasound can diagnose the development of portal hypertension by assessing portal vein diameter, flow velocity, ascites, and splenomegaly. And the multi-phase CT scan is an important option for diagnosis, portal vein thrombosis during cirrhosis diagnosis, and the ultrasound can identify thrombus in the portal vein tract and intrahepatic branches. CT allows for a more accurate assessment of the superior mesenteric vein, the existence of portosystemic shunts, renal vein, and then fear of vena cava, as well as the degree of thrombus. MRI with contrast like CT help reveal portal venous system flow and thrombus. So now the prevention and the management of the bleeding in cirrhosis. As we know that the platelet transfusion is recommended during bleeding events or prior to invasive procedures, example given liver biopsy, when platelet counts are less than 50,000. Giannini et al. Recorded invasive procedures and incidents of procedure-related bleeding among 121 patients and noted that bleeding and I noted that the bleeding related to the invasive procedures occurs most frequently in patients with severe thrombocytopenia, whereas significant coagulopathy does not seem to be associated with bleeding. TPO binding site agonists are regarded as possible alternative option to platelet transfusion. After et al. Reported that as compared with the placebo, the administration of Trembobag and oral TPO receptor agonist for 14 days in patients with cirrhosis and thrombocytopenia increased the platelet count and reduced the need for the platelet transfusion, but also associated with an increased risk of portal venous thrombosis. Antifibrinolytic have been shown to decrease blood component consumptions after liver transport, and given their relative safety, they may be useful in a preventive setting. Theoretically, prophylactic coagulation correction with the low volume products such as prothrombin complex concentrate outperforms plasma administration. When blood loss occurs, determining the most beneficial pre-homeostasis therapy can be challenging because bleeding can be caused by any of the homeostasis system failing. Thromboelastography may help determine which factors need to be corrected. Now, prevention and management of thrombosis in cirrhosis. Venous thromboembolism in cirrhosis is a growing clinical problem, demonstrating once again that patients with liver cirrhosis are not naturally protected from thrombotic events. Prophylactic anticoagulation is well established and suggested in guidelines for general population of inpatients. The most commonly used agents are heparin, unfractionated heparin, low molecular weight heparin, and fondaparinux, and vitamin K antagonists such as warfarin. The most widely investigated therapeutic in cirrhotic patients are low molecular weight heparin and vitamin K antagonists. Direct-acting oral anticoagulants that directly inhibit factor Xa, apixaban, evaroxaban, and edoxaban, or factor IIa dabigatran are increasingly being used in patients for a wide range of conditions. Low molecular weight heparin and enoxaparin, for example, inhibits factor Xa by binding to antithrombin. Its advantage in cirrhotic patients include documented safety and efficacy and the possibility to use it in an outpatient clinic without routine testing. As a result of the low financial implications and the more desirable oral methods of delivery, clinicians commonly select vitamin K antagonists for the long-term treatment. Vitamin K dependent procoagulant protein 2, 7, 9, and then along with the anticoagulant protein C and S are all inhibited by vitamin K anticoagulants. Vitamin K anticoagulants has several benefits including minimal cost, ease of administration, and capability to counter the effects with vitamin K and exogenous coagulation factor replacement. On the other hand, vitamin K anticoagulants require regular monitoring and adjustment with an INR as well as a diet compliance and have a very limited therapeutic window. Direct oral coagulates are gaining popularity as a treatment and prophylaxis for the thrombosis. Direct factor Xa inhibitors, apixaban, rivaroxaban, and endotoxaban, and direct factor 2A inhibitors, dabigatran, are available in the United States. Dual oral anticoagulants are not recommended in decompensated cirrhosis. The advantages of the is like compared to the conventional therapy are its ease of administration without monitoring, which is desired by the patients and the clinicians, and its a disadvantage include high cost, limited safety data in cirrhotic patients, and the perceived lack of reversal agents. There are several management options for patients with portal vein thrombosis, including anticoagulation, transjugular intrahepatic portosystem extensions, and endovascular procedures with fibrinolysis. This study shows the summaries of studies and the use of the anticoagulation for the portal vein thrombosis in cirrhosis. In the first study, Wing et al. Have recruited cirrhotic patients with portal vein thrombosis who underwent TIPS placement, in which 31 patients are treated with anticoagulant, and they are control, and 33 are untreated. And the duration of anticoagulant use was 12 months, and the warfarin was given, which shows the bleeding outcome in which 3 gastrointestinal varices, and those which are not treated include the 2 gastrointestinal varices. Whereas Chen et al. Study have shown that the cirrhotic patients with non-malignant portal vein thrombosis, which included 30 treated with warfarin, and have 7.6 months of anticoagulation follow-up, whereas 36 patients were untreated and thus used as a control. And this study shows that for homeostasis melina patients and 1 epistaxis and 3 gingival bleeding outcomes. Whereas the study showed by the Hung et al., in which cirrhotic patients with non-malignant portal vein thrombosis are recruited, in which the 14 were treated with warfarin with 3.7 duration of anticoagulation months, and 14 were treated as a control patients, and it resulted in no case of bleeding outcome, both in case of treated and untreated cirrhotic patients. Whereas in the study, Senzolo et al. Have recruited cirrhotic patients with non-malignant portal vein thrombosis, in which 35 patients treated with low molecular weight heparin and follow up for the 6 months, whereas 21 patients are untreated. And the outcome of this study show that the patients who are treated with the molecular warfarin have 1 variceal and 1 subarachnoid hemorrhage, whereas those who are not treated show that the 1 cerebral and 1 epistaxis, and 1 patient with the hemorrhagia and 1 patient with the variceal bleeding. So the conclusion of the study is that the cirrhosis is a medical entity associated with a high risk of systemic thromboembolism and bleeding, and patients may present with both bleeding and thrombosis, and treating such patients is a complex clinical challenge. Treatment options for the majority of the patients with cirrhosis and venous thromboembolism include heparin, vitamin K antagonists such as warfarin, and dual oral anticoagulants. Anticoagulants are the most effective in portal vein thrombosis prophylaxis and management. Platelet transfusion, anti-P receptor agonists, and antifibrinolytics are beneficial in bleeding complications of cirrhosis. And the link between the cirrhosis and the coagulations requires further deep insight research studies to develop a more structured and direct approach to diagnosing, managing, and preventing these conditions. However, up till now, the role of anticoagulants seems integral in the prevention and the management of the venous thromboembolism in cirrhosis. Thank you.
Thank you, Dr. Rabia, for your presentation. So anyone having any questions? No questions then. Thank you once again for your presence and presentation.
Thank you.
Thank you. So our next presenter is Dr. Ahmed Sadiq from University of Huddersfield, UK. Hello, Dr. Ahmed.
Yeah, hi, good evening.
Yeah, hi. So you are the presenter now. Please share your screen with us.
Sure.
Yes.
So can you see my screen now?
Not yet. Yeah, now it's visible. You can make it a full screen.
Sure. Okay. So thank you very much for the presenters for the previous presentation. They were very informative. My name is Ahmed Sadiq. I work as a clinical pharmacist in Sheikh Shakhbout Medical City in partnership with Mayo Clinic in Abu Dhabi City in the United Arab Emirates. I'm also a PhD candidate at Huddersfield University in the UK. So my presentation is going to be about one publication. It discusses the impact of MDT escalating approach on antibiotic stewardship in hospitals. So this is the paper. You can explore it. It has been published in the MDPI journal. It is one of the Q1 journals in antibiotics and with an impact factor of 5.2. So an overview. So this is a well-known information that inappropriate antibiotic use will lead to antimicrobial resistance, and this will lead to increase in days of antimicrobial therapy, increase in length of hospital stay, increase morbidity, and increase in cost. This is in parallel with the lack of synthesis of new antibiotics. That's why we need to protect our antibiotics. So in order to combat antimicrobial resistance and improve clinical outcomes, antimicrobial stewardship programs have emerged as a part of the solution. So the study concept is that appropriate implementation of antimicrobial stewardship program plus the involvement of multidisciplinary team, and this includes physicians, pharmacists, nurses, and microbiologists, will function to monitor and record all aspects of antibiotics utilization with a primary focus on antibiotic use, clinical parameters, resistance, and cost. So the study objective. So we plan to use a comprehensive escalating approach in order to evaluate the impact of the antimicrobial stewardship multidisciplinary team intervention. So as I said, the multidisciplinary team composed of clinical pharmacists, physicians, nurses, and microbiologists on clinical, microbiological, and other relevant measured outcomes among hospitalized patients. So the study was conducted in the inpatient settings rather than the outpatient setting. This study will also highlight the clinical pharmacist role as a part of the antimicrobial stewardship multidisciplinary team. So let's go to the methodology. So the clinical setting, what the hospital we are working in, which is Sheikh Medical City, it's a 74-bed governmental tertiary hospital in Abu Dhabi. It is the biggest or the third biggest hospital in the Middle East. Inclusion criteria. So we decided to include adult patients admitted in medical ICU and birth unit, and those patients should be on antibiotic therapy either for treatment or prophylaxis. We excluded patients who are below 18 years old, hospitalized patients without antibiotic prescriptions, and COVID patients were also excluded from the study. So what was the intervention in our study? So patients who received antibiotics were reviewed by the antimicrobial stewardship multidisciplinary team. This multidisciplinary team consisted of ID physician, an ID clinical pharmacist, and ward clinical pharmacist. So here, the novel intervention was the escalating approach. So what is that escalating approach? First, the ward clinical pharmacist reviewed all adult patients receiving antibiotics. the clinical pharmacist either discussed the intervention with the ward physician, or if he couldn't take the decision, he escalated it to an ID clinical pharmacist. The ID clinical pharmacist will review those prescriptions that have been raised by a clinical pharmacist. If the outcome of this patient case was still undecided, then those remaining cases would be escalated to the ID physicians, who will receive the undecided cases for the final decision. Some complicated cases have been directly reviewed by the ID physicians for their recommendation. So here we use this escalating approach, so we are ensuring that all patients who are on antibiotics are being reviewed, and to use and distribute the resources in an effective way, all clinical pharmacists should review all the patient and decide on the appropriate treatment, and decide if the treatment that the patient is currently receiving is appropriate or not. If they couldn't take the decision, they will escalate to the ID clinical pharmacist and he will do his review. If there no decision was taken, then the ID physician will be the final stop. So what are the recommendations that have been provided during the intervention? So there was a standard checklist tool of the antimicrobial stewardship MDT recommendations, which represent the ASP intervention that was created in electronic patient profile. So this checklist was created in each patient's electronic profile. So once the clinical pharmacist, ID clinical pharmacist, or ID physician reviews the patient, he can use this checklist tool and put his intervention. Recommendations uploaded in this tool were prepared and agreed upon by a group of healthcare experts comprising senior clinical pharmacists and consultant physicians. So those are the healthcare professionals who have prepared this checklist to be used by all the clinical pharmacists. Using this ASP intervention electronic tool, the clinical pharmacists documented the intervention that have been performed. So those are the recommendations. We have a lot of recommendations like antibiotic change, escalation, de-escalation, discontinuing therapy, dose or duration change, dosage form change like from IV to oral or opposite, a frequency change, therapeutic drug monitoring like what we do with vancomycin or with aminoglycoside, or sometimes the therapy is appropriate so that the intervention will be, or the documentation will be, no change to current care. So the outcome of the study were length of hospital stay, days of antibiotic treatment, readmission and mortality within 30 days, all-cause readmission rate for the patient with pneumonia and UTI within 30 days, IV to oral antibiotics, therapy cost, MRSA and MDR bloodstream infection, adjusted per 100 patient days, and antibiotic consumption expressed as defined daily dose adjusted per 100 patient days. So the results. We had a total of 3,000 patients. In the non-intervention group, we had 1,660 patients distributed among medicine, ICU, and benzonet. And we have the intervention group, which consisted of 1,340 patients. So we have compared the patients' characteristic between the two groups. So we compare the mean age, gender, and Charlson score. Charlson score is the score that used to evaluate the comorbidities of the patients. Then we did the unadjusted regression analysis on 4 outcomes. Those 4 outcomes were LOS, DOT, readmission, and mortality. I mean by LOS, length of hospital stay, and DOT, days of antibiotic therapy. So in the unadjusted regression analysis, we can see that all outcomes achieved a significant improvement except the days of therapy. The days of therapy was insignificant in the medical, ICU, bans, and all of those in it combined. So we decided to do the multiple variate analysis, regression analysis, in order to adjust for the confounders that may be present between both groups. Maybe we can get a significant result. So here we did the multiple regression analysis. We adjust for age, gender, and Charlson score, and still the DOT was insignificant. So that means we achieved significant improvement by using our intervention in length of hospital stay, readmission, and mortality. Those are the number of recommendations that have been used in the non-intervention and in the intervention groups. One of the outcomes also, so we discussed 4 clinical outcomes. Then the 5th outcome was the defined daily dose, which represents the antibiotic consumption adjusted per 100 patient days. So per antibiotic, we can see on the left the non-intervention period, and the right we can see the intervention period. I will just highlight 3 or 4 antibiotics. So we can see that piperacillin tazobactam increased in the intervention period. However, antibiotics or broad spectrum antibiotics like meropenem, ertapenem have been reduced in the post-intervention group, and that indicates the success of our intervention. For the microbiological outcomes, we didn't have much cases, and that's why we didn't conduct a statistical analysis. So you can see here, like for example, a 30-day all-cause readmission rate for patients with pneumonia. There were only 17 in the intervention and 14 in the intervention period. Or the rate of MRSA plus stream infection, we had 8 in the pre-intervention and 5 in post-intervention. So the cases were few. We did not conduct a statistical analysis because those numbers are not qualifying for that type of analysis. So, discussion. Our study demonstrated a comprehensive approach to improve and optimize antibiotic use in hospitals. This approach used a multidisciplinary team of ID physicians, ID clinical pharmacists, and board clinical pharmacists. The NDT, which represents the Hospital Antimicrobial Stewardship Program, used an escalating approach by reviewing all adult patients admitted to the medical, ICU, and burns unit and are on antibiotic therapy. LOS, as we have seen, it decreased significantly in the intervention period when adjusted by age, gender, and Charlson score. This reduction might have been driven by the IV to oral antibiotic switch intervention, which allowed patients to complete their course of antibiotics at home instead of staying at hospital. And of course, appropriate choice of antibiotics may result in a quicker symptom resolution and therefore lowered LOS. Days of therapy. So although there was a reduction in days of therapy in the medical setting, as we have seen, even after we have did the multiple regression analysis, this reduction was not statistically significant. So this insignificant change is proposed to be driven by ID physicians' encouragement to the attending primary teams to use shorter duration of the antibiotic even during the non-intervention period. So that was already encouraged during the intervention period, and that's why maybe we have not seen any change. For the 30-day readmission, we can see that 30-day readmission have been decreased significantly. So 30-day readmission for any cause, not only for pneumonia or for infectious disease, for any cause, have been decreased significantly in the intervention group, in the medical setting, and overall setting. Overall settings means medicine, ICU, and burns unit. Mortality decreased significantly in the intervention group, in the medical setting only, and the overall setting. So mortality has not decreased in ICU and has not decreased in the burns unit. For the defined daily dose, the highest increase was for piperacillin tazobactam. It increased during the intervention period despite the reduction in coamoxiclav, and also we have seen that there was a reduction also in meropenem and ertapenem. There are some limitations in our study. First, there was no limitation. No randomization. And that was because we decided to include all the patients who are on antibiotics to make sure that all these patients will get the benefit of the intervention. There was no control for potential variation in factors like social behavior, climate, food, water consumption during study periods, and we were unable to accurately obtain the severity of infections from patients' electronic health records. So what is the implication of practice of our study? So the findings highlighted the role of the clinical pharmacist as an active member in the multidisciplinary team, participating effectively in improving antibiotic use. Our approach allowed the review of all patients admitted into the wards who were on antibiotics. The multidisciplinary team involvement allowed speed in getting the right answer by physicians and acceptance of advice by the clinical team to translate it into action. There is a big potential for cost saving by reduction of the use of highly expensive antibiotics, shortening LOS and days of therapy, and lowering readmissions and mortality. Thank you very much. I would be happy to get some questions if you have about the study. Okay, so it looks like there are
Thank you,
no
Dr. Ahmed,
questions.
for your presentation. So anyone having any questions? I think no questions. Thank you once again for your presence and presentation.
Thank you, Simon.
Yes. So as our next presenter has not yet joined the program, so we'll go to the another one from Dr. Alan H. Gaboyan from Armenia. Hello, Dr. Alan.
Hello.
Yeah, hi. So I'm going to make you the presenter.
Yes, please.
Yes. So please share your screen with us.
Okay. Let me know when you can see my screen.
Sure. Yes, now it is visible. You can start.
Okay. So I would like to introduce our study by a method to control outbreaks of foodborne infectious diseases. So a bit of background. Foodborne illness, commonly known as food poisoning, is often caused by consuming food contaminated by bacteria or their toxins, parasites, viruses, chemicals. While the American supply food is among the safest in the world, the federal government estimates that there are about 48 million cases of foodborne illness each year. This estimate is equivalent to 1 to 6 Americans becoming sick from contaminated food, which results in an estimated 128,000 hospitalizations and 3,000 deaths. Microorganisms causing foodborne diseases mainly belong to Escherichia, Salmonella, and Listeria species. There is no any universal antibiotic can be used for control of all possible types of pathogens. The antimicrobials demonstrating wide spectrum of antimicrobial action are antiseptics such as hydrogen peroxide, iodine, etc. Hydrogen peroxide is more preferable as it is naturally existing in human organism. Some kind of lactic acid bacteria can produce hydrogen peroxide in different conditions and eliminate the pathogens from food. Lactic acid bacteria, and furthermore, I will say them lab, produce a wide range of inhibitory compounds such as organic acids, hydrogen peroxide, bacteriocins, and thus expanding shelf life and decreasing food safety, and have been generally recognized as safe, and they have this GRAS status. The inhibitory action of lab toward foodborne pathogens and spoilage organisms in non-processed foods occur during entire storage period by continuous production of inhibitory compounds. instead of a one-time reduction as it occurs with antimicrobial interventions. Among known lactobacilli, Lactobacillus delbrueckii subspecies lactis produces the most amount of H2O2 at low temperatures and is most used for food preservation. The hydrogen peroxide production varies from strain to strain. Therefore, the selection of lactobacilli with a high hydrogen peroxide producing activity is becoming increasingly important. So, therefore, our goal was to increase hydrogen peroxide production activity of delbrueckii by use of pleiotropic reef mutations and the effectiveness of the mutants against foodborne pathogens. The experiment showed that the NG mutagenesis increased the frequency and the diversity of the pleiotropic reef mutations, which in turn increased the yield of hydrogen peroxide. It was revealed that the frequency of occurrence of active producers among reef mutants was about 5 times higher than among cultures sensitive to rifampicin. The activity of selected reef mutants was examined and confirmed also by agar disk diffusion method, as you can see in the figure. Relatively larger inhibitory zones like this or this one on the lawn of pathogen E. coli around the disc soaked in culture liquids of active reef mutants indicate high antibacterial activity of the mutants compared to the parental strain in the center. To study the growth behavior of delbrueckii reef mutants, the growth medium was inoculated with overnight reef cultures and incubated at 37 degrees Celsius under anaerobic and aerobic conditions. Bio and hydrogen peroxide accumulation was assessed every 30 minutes. And as you can see from the figure, aerated cultures enter the stationary phase significantly earlier than the anaerobic ones. Aerobic cultures release hydrogen peroxide into the environment, which leads to premature growth inhibition, which occurs at different times of growth, depending on the rate of hydrogen peroxide accumulation. As compared to the parental strain, which is this one in the middle, all reef mutants, except of reef 3, eventually with approximately the same amount of H2O2. Okay, like this, hydrogen peroxide, but by 20 to 50% lower biomass as a result of an earlier transition to the stationary phase. When we go back to the other slide, we see it earlier, and that is because of the high hydrogen peroxide accumulation. When the level of hydrogen peroxide reaches to approximately 60 milligram per liter, the growth and thus the synthesis of hydrogen peroxide gradually cease. Due to autoinhibition, the maximum level of hydrogen peroxide accumulation in all cultures was approximately the same. But in mid-logarithmic phase, the comparison of H2O2 concentration revealed significant differences between mutants as well as the parental strain. The reef mutants produced from 30 to 50% more hydrogen peroxide than the wild strain. Since lactobacilli are widely used for food preservation at refrigeration temperature, the behavior of delbrueckii mutants at 5 degrees was studied. I can say that in the most of the production of hydrogen peroxide by labs was examined in phosphate buffer, but the formation of hydrogen peroxide must also be studied in complex media since food, especially raw meat, is rich in nutrients. That's why we examined Delbrueckii mutants under cold conditions in complex medium, in rich medium. For that, harvested Delbrueckii cells were inoculated into fresh labbed medium and incubated at 5 degrees. The rate of accumulation of hydrogen peroxide determined for 5 days is shown in this figure. The accumulation of hydrogen peroxide by wild and mutant strains gradually increased and reached to its maximum on 4th day and remained stable for at least 10 days of cold incubation. During the entire period of cold exposure of the Earth, despite the active production of H2O2, no significant changes in the pH and in the live cell population was observed. With the same biomass, without the growth of reef mutants, have produced significantly more hydrogen peroxide in the medium than the wild strain, as you can see. Despite the high amount of extracellular hydrogen peroxide accumulated in the cold, it does not lead to death of the host. The phenomenon of lab to produce hydrogen peroxide at refrigeration without growing allows them to accumulate enough amount of hydrogen peroxide, avoiding autoinhibition. It was first shown that Lactobacillus delbrueckii can synthesize hydrogen peroxide in a complex medium at 5 degrees. Then the antagonistic effect of active reef mutant, REF4, against the pathogen E. coli was determined at 5 degrees at co-cultivation at ratios 10 to 1, 100 to 1, and 1000 to 1, respectively. Data of E. coli survival determined on McConkey agar are shown in the figure, and as it can be seen from the figure, there is a direct relationship between the number of lactobacilli, between the ratio, I mean, and the death of pathogen. The optimal ratio of lactic acid bacteria to pathogen is most likely in range between 1000 to 1 and 100 to 1. On the first day of co-cultivation, when the H2O2 concentration had not yet reached to the minimal inhibitory concentration of Escherichia coli, a significant decrease in coli cell count was observed depending of lactobacilli concentration. According to our earlier data, death at sub-inhibitory concentrations of hydrogen peroxide can be caused by Delbrueckii co-aggregation with the pathogen and direct release of hydrogen peroxide on it. Experiments revealed around 39% level of co-aggregation between Delbrueckii and coli. And regarding ratio, at a ratio of 1000 to 1, REF4, the mutant, practically eliminated the pathogen within 4 days of co-cultivation. At a ratio of 100 to 1, complete elimination occurred on 6th day, which is not far behind the result from 1000 to 1, whereas at a ratio of 10 to 1, the E. coli population decreased only in small amount. So the optimal ratio we recommend between 1000. Then, for conclusion, in our study, it was shown that by use of reef mutation, it is possible to increase the yield of hydrogen peroxide. It was shown that inhibition of pathogens by sub-inhibitory or sub-MIC doses hydrogen peroxide may arise due to the coaggregation and direct release of hydrogen peroxide onto the target cell. The proposed method by use of pleiotropic reef mutants enable to fully eliminate the foodborne pathogen from food independently of storage conditions. Unlike other preservation methods, the biomethod works safe and permanently. The active producers can produce higher amount of hydrogen peroxide with a smaller biomass, and therefore they do not affect the sensory characteristics of food. That is all from me. Thank you. Do you have any questions?
Thank you, Dr. Allen, for your presentation. So, any questions from anyone? So, no questions. Thank you once again for your presence and presentation.
Thank you too.
Thank you. So, our next presenter is Dr. Krisa Vaisaki from University of West Attica, Greece. Hello, Dr. Krisa.
Good evening.
Yeah, hi. So, you are the presenter now.
Um,
Please share your screen.
uh,
Is it a MacBook?
do you see?
Yes.
Okay.
Yeah. Please open your
Yes.
presentation.
How did you
Yes.
did you
Yes.
see?
Please make
Okay.
it a full screen and start presenting.
Full screen. Okay.
Yes.
Now?
No, not yet.
Not yet.
Yes.
Yes.
No. It's yes. Now it is okay. Please continue.
Okay. Okay. Hello. My name is Hrisa Voyadjaki, and my presentation is about attitudes, sexual behaviors, and prevention measures of sexually transmitted diseases in young adults in Greece. As you know, sexually transmitted diseases, STDs, are associated with exposure to pathogenic microorganisms and are transmitted during sexual intercourse. Nowadays, STDs demonstrate an increased prevalence mainly in young adults and are a significant burden on public health worldwide. Sexually transmitted diseases are a major global health problem with more than 340 million new cases occurring every year worldwide. Although STDs are present in individuals of various age groups, they most frequently affect young adults since they represent not homogeneous populations with regard to their social needs and sexual behavior and are associated with various biological and social factors around transitioning from adolescence to adulthood. Specifically, the premature initiation of sexual activity, the number of sexual partners, the need of self-assurance, the access to health care services, the financial status, and education and occupation profiles are all factors associated with the increased frequency of STD infection in young individuals. Teenagers are more prone to have relationships with multiple sexual partners, which in turn increase the possibility of STD infection. It has been suggested that young people do not possess sufficient knowledge regarding ST3 infections, and that their education and knowledge level are the main contributing factors affecting the incidence of infection. The overall aim of the present study was to assess the knowledge level of a great population of young adults regarding first the risk of STD infection, the attitudes, sexual behaviors, and ways of prevention of STD infection. Also, information regarding the sexual behavior associated risk was gathered from the participants. For the present study, we created an anonymous questionnaire of 35 questions, which was posted on Microsoft Office forms and social media. The study involved 1833 people aged 18 to 30 who met the inclusion criteria in order to ensure the reliability of the results. For the analysis, we used the statistical package SPSS V21.00. Inclusion criteria were used: written consent for participation in the study, data analysis, and publication of the results. Second, participants must be 18 years or older, and the third must be sexually active. The results of the study are the following. As you can see, with yellow and gray color in the pie, do you see my mouse? I don't know. The majority of the participants believe that they have a medium to high level of knowledge about STDs. Despite that, approximately 94% of them are still interested in a high degree to learn more about STDs. Here. Following this high interest, the main source of information about STDs seems to be the easily accessible internet by 42%, education by 30.5%, and then follows the family doctor 18.8%, the family, and last, the press. Here you can see the answers of the participants on condom use during the sexual intercourse. 50 here, the price is absent, but is 52 of the participants didn't see a condom because didn't use a condom because they were in a stable relationship, while now 30 here, 39% believed that their partner didn't have an STD. Both these cases show that trust between partners is the main reason for not using a condom. Furthermore, only 31% of the study populations stated that they always use a condom during sex. Here. Next, when they were asked about testing for STDs, surprisingly, half of the participants, as you can see here, 49%, blue color, have never been tested for STDs. Only 23% of them gets tested regularly with blood exams, and a small portion of the study population is tested after risky behavior or suspected exposure to STDs. The most common STD the participants have been diagnosed with is HPV, human papilloma virus, by 46.7%, followed by herpes simplex virus HSV with 9.8%. Additionally, fungal infections, Molluscum contagiosum, and chlamydia are also present in some participants, as you can see here in the pie. Okay, you see these the main STDs that participants state that are affected. It is very important to say that the mean age of diagnosis with one of these STDs was 21 years old. Regarding vaccination against HPV, 36.7% of the participants have been vaccinated. Although HPV is the most common STD in the participants with a positive record, a great percentage of them, 32.4%, is not even aware of a HPV vaccine. You can see that in red, bold red color here. Also, 7.3% are planning to be vaccinated soon. Last but not least, as you can see in the last two bars, some of the participants are afraid of side effects or they don't trust vaccinations. Assessing partner communication about STDs, we found that most of the participants are interested to know if their partner has an STD. In fact, a total of 77% ask their partners if they have an STD. You can see also that a significant percentage of 17% here at the bottom is afraid to ask because of fear of rejection. Regarding alcohol or drug consumption before sex, 49.1% shown here with brown color in the pie, reported occasional consumption before sex, and 45.4% shown with green color never consume alcohol or drugs before sex. Also, you can see with yellow color in the second pie here, the majority of the participants have never been intercourse with a sex worker. To sum up, in this study, we show that half of the participants have never been tested for STDs. HPV is the most common STD. HPV, is the most common STD among the participants, 47%. 32% of the participants are not informed about the HPV vaccine. 94% of the participants are interested in additional information about STDs. 42 of the respondents used the internet as main source of information. More than half of the participants didn't use condoms because they were in stable relationship. 31 of the participants reported that they have always have protected sexual intercourse using a condom. Last but not least, 49 of the participants reported occasional consumption of alcohol and drugs before sex. It has been reported that health education programming for youth in Greek school is imperative to promote healthy lifestyles and to prevent chronic and infectious diseases. Moreover, national programs can be implemented to increase the education of young individuals on STDs. It is important to know that recently the Ministry of Education has declared compulsory training on sexual education at schools in Greece. Effective dissemination of relevant scientific knowledge is also required, as well as modification of incorrect beliefs and concepts regarding STDs that are present in the vast majority of the young population. It is important to focus on promoting the sexual education of young adults and adolescents worldwide. Counseling, education, and information are significant prevention measures to be used against the spread of sexually transmitted diseases. Moreover, relevant research studies must focus on the evaluation of the effectiveness of sex education and its social impact on the affected population. By combining the aforementioned measures, a more complete level of sex education can be accomplished, leading to the prevention of relevant health and social problems. Thank you for your attention.
Thank you, Dr. Krisa, for your presentation. So anyone having any questions?
I'm last but not least.
No.
Yes.
Yes. So I think no questions then. Thank you once again for your presence and presentation.
Thank you. Thank you.
Yes. So actually we are left with one presentation from Dr. Bozan, but we tried to contact him with several ways. He's not getting contacted and he's not replying to our emails or calls also. So by this, we have to wind up our webinar for today. Thank you all for making this a successful one. Have a
Thank
nice
you.
day. Yeah, meet you in the next conference.
Okay.
Yeah, I'm sorry. I have one video presentation also,
Mhm.
which we will play right now um, by sharing our screen. Yes, Simon Peter will share the screen now. Yes, the voice is not audible. Can you please unmute yourself?
Article about COVID-19 and natural killer cells. Alright, to begin, we will have a brief overview on COVID-19 and natural killer cells. COVID-19 is a viral disease and its causative agent is SARS-CoV-2, which is a member of coronavirus family. The disease has begun in China and later spread all over the world, and the WHO called it a pandemic. As you already know, some epidemics by other members of this family have been reported before, but the higher transmission ratio of COVID-19 is one of the main differences between these diseases. The incubation period of the diseases range from 2 to 14 days, and most of the infected people are asymptomatic, although they can spread the disease. And here there is a table showing some of the symptoms of COVID-19, which some of them like fever, fatigue, and are common among patients, while others such as dyspnea and pneumonia are most seen in severe cases. And also here, there are some factors like interleukin-1, 6, 8, GM-CSF that are increased after incident with COVID-19. Natural killer cells are a group of lymphocytes that belong to the immune system. These cells are derived from hematopoietic stem cells, and there are two classes of NK cells, including CD56 bright that are mostly present in the peripheral blood, and the other one is CD56 dim, which constitute the majority of NK cells in secondary lymphoid tissue. The activation of NK cells depends on the portion of activating and inhibitory receptors on the surface of these cells. And these are some of NK cells activating and inhibitory receptors such as KIR2DL1, KIR2DL23, NKP13, NKP44, NKP46, and NKP80 in the activating group, and also NKG2A, NKG2D, NKG2C, and DNAM1 in the inhibitory group. NK cells know when they have to avoid attacking the host cells by recognizing the HLAs on their surface. As we know, the virus-infected antihuman cells reduce the expression of HLAs to evade the cellular immunity. On the other hand, this leads to the activation of NK cells. Upon being activated, NK cells use three methods to destroy their targets. First is altering them to start apoptosis through fast ligand pathway. Second one is direct destruction through perforin and granzyme, and the third one is recruiting other immune cells by cytokines. It has been observed that patients with impaired production and function of NK cells are more likely to contract viral infections. And now about changes in the NK cell counts of COVID patients. The number of NK cells decreases after being infected with COVID-19, and this decrement is associated with the severity of the disease. Studies show that in comparison with healthy controls, CD56 dim and bright cells are higher and lower respectively. While the NK cells are reduced in the PB, neutrophils are increased, and so the neutrophil to lymphocyte ratio, which is a criterion of inflammation, is escalated. And a similar situation has been observed in the SARS epidemics. In addition, studies indicated that the NK cell count returns normal after being recovered. However, studies on bronchoalveolar lavage samples show different results, and both increase and decrease have been reported. The precise reason for the reduced NK cell count in the PB is not clear yet, but migration or apoptosis of these cells are suggested by the researchers. NK cells use the VLA4 to attach to the VCAM1 and migrate to the lungs, and severe COVID patients express more VCAM1, so it may contribute to the migration of NK cells from the PB to the lungs. Also, the expression of interleukin-12, interleukin-15, and interleukin-21 is decreased in COVID patients. And these cytokines are important in the production and activation of NK cells. In addition, the virus is also presumed to induce apoptosis in the NK cells, but more research is required. NK cells phenotype and function are also affected by COVID-19. These cells constitute 10 to 20% of the lung lymphocytes. Since lungs are extremely sensitive organs, they have developed an anti-inflammatory environment to avoid being harmed by the immune reaction. NK cells in the lungs are not already activated, but the presence of type 1 interferons seems to be crucial to trigger their activation. SARS-CoV-2 impedes the proper expression of these interferons and prevents the activation of NK cells. Also, other lung epithelial cells lack the activated antiviral genes to fight the virus. So it can cause epithelial cells to develop pyroptosis and consequently overcalling the immune cells to the lungs because of the tremendous release of inflammatory cytokines and chemokines. The NKG2A is an inhibitory receptor often expressed on the surface of T cells and NK cells. In NK cells, this receptor is responsible for maintaining tolerance and preventing host cells damage. This receptor is also a sign of NK cells exhaustion due to chronic infections. SARS-CoV-2 uses this receptor as a way to escape from the immune system. In samples taken from COVID patients, it has been observed that the level of this receptor on NK cells is significantly increased, especially in severe patients, and cytokines such as interleukin-6 and 10, which are increased in patients, are responsible for this. The interleukin-6 lessens the perforin and granzyme B expression, and interleukin-10 is negatively correlated with NK cell cytotoxicity by reducing interleukin-2 and interferon gamma. And noteworthy, this receptor is important in reducing the secretion of interferons, interleukin-2, TNF-alpha, and granzyme B. On the other hand, studies showed no significant change in the expression of NKG2C, which is one of the NK cell activating receptors. Interestingly, NKG2C also uses HLA-E as its ligand, but with a less affinity. So we can conclude that SARS-CoV-2 increases NKG2A and keeps the NKG2C stagnant, and so it causes NK cells to be suppressed. NKG2D is another activating receptor on the surface of NK cells. These receptors ligands are MHC class I chain-related protein A and B, also called MIC-A and B, and unique line 16 or UL16, which are significantly increased on the virus-infected cells. This receptor's expression is reduced in COVID patients, which significantly weakens the immune system's antiviral ability. DNAM1 is another NK cell activating receptor that its ligands are CD155 and CD112. This receptor is essential for the secretion of inflammatory cytokines and cytotoxic properties of NK cells, and the expression of this activating receptor is also decreased in patients with COVID-19. Altogether, it is known that the virus evades the cell activity and spreads through the body by increasing the inhibitory receptors and their ligands, as well as decreasing activating receptors. The other issue that should be noted is the exhaustion of NK cells. Some of the NK cells exhaustion factors have been recognized in COVID patients, but still there's not an reason for that, and so more studies are required. These factors including LAG3, TIM3, PDCD1, and HAVCR2. NK cells also have a significant role in the regulation of the adaptive immune response in different types of viral infections, autoimmune disorders, and transplantation. The ability of NK cells to modulate cellular immune response can be directly mediated through T cell and NK cell interactions by the secretion of cytokines or indirectly through other cells like dendritic cells. According to studies, NKG2D upregulation on NK cells during LCMV infection and accumulation of trail positive NK cells in HPV and MCV resulted in CD4 positive and CD8 positive T cell elimination. Interestingly, besides CD4 and CD8 positive T cells, also regulatory T cells can be depleted by NK cells. Another dark mechanism is NK cells secreted interleukin-10, which has been shown to be produced by NK cells following various infections such as LCMV and MCMV. Interactions between NK cells and APCs can also abate T cell activity. Such negative regulation by limiting the availability of antigen-presenting APCs and reduce stimulatory capacity of APCs has been demonstrated following various infections, which consequently result in increased viral persistence. And here the picture depicts the effects of SARS-CoV-2 on the NK cell properties. And now about COVID vaccines and NK cells. It's expected that vaccination affects the function and differentiation of NK cells. However, few studies have focused on this issue, but we know something from previous findings. Vaccination of rhesus macaques by attenuated SIV-activated NK cells by interleukin-15. The influenza vaccine improved cytokine-induced memory-like NK cells. Influenza vaccination increased the expression of NKG2C, and vaccination against and yellow fever increases the proliferation and the number of CD56 stem and CD56 bright subtypes. But a limited number of studies evaluated the effects of COVID-19 vaccines. But there are some points to say. DNA vaccines induce anti-spike dependent NK cell responses in vaccinated rhesus macaques. The lack of serological response is associated with low levels of NK cells after vaccination of hematological patients with the Pfizer-BioNTech vaccine, and that vaccine increases the NKG2C positive cells at day 0 and anti-SARS-CoV-2 antibody titers on day 35. Some studies also evaluated the effects of adjuvants on the NK cells. Adjuvant system 03 can enhance adaptive immune responses by activating and proliferating NK cells and also increases vaccine immunogenicity by increasing the production of interferon gamma from NK cells. Also, MF59 can increase the effectiveness of the influenza vaccine in the elderly by activating NK cells. But as you see, there are really a few number of studies, so we really need further evaluation. And now it comes to NK cell-based and targeting therapies. As I told before, interleukin-6 can inhibit the effective NK cell response against viral infections. The use of tocilizumab in the treatment of cytokine storm by CAR T cells has been effective, indicates the importance of the inhibitor both to keep NK cells active and to neutralize cytokine storm caused by SARS-CoV-2. Now, clinical trials are underway to evaluate the effects of these inhibitations. Another inflammatory cytokine is TNF-alpha, which can play a role in the severity of the disease. The use of TNF inhibitors has also been suggested as one of the therapeutic approaches in COVID-19. Since TNF-alpha is the byproduct of NK cells and has a role in their effector function, it seems that the use of TNF blockers had adverse effects on them. However, this issue requires extensive studies in the future because TNF-alpha has different roles in COVID-19, and some studies demonstrated that COVID-19 patients receiving anti-TNF had lower probability of hospitalization. Monalizumab is the inhibitor of the NKG2A receptor that has been used to treat different types of malignancies like leukemia, and its positive effects have been proven. NKG2A inhibition may be effective in preventing pathological effects of the immune system. However, complete and detailed studies should be performed on the usage of this medication in COVID patients because this receptor is expressed on the surface of other immune cells like T cells. So its inhibition may be associated with more pathological effects exacerbating the disease. CYNK001 is a group of NK cells derived from umbilical cord stem cells and has a remarkable ability to fight against viral infections. These cells have also been used to treat malignancies such as multiple myeloma and this group of laboratory-produced NK cells has the ability to detect virus-infected cells and eradicate the infection using activating receptors such as NKG2, DNAM, and NCRs. And currently, clinical trials using these cells for patients with COVID-19 are ongoing. But the important point is that the time of using them must be considered because using them in the earlier stages of disease will probably result in better outcomes. Chimeric antigen receptor cells or CAR cells are among the most critical medicine to treat cancers, viral diseases, and even also autoimmune disorders. In these cells, receptors that are generally not present on the cell surface are genetically engineered at the cell surface. Application of CAR T cells showed promising effects against cancer and infections. However, the use of these cells also faces several challenges, including the high cost and the significant risk of cytokine storm. So researchers have begun to produce genetically engineered cells called CAR NK cells, which are less expensive and less likely to cause cytokine storm. Recently, a CAR NK cell encompassing an extracellular domain of ACE2 developed that secretes interleukin-15 to improve its survival and showed promising effects against VSV SARS-CoV-2 chimeric viral particles and the recombinant SARS-CoV-2 spike protein subunit S1 by increasing cytotoxicity as well as TNF-alpha and interferon gamma production. Adaptive NK cell refers to a group of NK cells with memory properties such as high longevity, and high cytotoxicity, and also higher cytokine secretion. These cells are usually developed in response to the CMV infection and cause resistance to reinfection with this virus. This group of NK cells generally express the NKG2 receptor and the maturation marker, CD57 is higher than normal NK cells, and also they secrete more interferons. Studies have shown that the severity of COVID-19 in kidney transplant recipients infected with both SARS-CoV-2 and cytomegalovirus is less than those recipients only infected with COVID. So that indicates the effects of adaptive NK cells on COVID-19. In addition to being naturally developing in the body of CMV-infected people, these cells can be produced in the laboratory using CMV-infected fibroblasts, which can be considered a treatment option for COVID patients. A phenotype investigation study also showed the presence of memory-like CD57 plus NKG2C plus NK cells in the peripheral blood of COVID patients. So it indicates the promising potential of convalescent therapy to treat SARS-CoV-2 infection due to the unique cytotoxicity activity of this subtype that has been shown against different viral infections. And now you can see the clinical trials about the therapeutic usage of NK cells in COVID. And this picture shows a summary of the mentioned therapeutic approaches for the COVID. And eventually, to conclude, some noteworthy points that should be mentioned. In the SARS-CoV-2 infection, the virus hampers proper immune response by impairing NK cells' functionality, leading to an improper response in the initial stages and can even cause cytokine storms in the last stages. Also, the virus causes exhaustion of NK cells by increasing the inhibitory receptor NKG2A, hindering proper production of signaling of interferons. The virus also reduces the number of NK cells in the peripheral blood. All of these are involved in the inadequate immune response at the onset of the disease that causes the virus to spread. Also, due to the exhaustion of NK cells as well as the reduction of activating receptors such as NKG2D, these cells are not able to control hyperactive cells at the end stages of the infection, which causes severe damage to tissue, especially lung tissue. I do really appreciate the time you've given to me, and this is my email for further inquiries.
So this was the last presentation for today's program. By this we came to end of our webinar. Thank you all for making this a successful one and hope to see you on the next conferences. And the certificates will be mailed to you. Kindly check your spam or junk also for the certificates. Thank you and have a nice day.